Over to you, Dr. Yadav. Dr. Yadav,
Yes.
over to you, sir.
Yes. Yes. Dear friends, now we are starting second day of the smoke exam, and the teacher is Dr. Deepak Dubey and Dr. Trivedi, and President are Rohit Kapoor, Dr. S. Reddy Bhatti, Sanjay Kole, and Samrat Patel. They are residents. Please.
Okay.
Thank you, Dr. Dubey.
Thank you. So good morning, everyone. So today we will have a case presentation. So what I'm going to do is I'm going to present the case to you, and I would like one or two of you to be the primary residents who will respond to the questions. So you can volunteer and start off. And then as it'll be more like a examination, proper examination in your exam. So we'll take it like a short case, go by slide to slide, and we'll discuss and ask questions according to each slide and then proceed. Yeah. So can you see the slide? Who's going to be the resident who's going to take up this? Hello?
As per list, it is Dr. Rohit Kapoor, Dr. S. Reddy, Dr. Sagar, and Dr. Patel.
So any of you are there?
Navneet?
Sir, there is a
Sir, Dr. Sir, Dr. Prashant Chauhan and Dr. Praveen Lakhera will be taking.
Okay, okay.
Dr. So is Prashant there?
Yes, sir.
Yeah,
okay, Prashant, so
just introduce yourself.
Sir, I am Dr. Prashant, sir, from INU Bangalore, sir.
Okay.
Okay, Prashant. So Prashant, this is a patient. He is a 35-year-old male patient who has he had a history of a road traffic accident, and this is history about 6 months back. This patient had a history of a road traffic accident. He was admitted to the emergency, diagnosed to have a pelvic fracture, and also noticed to have blood at the meatus. So this is assessed by the emergency doctor, and he has called you to examine the patient and do the needful. So you have come to see the patient. I would like you to briefly tell me how you will quickly assess him and whether you will do any imaging or investigations.
Sir, it is a case of RTA, sir. So first
Yes.
we have to assess his...
So Prashant, don't repeat what has been said. Let us try to be quick. So
Yes,
please, this is what again I would like to emphasize to all of you when you're going for the exam. When you have been told a certain history, you want to utilize maximum time for your advantage. So the more you repeat what has been asked to you, the more you're losing your time. And that doesn't give a very good impression to the examiner. So if you want to ask anything, that is fine, but don't repeat. So go ahead.
Okay. Okay, sir. Sir, we'll assess first his general condition, sir. His GC, sir. If it is not vitally stable,
okay, so I'll tell you this, he's hemodynamically stable and his BP, pulse, everything are okay.
Okay, sir. Then I will ask the RTA.
Hello.
Hello.
Hello, Arun, can you hear me? I'm unable to hear Prashant.
Sir, can I take you?
Yeah, Nripen, you can go ahead.
Good morning, sir. Good morning, sir. Sir, first, as you have told that patient is hemodynamically stable, so I will ask about the mode of injury. What was the mode of injury? And
it is a road traffic accident. That's not very relevant. Let us go to the relevant points. The patient is in front of you. He's hemodynamically stable. He has got blood at the meatus. what is the examination you will do in this patient aside from the general
Sir,
examination?
after general physical examination and the abdominal examination, I will focus on the pelvic examination. We'll look for the any pelvic fracture is there. We'll look for the pelvic instability, and then I will do the local examination of the external genitalia, whether as you have told that blood is there, whether any tear or any laceration is there, whether the scrotum is okay or any evidence of hematoma is there, whether any perineal hematoma is there, and we'll do a quick DRE also to assess whether there is high riding prostate or some evidence of disruption is there.
Also, if you do a DRE and you don't feel the prostate in its position, what is your inference?
Inference is that probably patient has sustained this pelvic fracture urethral distraction defect at PFUDD. What we should say that posterior urethra, it is high riding prostate. That prostate has gone a little bit higher, and I can palpate the bladder. Where patient is not able to void also, and blood at the meatus, as you have already told, sir.
Okay, fine. So on abdominal examination, there is diffuse lower abdominal tenderness. You cannot feel a bladder separately, but there is obviously some hematoma in the pelvis, and he has got lower abdominal tenderness and guarding. You can't feel the bladder. What will you do now?
Sir, if patient is stable, so in emergency, I would like to do a quick ultrasound, fast scan. I
Would you
will like
like
to
to
do.
pass a? Would you like at this point? Would you like to pass a catheter and see?
Right now, sir, as I am unable to palpate the bladder, so
No, I am
I will first,
asking you whether will you pass a urethral catheter?
sir, gentle attempt of pass with adequate jelly, sir. We can put an attempt,
So
but
a
only
gentle
single
attempt
attempt.
to, so the message here is a gentle attempt to pass a catheter is not going to be harmful. Only
Yes,
thing,
sir.
one should not try and force the catheter through. You might complicate the injury further. But if a gentle
Yes, sir.
attempt,
Yes, sir.
your catheter goes in, it is fine.
Yes, sir.
So we have tried a catheter gently, it is not going in. Now, what is the next step?
Next step would be, sir, I will do a quick ultrasound. We'll see whether bladder is inflated and patient is not, as patient will also give history of not able to void. So I will plan to put a, sir, high midline SPC under ultrasound guidance for this
Good.
patient.
So, in case you are unable to palpate the bladder, it is always better to get an ultrasound done and do a suprapubic catheter under ultrasound guidance. Fine. So you have got an ultrasound done. You have put a ultrasound guided suprapubic catheter. What next now? Once you put the catheter, you got mildly blood-stained urine, but the patient is feeling a lot more comfortable now.
Yes, sir.
What next are you going to do? Patient is stable. His blood
Sir,
investigations are all right.
we'll get orthopedic opinion also. We'll get orthopedic opinion. Patient is pelvic stable and all. Then I'll just advise the patient to review to my OPD with the relevant investigations. So at this
Yeah.
point of time,
So
I would not.
fine.
Yes.
This patient has got the orthopedic surgeons feel because of the pelvic hematoma, they want to stabilize his pelvis and keep him in the hospital till he is stable, observe him. I don't think such a patient should be sent home after such kind of an injury. So he is admitted and he's stabilized by the orthopedic surgeons. It is 3 days post-operatively. They have called you and asked you, what would you like to do? Shall we send him home or so what would you do in this situation?
Sir, immediately I'm not going to intervene in this case. So I will just, after putting my advice, I will ask to discharge the patient with the advice of proper SPC care. And as I have put the SPC trocar, so I would like to call him after 2 weeks to my OPD to change the catheter. And
Fine.
then
Dr. Prashant, you have any difference of opinion or would you like to go in the same way?
Sir, it will be like that only, sir. But one thing we can do, sir, endoscopic realignment after 1 week, sir, at that time.
So see, in the exam, this is a what I'm trying to come to is management of initial pelvic or urethral injury due to pelvic fracture. We have two approaches. We have a delayed approach like what Ripendra has said. He will place an SPC and reassess the patient later. The other question that can be asked is, what do you know about early endoscopic alignment? Now, in the exam, it is always better to tell that what is the practice being followed in your center. You know, the examiner will understand that this is what you have seen, what you have been exposed to, and that is absolutely fine. But as a, going for the exam, you should know what are the other alternatives and what is the data and the literature on other alternatives. Though it is not necessary that you have to say that that is the only way, because the examiner will understand the kind of approach being followed in your center. So yeah, Prashant, what is the other approach that can be done? Prashant, you were saying something.
Yes, sir. I was telling about the endoscopic realignment, sir.
Yeah. So tell me in brief, what is that? What is that?
Sir, that to be done around after 1 week, sir. After 1 week of injury, sir. Two scopes are put.
What exactly is done in that?
Sir, in that thing, two scopes are put, sir. One flexible, probably flexible cystoscope through SPC side, and one per urethrally, sir. And both are realigned, sir. After realignment and a passing guide wire, one catheter is put, sir.
So
And
you must be aware that endoscopic alignment is now, there is a lot of literature available on that is done within the first week after the pelvic injury, and it is done where you have adequate facility for fluoroscopy and endoscopy available. You have to have retrograde and antegrade endoscopy and availability of fluoroscopy. So Prashant, what is the advantage of doing early endoscopic alignment?
Sir, the only advantage will be there, like that realignment will be there, sir. But the stricture rate will be same. The advantages will be there. Both the end will be nearby, sir. So after definitive repair, there will be less difficulty, sir.
So you must be aware on the data that when you do endoscopic early realignment, the proponents of this technique, they say that the kind of strictures that develop in the long run will not require very complicated surgery. The amount of fibrosis that happens between the disrupted ends of the urethra will not be as much. The amount of callus that is there. So proponents of this technique cite the data says that the future stricture that develops will be much easier to tackle than in a delayed approach. But both approaches are correct, and whatever approach is followed in your institute, you should say that. And if asked about any sort of alternatives, you should be aware that this is done and what are the advantages and disadvantages of each approach. Okay. So yeah, so this pelvic fracture was managed conservatively. No other injury was present. The patient was discharged after 3 days. Like Dr. Ripendra said, he would not want to do anything now. Bed rest for 6 weeks. And the patient is on regular SPC change. Then he has come about 8 weeks following the surgery. What would you advise him now? He's able to walk around. He says he has got weak erections, but otherwise he has recovered quite well.
So, sir, I will advise, I would do a repeat ultrasound, sir, to look for the hematoma as you have told, whether it has resolved completely or
See, if the
or
patient
any.
is stable and the patient is walking around and he's otherwise okay, there's no need to do the ultrasound. The ultrasound is first of all not a very great tool to assess for pelvic hematoma. And you have to talk about clinical situations. So unnecessary investigations which are not going to help you in your management are not to be said in the exam. So this is what happens. If you say something which is not relevant, then you will be asked questions. What is the advantage of doing ultrasound? Will it change your management? And then you are stuck in that. So please go to relevant In the exam, the important thing is relevant investigation, so that examiner knows that you are in the right direction. So you save time for yourself. You get more time to answer your questions, and that's the way to go about in the exam. So
I would like to do RGU for this patient, RGU along with the antegrade retrograde ureterogram along with antegrade ureterogram, or better approximate ureterogram, to assess the defect in the posterior urethra.
So before that, before going to the investigation, see, you said ultrasound, then straight away you went to RGU, MCU. You must ask for clinical examination. What is the clinical examination?
Will
8 weeks after injury, what is the situation? That is the way to go about it. First thing is the clinical examination, then is the relevant
So
investigations.
we'll assess for the pelvic stability. We'll ask the patient, as I am going to intervene in that, whether patient is can be taken into lithotomy position. So I will assess him in whether he is able to squat or not, and we'll assess his external genitalia. We'll ask for the, as you have told, erectile mild ED is there. So I will apply this international index of erectile function, IIEF score. I will calculate before moving further, sir,
Good.
so that
So,
I can explain.
in this kind of patient, you must ask for erectile dysfunction, because that is an important in young men who usually sustain these kind of injuries. That is important for you medical legally, as well as, you need to know the status before you attempt any surgery, because, the patient, if the patient feels he has good erections, post-operatively the erections become weak, then it always can be said that this was due to surgery. So what is your knowledge about the etiology of erectile dysfunction in pelvic fracture urethral injuries? What is the etiology?
Sir, pelvic fracture can cause vascular injuries, sir, to the cavernosal vessels, sir. That is one of the etiology. It can lead to AV fistula formation. That can also be a cause of erectile dysfunction,
Not
and can
talking
be
about very rare
neurogenic
causes. What
injury.
is the most common cause of ED after a pelvic fracture? It is neurogenic.
Neurogenic, sir. Neurogenic.
Neurogenic is very common,
Neurogenic.
and it may be multifactorial. You may have neurogenic plus vascular. Vascular can be arterial, venous, or a combination of all these three.
Yes, sir.
Generally speaking, the neurogenic component is very important, but you can also have vasculogenic, which is either arterial or venous. Fine. So you have examined the patient. The patient is generally, all the examination is quite okay. He's got normal genital. He's got normal investigations. And now what do you want to do after this, after getting his routine investigations done?
Then I will order this retrograde ureterogram plus antegrade ureterogram, sir.
Okay. So anyway, this is a plain X-ray that was done. And what does this show? Can you briefly comment
Sir,
on that?
not able to see your slides, sir.
No? Can you see this X-ray?
Yes, sir.
Yes, sir.
Okay, so this is the, please comment on this. Look at it carefully and then see, and I want you to give your assessment of this.
It is a sort of approximate ureterogram where I can see a abrupt cutoff at the bulbomembranous junction, sir, and the whole of the anterior urethra looks normal, and with
So you
abrupt
must
cutoff
say
at
in the
the
exam, this is a combined cystogram and a retrograde urethrogram.
yes, sir.
Okay. Yeah, go ahead.
So there is a abrupt cutoff with the dilatation at the abrupt cutoff at the bulbomembranous junction, with posterior urethra not visualized, with the contrast I can see inside the bladder, with the bladder neck integrity is there, as I can't.
So what is this over here? You see this arrow?
Sir, this is bladder neck, sir. It is not open, sir.
Okay.
It is
So
might
you
be
have
some
bladder neck,
calyx maybe
which
there.
is not really open and is not have a proper voiding study.
Sir.
So what is your
And
assessment of the anterior urethra now? What are the key things you look for in this kind of a patient in the anterior urethra?
sir, in anterior to say, sir, distensibility of the bladder. If there are whether
I'm
any
asking anterior
extra,
urethra, yeah.
yes, sir. Whether any extravasation is there or not, sir.
No, all that is not there. So what is
Yes, sir.
in terms, if you're planning a surgery, let me rephrase the question. If you're planning a surgery, what are the relevant findings in the anterior urethra which will affect your surgical treatment?
Any BXO changes are there or
No,
not?
all that is not there. I'm saying this is the
There can
urethra.
be
You see normal pendulous urethra, which is the critical part of the urethra, which is going to
Sir,
impact on your surgical procedure.
sir, in this we'll see the distal extent of the stricture, sir. Where it is this.
So the bulbar urethra is
bulbar.
extremely important. Bulbar urethra is because when you are planning a surgery for pelvic fracture distraction defect, the quality of the bulbar urethra, of course, other things you mentioned, BXO, all that is fine. But where you have a normal anterior urethra, you want to know the quality of the bulbar urethra. What is it in bulbar urethra that is important?
Sir, length
The
of the
length
bulbar,
of the bulbar urethra is very
urethra.
important.
Very
Whether the
important.
proximal bulb is healthy,
Yes.
what is the length of the bulbar urethra. So those things are important because they can impact the type of surgery that you are going to do. So always look at the bulbar urethra. Other things that you look for, as you pointed out, is how does the bladder look? What is the bladder capacity? How is the bladder neck? The bladder neck is very important to know. You must not, so here the bladder neck is not opening, which is probably physiological. Sometimes it doesn't relax when the cystogram is being done. So what is the thing about bladder neck you want to know? Like in this case, okay, let me ask you, in this case, since the bladder neck is not distended or opened, how would you assess the bladder neck?
Sir, to assess bladder neck, we can do again this MCU after giving tablet silodosin, sir, 1 hour before the procedure. Or we can do, sir, integrate cystoscopy, sir, either with the flexible, probably with flexible cystoscope, sir. If it is not there, then we can do rigid cystoscope also, sir.
So what do you want to know
We'll
about the
see.
bladder neck?
Sir,
Sir, after
integrity of the bladder neck, that is our concern, because anyways the external sphincter function will be gone, so all the continence it will be depend on the bladder neck, sir. So we want to check whether patient will retain the urine after the surgery or not, sir. So bladder neck integrity, sir, we want to check, and also
So the
sometimes
competence of the
callus formation. Callus formation is also there, that will pull the urethra apart, sir. So that will also impact my surgery if I have to remove the callus.
So the competence of the bladder neck is very important to assess, because if you have a wide, fixed, dilated bladder neck which is not competent, then your whatever surgery you do, you're very likely your patient is going to be totally incontinent. And you have to counsel all this before, because if you do a surgery and you land up with a severe incontinence, then it's not of any use. So counseling is very important. Length of the bulbar urethra. Does anybody know what is called gapometry index?
Sir, it is calculated in the MRI.
No, it can be calculated by a good RGU MC also. What is that actually?
Length of
What is gapometry index and how useful it is? What is the purpose of doing that?
Sir,
Sir, it will tell about the defect, sir. It will tell about the length of the stricture, sir.
No, gapometry index will not tell the length of the stricture. So what you have to see is,
Angle.
I mean, in this patient, you can't calculate the gapometry index because you can't see the proximal extent because bladder neck is not opening. But when you have contrast in the posterior urethra, you can measure the length of the defect on the X-ray and divide it by the length of the bulbar urethra. So gapometry index takes the length of the bulbar urethra in consideration along with the length of the defect. And if the index is less than 1/3 of the length of the bulbar urethra, overall length of the bulbar urethra, then the chances of having a less complicated procedure are there. But if the gapometry index shows, basically the longer the defect and the shorter the bulbar urethra, the more complex is the surgery. So the gapometry index is an objective way to know the ratio, length of the defect divided by the length of the bulbar urethra. If less than 1/3, then chances are you will have a simple procedure. If it is more than 1/3, say half or 3/4, then you are likely to have a more complicated procedure. So this will give you a rough idea, or not a rough idea, a good idea about what kind of a surgery you're going to be required to do, because you have to be mentally prepared in these cases to what extent you have to go. Anyway, what is the role of, so these are the things on the RGU that are very important. Look at the urethra carefully, look at the length of the bulbar urethra, look for bladder condition, look for the bladder neck. All these things have to be thoroughly evaluated, and know about the gapometry index, what is the importance of that, how you can plan your surgery. So this gives you a good information on a roadmap ahead. What is the role of, anybody can say what is the role of an MRI in these cases?
Sir, MRI, because it is posterior defect will be this, MRI will tell about the alignment of the urethra. Sometimes with severe injury, the alignment of the urethra very wide of angles will be there. So it will be very difficult to align the urethra. If we are aware pre-operatively, then we can proceed accordingly, sir.
Actually, yes, the direction of displacement of the prostate you cannot assess on a RGU and MCU. And in a lateral view and a posterior view of the MRI, you can get a 3D orientation about the actual, if the defect appears very small and if the angle is different, you may get a much longer defect, which you won't be able to see on the this kind. So these are various other methods that used to, which are meant for better knowledge about the defect. And there is also some talk about 3D reconstruction and 3D printing. But so you should know about all the, you should clearly know how to read the RGU and MCU. If you know that well, then you are passed in the exam. But you should also know the newer techniques that are being used and what is the advantage of that. So see, in the exam, if you go through the basics right, then you are more or less passed. But knowing extra information, whether you know or not know, it's always advantageous for you. You perform better, you give a better impression to the examiner. And if you do really well and have a good idea about one case, and in the other case you are a little bit weaker, so that time all these things are taken into consideration, that okay, this guy is well read. Maybe in one of the cases he was not that proficient. So this is how you should go about in the exam. Basics have to be covered completely. Fine. So you have done your assessment, and now what is the what surgery you go ahead for?
Sir, I'll explain the procedure to the patient, sir, and we'll take the relevant consent to. I'll proceed with the progressive perineal urethroplasty, sir, for this patient.
So can you briefly, quickly go through the step-by-step description of the progressive perineal end-to-end urethroplasty?
4 components of bulbar mobilization, pleural separation, coming, and urethral rerouting. So
you will do a bulbar urethral mobilization first, followed by
mobilization, pleural separation for inferior pubectomy and urethral rerouting.
Okay. So these are the progressive steps. So once you have opened the crura, the next step, what do you do? So those of you who have assisted this kind of surgery, you have divided the crura, separated the crura on either side. Now, how do you identify the proximal end? Prashant, can you take that question?
Yes, sir. Sir, it can be done. We can put one bougie, sir, anti-greatly, sir. At that, we can assist, sir.
A group sound or something.
So one way of doing it is you put a bougie, and you should put a wide, not a very thin bougie, a wide dilator or a bougie, so that you do not enter in, you do not perforate anywhere around the bladder neck and come through a false passage, because it is a blind procedure. And if you try to force again through your, suprapubic tract, you might enter into the perineum through a false passage, and that can be really dangerous because it will totally misguide you and you will go in a wrong direction. So getting the proximal stump is very, very critical. So one of the ways is doing, suppose there is a lot of scarring there and you put a bougie, you are unable to feel it in the perineum. You put a wide dilator or a semicircular bougie and you put it through the suprapubic tract, you can't feel it in the perineum. You open the crura, there is all scar tissue there. You can't feel that because of the scar tissue. What will you do then?
So we'll take one flexi scope, sir. We'll take one flexi scope and we'll cut through light. That light will, whenever it is coming, wherever it is
Sometimes the
coming.
scarring, if the scar is very thin and flimsy, you'll be able to see some light. Otherwise, there is no light seen there because of the thickness of the scar. So what this means is that your proximal end is much higher up or much deeper in the perineum, and you cannot proceed blindly. And so then the next step, then you do the inferior pubectomy, because by dividing the lower inferior pubic bone, you get deeper access in the perineum, and then maybe you may start feeling the bougie. So that is what is called step by step. So suppose you have divided the pubic ramus and you are still not sure where your proximal end is. What do you do?
We'll have to
Okay.
go
So one
for
of
the
the things
abdominal.
that can be done is, if you are unable to, feel the bougie, or if your suprapubic tract by the original doctor is not being placed in a proper way, it is on the side and your bougie doesn't enter into the perineum, you can make a small cystotomy, and it is safer to do that, and ask your assistant to insert his finger through the bladder neck. And then with the finger mobility, you know you are in the right place, and then you can cut over that, as it is fed in the perineum, you can feel the finger and then cut over that area. So when you are facing with lot of scar tissue, blindly trying bougies and all may be risky. So it is no harm in doing a cystotomy, seeing the bladder neck, visualizing it and going in the right direction. So fine, once you have done all of that, you have identified the scar tissue and you have identified the proximal end. So what are the key steps to deal with this prostatic apex and scar tissue? So what I mean is, the important thing is complete excision of scar tissue and identification of a healthy prostatic apex is the goal of the surgery, and that is one of the things which ensures a good outcome. You must see supple mucosa of the proximal or the prostatic urethra. All the scar tissue has to. So this is what you have to say in the exam, so that people know what exactly you're saying. Last couple of situations which are rare, but you may have an idea about it. What if you have done adequate bulbar mobilization and you have identified the apex and your two ends are not coming together?
And crural separation, sir.
No, crural separation pubectomy is done, still your two ends are not coming to close to each other.
Sir, in this case, superior pubectomy may be tried, sir.
What is that?
Sir, superior pubectomy, sir. Superior pubic rami, sir.
So you mean to say total pubectomy?
Yes, sir.
That is a transpubic approach. You excise the pubic bone in the midline completely bilaterally and do a transpubic approach.
Yes, sir.
So sometimes a transpubic approach may be useful, but the advantage, the transpubic approach, when you do, it doesn't add to the length. You don't get extra length if you convert it to transpubic. It is only gives a help for you to take adequate sutures because of the pubic bone which is sitting over there. It will not give you extra length. It is just done sometimes to facilitate the anastomosis. If your two ends are not coming together, then you break the pubic bone, you may still not be able to get the two ends together. So in those situations, there are other procedures where these are very complex strictures. You may have to put an intervening preputial tube in between or do a two-stage procedure. So these are some things you should be aware of. So, okay, you have done the bulboprostatic anastomosis. So how do you follow up these patients now? Quickly, man. Now you should not wait. This is simple things.
Sir, we'll discharge the patient after removing the drains and all, and we'll keep the SPC and PUC in situ, and then we'll ask the patient to come to the OPD after 3 weeks, sir. Sorry, 10 days
So 3
for
weeks is the
suture
time you
removal,
give
or
for healing, for anastomosis healing.
yes, sir.
What do you do after that?
What? Sorry, sir.
After 3 weeks, he has come to you. What will you do now?
Sir, we can go for pericatheter ureterogram, sir, before removing the periurethral catheter to check the integrity of the anastomosis.
See, the pericatheter ureterogram is a little controversial thing because
Yes, sir.
you are doing it in a non-physiological way. You're pushing contrast from the side of the catheter, and you're using extra force because already there is a catheter inside. So you may not get a very representative study. So there is no harm in removing his urethral catheter and doing a cystogram. Maturating cystourethrogram.
VCUG we will advise.
VCUG is a good way. It is a physiological way of assessing what has gone wrong, and what is the situation. And then if he voids well, you don't see any extravasation, then you either clamp the SPC, remove it after a day, and that is how you go about it. Suppose you see some contrast extravasation, but he voids well.
Sir,
more weeks.
We will give 1 more week, sir. We will put catheter and we'll give 1 more week for proper healing, sir.
So there is no harm in leaving a catheter. Rare situations, it may take a few extra week or so for things to heal. So that is the advantage of doing a dye study. So any other doubts that you may have now about these kind of cases?
Sir,
Sir, last 10 minutes for this case, sir.
Sir, your voice is not coming.
Hello?
Yes, sir.
Yeah. So,
sir,
any questions you may have, any doubts any of you have about, because these are quite common cases kept in the exam.
Sir, when to use the abdominal approach also, that when to approach this patient through abdomen. Also,
yeah, so you go, the important thing is to go step by step, as we discussed, as you already said, do the steps one after the other, do an inferior pubectomy, identify the proximal end. Now, suppose you have identified the prostatic apex after doing a pubectomy, and you feel there is still a lot of callus or bone there, and you can't take your sutures properly. At that point, it is important to convert it into a total pubectomy. That is the abdominoperineal approach, where you go make a lower abdominal incision, expose the pubic bone, detach the attachment of the rectus abdominis from the sides and do a pubectomy. And then you create a subperiosteal plane. And then what will happen is from above, you will be able to directly see your bladder neck and the urethra. There'll be wide open space and it's very easy to take sutures. See, because these are, these are patients where the first attempt is the most important attempt.
Yes.
Once they fail, then the problems are more difficult. So there is no harm in going ahead for a, if you feel after doing an inferior pubectomy or you can't take appropriate sutures or you can't dissect the prostatic apex because it is so high up, then you do a pubectomy, you'll be able to easily dissect the prostatic apex. So in a step-by-step approach, after doing the inferior pubectomy, if you feel you still can't assess the prostatic apex, you can't get a nice tension-free anastomosis, then you do a pubectomy.
Yes, sir. Sir, any rule of graft or something?
Yeah, so those are rare situations which we talk where the two ends are very wide apart and you cannot bridge the, if you try to pull the distal urethra, you may lead to a severe cordy. In that case, you have to bridge the defect. One can use a penile skin flap and convert it into a tube and connect the two ends. There is no role for grafting here because there is no bed available there. There is all callus there. So no graft is going to sit there and, take up. So if you are unable to bridge the two ends by all your methods, you can either do a two-stage procedure or you can bridge the defect with a penile skin flap. Make it into a tube and bridge it. These are very complex procedures, so this will not really, that much discussion may not go in your exam, but you need to be aware.
Excuse me, sir. Can we wind up this case, sir? So we'll running short of time, so we'll start with the next one.
Yeah, I have completed most of the
Deepak,
salient features in this
Deepak,
case.
Before you wind up, one question from chat box. What is the indication of MRI in the background of PFUI? You can take this issue into early and late evaluation. Yeah. MRI.
So the role of MRI is required in some cases where there is a lot of, what to say, severe disruption that happens and leads to bony spicules which might come in the way in your prostatic, I mean in the callus formation and the urethral defect, which you need to know the exact orientation of the bone of the prostatic apex, because sometimes that information is important when the kind of injury is very severe and there is a lot of rotation and distortion of the prostatic apex and the bone penetrating into the defect. So that will give you an idea about the bony anatomy and what all extra bone you need to excise and stuff like that. So MRI may be useful in those kind of cases.
Thank you, Deepak. Thank you very much. We'll move on to the next case.
Yes,
thanks.
We'll move on to the next case, case number 9. It will be chaired by Dr. Rajesh Tiwari, sir. And the students for this session would be Dr. Vivekanand Hiremat, Dr. Zishan, and Dr. Vikas Agarwal.
Am I audible, sir?
Yes, sir. Yes, sir.
Oh, good morning to all. Dr. Dubey, Dr. Chawla, Dr. Yadav, Dr. Rajiv. So let me start now. My case is 70-year-old male with complaint of poor urinary stream for last 1 year, incomplete emptying for last 4 months, increased frequency with urgency 4 months, and hesitancy 4 months. So let me ask Dr. Vivek, what do you call these group of symptoms? What term stands for these group of symptoms?
These are both storage and widening lower urinary tract symptoms.
Oh, so lower urinary tract symptom comprises of storage symptoms, widening symptoms, and one more.
Quality of
Post-void dribbling.
Post-void.
post-void dribbling. Out of these three, which is more bothersome and compels the patient to seek early treatment?
Storage symptoms, sir.
So storage symptoms, because this gentleman was having symptoms for last 1 year, but when storage symptoms get added, then he came for treatment. So what do you think are the probabilities differential diagnosis for these group of symptoms in a 70-year-old male?
One can be bladder outlet obstruction, sir. Can be due to benign
that is a very broad term.
Benign prostatic enlargement.
Benign prostatic enlargement or hyperplasia. Second?
Second can be stricture urethra, sir.
Okay. Third?
Third, prostate carcinoma.
Okay.
Then bladder calculus.
Okay.
Neurogenic bladder.
Okay. More common than that? Phimosis and metal stenosis. These are the other possibilities in this case. Okay. So how will you proceed further? You will go for history of present illness, na?
Yes, sir.
So what will you ask in history of present illness?
History of present illness, I would like to ask, is there any history of hematuria, sir? Lithuria.
Okay.
And instrumentation.
So any history of catheterization, instrumentation, all these things have been written here. What is missing you should ask for?
Trauma.
You should take, even the patient is 70 years old, but you should ask for sexual history. You can't ignore it because it will important in the future plan of treatment also. And you should also ask for bowel. You should also ask for bowel habit, sleep history. These things are very important. Okay. And then again, what you will ask for? History of allergy to drugs. It is also very important from management point of view. Next, what you will do?
Then I would like to go for examination, so general physical examination.
So he is conscious, oriented, afebrile, vitals are stable, systemic examination, NAD. So I will like to highlight one point. Recently, I was in one exam, I was examining the students and asked about systemic examination. He told everything is all right. I asked about apex beat in CVS. He said it is in the left intercostal space, but patient was having dextrocardia. So we have not seen the exams patient. So at least please examine the patient before telling anything that everything is all right. So he was caught that he has not examined, he was telling lie. So these things should not happen. At least before committing anything, you should confirm it. Next, what you will go further? Next.
Local examinations, genital
local
examination. Yes.
Local examination, what you will look for?
One is genital examination and bladder palpable. Is there any distal rectal examination?
Okay. What you see in distal rectal examination, what things are important?
One is anal sphincter tone, sir.
Okay.
Then first, and then if there is any prostatic enlargement, if it is palpable, what is the consistency? What is the mucosa?
Okay.
Whether is it tender?
Okay.
Whether nodules, if it is felt, what is the, whether it is unilateral, bilateral, or
can you, does DRE give you an exact idea of prostatic size?
Yes, sir. Approximate. Yes, sir.
Whether it overestimates or underestimates?
DRE overestimates. DRE underestimates, sir. Trust overestimates. Yes.
Which
Press
lobe you can't assess by DRE?
Median.
Median lobe you can't assess by DRE. Okay.
Oh.
Next, anything more in examination?
Bulbocavernous reflex, sir.
Oh, so focus neurological examination you must
Focus.
do. Focus neurological examination you must do. You should look for sensation. You should look for muscle tone, bulk, and then reflexes, out of which bulbocavernous reflex is very important. How do you assess bulbocavernous reflex? Any other?
We will keep the sir. We will keep the finger in the anal canal and will pinch the glans of the penis and look for the contraction, sir.
Okay. And any other? If the patient is on catheter?
Sir, then we can just gently pull the catheter against, touch the catheter, and the same reflex will be elicited. That is, there will be the contraction of the anal sphincter, sir.
What does it tell? What is the significance of?
Sir, it tells us the intact reflux pathway that involves the pudendal nerve, S2, S3, and S4, sir.
Yes, yes, yes. Yes, so focus neurological examination is very important. What will you do next?
Sir, also I would like, in this patient, I would like to have a bladder diary and IPSS scoring of the patient, sir.
In which group of symptoms bladder diary is more important?
Over storage symptoms, sir.
So for storage symptoms, especially nocturia, it is very important. It is very important. Avoiding diary is very important. What you do, in what information you get from avoiding diary?
Sir, it helps us to differentiate between the nocturia, overactive bladder, and nocturnal polyuria.
What you instruct to the patients, how to prepare a diary?
Sir, for the patient, the diary has two parts. One is the voiding part and another is the intake part. For the intake, we have to ask the patient every time he is taking the fluid, amount of fluid that he is taking. He has to mark that and mark the volume. And for the voiding, the patient has to mark the amount of urine is passed, the number of time he has passed the urine, and also if each pass was associated with urgency or urgency incontinence.
Okay. For how many days you will ask to keep the record?
Sir, minimum of 3 days, sir.
Minimum of 3 days. How it helps in nocturia evaluation?
In the patient with nocturia, sir, there will be increased in the either there will be a increase in the urinary output in the night, which could be around more than 33 to 40% of the total output, or there could be this could also tell us about the decreased nocturnal bladder capacity, in which the patient will be having frequent voids, and each void will be less than the maximum voiding capacity during the 24 hours, sir.
Okay. Okay. And voiding diary also helps if you are putting the patients on medical management or conservative management. Then follow-up voiding diary will help you in the
objective assessment of
the patient. Yes. How will you assess the severity and bothersome of the symptoms, these LUTs?
Sir, we do the IPSS scoring for the patient, which includes symptoms and a 8 score of quality of life, and it is graded on basis of 1 to 7 is mild symptomatic, 8 to 19 is moderately symptomatic, and more than 20 to 35 is severely symptomatic patients, sir.
Okay, so this patient is having a score of 20. Okay.
Yes, sir.
So next, what will you do to work up this case, to arrive at a diagnosis?
Sir, I would like to get the basic workup of the patient.
Any other student can also answer. Give an opportunity to other.
I would like to do an ultrasound of the abdomen, ultrasound KUB of the patient.
Okay, first you will go for ultrasound or some lab investigations?
Sir, basic routine blood investigations in the form of complete blood count, serum creatinine, urine routine microscopy.
Okay.
Also urine culture.
This is the hemoglobin, hematocrit, total WBC, platelets. This is all within normal limits. Renal function test. So this is all about urine microscopy and culture. So urine routine is showing WBC 60, RBC 19, epithelial cell 3, bacteria present. and culture is negative. Can you comment on this report?
Pyuria, hematuria and
what could, so he is having hematuria along with the pus cells.
Yes.
But culture is negative, bacteria present.
Yes.
So what does it indicate? In which conditions?
Sterile
pyuria. What are the causes of a sterile pyuria?
Sir, causes of sterile pyuria could be divided into infective and the non-infected causes, sir. Infected causes include patient has a recent intake of antibiotic, fastidious organism, geotuberculosis, fungal infection, while the non-infected causes include acute tubular necrosis, glomerulonephritis, interstitial cystitis, recent history of instrumentation, sir.
And anything else? In context of this patient, you have not enumerated, you have noted. Yes, a stone, malignancy, tumor, they can all cause this picture.
Yes, sir.
They could not, they can't?
Yes, sir.
They can present this picture. So, presence of WBC, RBC, they suggest the presence of whether it is a associated tumor or maybe because of a stone. Bacteria is present in urine microscopy, but culture is negative. What is your take on this?
Sir, it could be either the contaminant.
Patient is not on catheter. It could be a contamination.
Contamination.
It could be a contamination. So now next, what investigations will go for? Next, lab investigation completed. What you go for? Imaging.
Imaging. Ultrasound KUB.
Ultrasound of the KUB, sir.
So this is the ultrasound. Can you comment on this ultrasound? What is the positive finding on this ultrasound?
There is hyperechoic in the bladder, sir. Probably.
What is the? What? Now tell me the radiological findings first. What does it is showing?
A hyperechoic lesion. Hyperechoic lesion with a posterior acoustic shadowing, sir.
Yes. It means there is a bladder stone. It suggests the presence of bladder stone. So this is the complete report of ultrasound. I am reading for you people. Bladder well distended, 3.5 centimeter hyperechoic focus, bladder stone, wall thickness 7 mm. What is the importance of wall thickness?
Sir, wall thickness is considered a surrogate marker of the bladder outlet obstruction. And in a patient, in an adult patient, if a volume is around 150 ml, it has to be less than 5 mm. And patient having 250 ml of volume, it should be less than 2 to 3 mm, sir.
Okay. So wall thickness is more. So the whole wall thickness is there. Another parameter is which is seen, detrusor thickness.
Yes.
And bladder weight. These are the advanced parameters still to be clinical, to come in clinical practice. No free floating internal echoes. Prostate is 70 cc. 1 centimeter intravesical median lobe extension. What is the significance? Why it has been written?
It decides the if there is median lobe protrusion, sir.
So what is the significance of knowing about the median lobe?
There may be failure of medical management, sir.
One thing is that median lobe people respond poorly to medical treatment. Second, it is also a sign indicator of
chronic
obstruction.
Yes.
Like bladder wall thickness. Can you grade it?
Sir, it is graded as less than 5 to 10, more than 10 mm, sir.
More than 10 mm is important. And kidneys are bilateral normal size and echo texture, PCS, no. So next, what you will go for next?
Next is
patient is not on catheter, uroflowmetry. So this is the uroflowmetry. If it is obstructive or non-obstructive?
It is obstructive.
Obstructed pattern, sir.
The curve is obstructive. And what about the parameters?
Significant PVR, sir.
Significant PVR. What
Yes,
is the,
and
whom we call it significant PVR?
more than 10% of the void. Consider
More than 10% of the void.
Voided balloon. Yes.
Okay.
Clinical, like.
And which parameter you regard for telling that whether the uroflow is obstructive or not obstructive? Which is the
Maximum
most
flow rate, sir.
Max,
Q max, sir.
maximum? Q max is the parameter on the basis of which you tell that whether it is obstructive or non-obstructive.
Yes.
Okay.
Less than 15.
So based on these investigations which you have already got, what is your probable diagnosis? Or you will go for some other investigations?
I would sir, for probable diagnosis, it is a complicated lower urinary tract symptoms with benign prostatic enlargement and a bladder calculus.
Okay, good. So your diagnosis is BPH with bladder stone. So will you like to have some more investigation or it is sufficient for starting management?
Sir, I would like to get an X-ray KUB or with pelvis region, sir, just to document the bladder stone, and it will help us in follow-up in the post-op, sir.
What type of a stone does it look? It is smooth?
Smooth, round, oval shape, sir. Secondary bladder calculus, sir.
Secondary. What are the types of bladder stone?
Sir, primary bladder stone, secondary bladder stones.
So, which is primary, which is secondary?
Sir, primary bladder stone are those that are not associated with any intravesical pathology and primarily seen in the pediatrics age group.
Okay.
And they are made up of, they are consist of, basically they are due to the deficiency and protein deficiency and cereal based diet in those patients.
Okay. And secondary bladder stones, they are formed because of?
There is either an intravesical pathology or a bladder outlet obstruction, sir.
In a case of BPH, what are the risk factors for formation of bladder stone?
Chronic obstruction, sir.
Chronic obstruction, especially in median lobe. Enlargement, because of the stasis of urine, bladder stone is formed. Patients on chronic catheters, they are prone to form history of recurrent UTIs. These patients are prone to form bladder stones. So, any more investigation before starting management, or you are satisfied?
Satisfied.
Will you like to go for PSA in this case?
Sir, the patient is more than patient is around 70 years of age.
Okay.
So, doing a PSA in this patient will not change our management plan.
Okay.
Because that we
and also DRE.
What the guidelines say?
Sir, the guidelines
say in India only for means in DRE if there is suspicious nodule, sir, or
okay.
And if it changes the active management of the patient.
Okay. And if the life expectancy is
more than
10 years, then you should go for. But unfortunately, this patient got his PSA done and it came out to be 8. Sometimes patients are very interested in getting their PSA done, or their relatives are very interested in getting their PSA done, and PSA has come 8.
Sir, since the patient has also have a large bladder stone in situ,
Okay.
so I would like to get a PSA repeat in the post-operative period with standardized condition from the same laboratory with the same assay, sir.
Okay. Now, what do you do for this patient?
Surgical management.
How will you manage?
Surgically management.
Surgical management. Okay. What surgery will you plan for this patient?
URP with percutaneous histolithotripsy we can.
Sir, I would like to go for an SPCL with open prostatectomy, sir.
And because will you like to do when there is a suspicion of PSA is raised, you have not done the biopsy, there is chances of that patient may be harboring malignancy. Will you like to go for open prostatectomy in this case?
No, sir. No.
Taking this picture in background, what will be the safer alternatives? Yes, if PSA would have been normal or no suspicion of malignancy, I would have agreed with you that you can go for. What type of open prostatectomy will you like to offer? What are the types of open prostatectomy which you can do?
Freyer's and Freyer's prostatectomy.
What is Freyer's prostatectomy? Which route does it follow?
Transvesical.
Transvesical.
Transvesical. So another route is
retropubic.
Retropubic. So whether you will go for Millions or whether it will go for transvesical in this case?
Transvesical, so that we can handle the bladder stone also in the same setting.
And another factor which is present in this case, which you will handle easily
median
by transvesical route. Yes, median lobe and big bladder stone. Both can be handled at the same time, which you will find difficult to handle with retropubic prostatectomy.
Millions.
And what are the other options if patient doesn't want to have open operation for prostate or for bladder?
Holmium laser excision.
Again, with holmium, one thing is that it is not being practiced. I will not discourage you, but what is the negative factor in this patient which will go against holmium, use of holmium?
The presence of the bladder stone.
Now, that you can handle by separately. Yes, large median lobe, you can injure ureteric orifices while handling median lobe. And second thing is again that biopsy material may not be will be getting for histopathological exams, because we are opting for laser. What are the other options, common options, before going for open prostatectomy and laser prostatectomy? What are the common options for removing prostate?
Transurethral
TURP, sir.
By which? By monopolar or bipolar? How do you choose that which cases you can do by monopolar, for what cases you need bipolar?
It is large gram, more than 45 gram, can go for bipolar, sir.
What is the advantage of bipolar?
To reduce the chances of TUR syndrome.
To reduce the chances of bleeding is less with bipolar, chances of TUR syndrome is less. Okay. And what about bladder stone? What are the routes? One, you told me that you can do open cystolithotomy. Another, you can do percutaneous suprapubic cystolithotripsy. And why not by transurethral route?
Since this patient has a large median lobe, so it is likely that we will not be able to reach the bladder stone.
Okay. Then you, whether you will deal with bladder stone first or with prostate first, if you are going by transurethral route in this case?
So we'll have to do a TURP first and then handle the bladder stone.
Okay. Normally you do go for bladder stone first.
Bladder stone.
Why you go for bladder stone? Normally, why you go for bladder stone first and then TURP?
Sir, once TURP is done, then the field will be all hemorrhagic and the stone couldn't be cleared up easily, sir.
Okay. So, result-wise, which has got the better result? By transurethral route, complete removal of a stone, or by percutaneous suprapubic root?
Percutaneous.
There are three terms: cystolithotomy, cystolithotripsy, and cystolithopaxy. Can you define all these terms?
Excuse me, sir. Last 10 minutes for this case, sir.
Okay.
Sir, cystolithopaxy is a removal of intact stone, sir.
No. Cystolithotomy is removal of intact stone. And what about cystolithotripsy and cystolithopaxy?
Cystolithopaxy is just without fragmenting it, sir. You have to remove it. Whereas if you fragment with energy,
cystolithotripsy is fragmenting the stones by newer energy sources.
Yes.
And cystolithopaxy is fragmenting the stones with the help of mechanical energy, mechanical lithotrite, by crushing or things like that. These are all in the Campbell. So have you heard about the Jack stone calculus?
Yes.
What is the why it is called Jack stone calculus? What is its characteristic?
It will be having a spike, sir, like jackfruit.
Yes, it is irregular spiny surface it has got. And what is its composition?
Ammonium urate.
No. It is calcium oxalate dihydrate. So it can be easily fragmented by newer energy sources. What are the, suppose patient wants medical management along with cystolithotomy. Is it possible?
Yes. Yes, sir. Yes,
you
sir.
remove the bladder stone and put the patient on medical management?
Yes.
Yes.
Alpha blocker with 5-alpha reductase. We can.
Is it possible in this case?
But median lobe is large, sir.
Yes.
So
likely to fail.
So likely to fail. Is there any role of ESWL in cases of bladder stones?
No.
Yes, you can do in augmented bladders or neobladders or patient on external urinary sphincters, artificial urinary sphincters. You can go for ESWL. It is all in the literature, but what are the results? We do not know actually, because they are all personal small series. So it is a case of BPH with bladder stone, for which you will go for TURP either by bipolar or monopolar route, and you will do the remove the stone either by open or by suprapubic route. Better by suprapubic route, percutaneous route. What can you describe the procedure of percutaneous suprapubic lithotripsy? Anybody? What are the steps?
Sir, first we do the cystoscopy and bladder is distended.
Okay.
And once the bladder is well distended, then we will with the needle do a suprapubic puncture that is about 3 fingers above the pubic symphysis.
Okay.
And a guide wire is passed into the bladder under the vision of the scope.
Okay. Okay.
Then the track is dilated.
Okay.
Into the bladder. Okay. And we use a nephroscope.
Okay.
And the bladder stone could be broken up using pneumatic lithotripsy, sir.
Okay. And you will remove all the fragments, and
all
then put SPC, because it will also help in your next procedure, that is TURP.
Yes,
TURP. How will you follow this patient?
Sir, in the initial post-op, the patient is kept on the first we keep the patient on the catheter traction due to TURP with SPC in situ, sir.
Okay.
If post-op is unremarkable, then we can remove the SPC on the day 1 with the releasing of the traction after 24 hours.
Okay.
And if and we'll monitor the patient for 48 hours for urine output and the color of the urine. And if it is uneventful, then we can go for the catheter removal after 3 to 4 days, sir.
Okay. And what instructions will you give to the patient in the immediate post-op period? After catheter removal, when he goes home?
Patient should not strain, sir.
Okay. Strain during?
During voiding and during passing stools, he shouldn't strain.
Yes. And
should be
and anything else? He should not take alcohol. He should avoid sexual relationship, intercourse. So all these things you must tell your patients to avoid hemorrhage in the immediate post-op period, hematuria in the post-op period. And again, in the long-term follow-up, what will you look for? What are the complications of TURP? Uroflowmetry will do to have a look at the. And what about the stones?
Ultrasound, sir.
Why to do ultrasound for stones?
Uroflowmetry.
In the immediate post-op, you can follow up the patient by your uroflow, and if the PVR was more, if you are suspecting chronic retention, atonic, hypertonic, underactive detrusor, then you go for residual urine measurement. Otherwise, if it's passing urine with good frequency, good stream, then you can ignore ultrasound. For bladder stones, you will have to give him some advice, because this patient was having some storage symptoms. So suppose after operation, how will you follow these symptoms?
IPSS, sir.
If it is because of yes, by IPSS scoring, you can again repeat your IPSS scoring and look for whether these storage symptoms are persisting or not. How much time it takes for these symptoms to settle if it is because of obstruction? How long will you wait?
6 months to 1 year it will take, sir, for the irritative symptoms to settle down.
But if it is not settling, how will you manage them?
Sir, since the patient has already underwent an invasive procedure and the symptoms are not improving, I would like to recommend this patient for urodynamic evaluation, sir.
First, you will go for some conservative management, or straightway you will go for urodynamics? I think you should go for uroflowmetry and IPSS scoring and voiding diary and see where lies the fault. He might be taking too much of water. So by voiding diary, you can advise about his water intake, his bowel habit. You can look for. You can see whether he is taking caffeinated drinks or coffee, tea too much. So all these things, whether it is he is having sedentary habits. So all this diet, what he's taking. So all these things you have to look for and then advise accordingly. And if he does not respond to your conservative advice, you can start with the drugs first.
Medical management.
Yes, you can go for medical management if they do not respond. Which drug will you to start with?
Anticholinergic. We can start with anticholinergic.
Which anticholinergic?
Oxybutynin, sir.
Solifenacin. Tablet solifenacin.
Solifenacin also.
Yes, oxybutynin has got a side effects more than
last 1 minute for this case, sir.
So better to go for solifenacin. You can start with solifenacin and see the results. Again, follow up the patient and again look for voiding diary symptoms and see whether he's improving or not. If he's not improving, you can add
mirabegron, beta-3 agonist.
Beta-3 agonist.
It is beta. You can combine with beta-3 agonist and then look for what is the commonest side effect of mirabegron?
Hypertension and headache, sir.
Hypertension, headache, or in tachycardia you can't give if the patient is having tachycardia. So again, you follow up this case, and if these patients do not respond even to your medical management, which is very unlikely, then you can go for invasive tests such as urodynamics. Now, anything you can ask because the time is now about to finish. So you can
sir,
ask.
this patient has a stone and the BPH, sir. So,
Yes.
sir, in these patients, we have to do uroflowmetry or not, sir? Because there is already a stone present in the bladder, so uroflowmetry readings might be.
But patient is voiding. He's not on catheter. So by uroflowmetry, yes, because it has been seen that in there are many reports in the literature which says that all the stones patients with stones are not obstructive even in that age group. So okay, if the uroflow comes down to be non-obstructive, then you can go straight forward for only stone removal, not yes, for. So uroflowmetry will help you in that way for patients who are not on catheter. Any question?
Thank you very much. Thank you, sir. We'll wind up. We are short of time.
Okay,
yes.
Okay, sir. Okay. Thank you.
Thank you.
Thank you. Thank you, Rajesh sir, for this excellent discussion. Now we would be moving on to the next session on a few talks which will be coming up. I would call upon Dr. Naveen to moderate this session. Thank you, everyone.
Thank you for enlightening us, sir. So our next topic of talks will be neurogenic bladder after spinal injury, and it will be from Dr. Pawan Vasudeva, sir. So I would like to invite Dr. Pawan Vasudeva, sir.
You can hear me, Naveen?
Yes, sir. Very well.
Yes. So should I start?
Yeah. You can share your screen.
Yes, sir.
Yes. Is it sharing?
Not
yet, sir.
Now?
Yes, sir. Now it is.
Yes. Yeah, you can make a slideshow and then yes, good to go.
Oh, thank you. Good morning, everyone. First, I'd like to thank.
The time starts from now. It's 9:52 and 25 minutes.
All right, thank you. Good morning. I'd like to thank the USI, ISU, and Dr. Chawla for this opportunity. I will be speaking on neurogenic bladder after spinal cord injury. So we will briefly touch upon the neuroanatomy, physiology, and normal bladder function. We will then go on to see what is the topographic correlation and the patterns of distinction. Move on to the acute initial management, and then see what we do with them in the chronic period. So to cover this briefly, we all understand that you have higher centers in the cerebral cortex, which and then you have the pontine micturition center in the brainstem. After that, you have the outflow, which is coming from the lower thoracic and upper lumbar region, which is the sympathetic flow. You have the parasympathetic flow, which is coming from the sacral region, and the somatic outflow, which is again coming from S234 region. So during the filling phase, what is happening is that you are having, this is actually, yes. So during the filling phase, what is happening is you're having inhibitory inputs from the cerebral cortex, and the pons is sending inhibitory inputs down. So your parasympathetic outflow is silent, and your sympathetic outflow is working to make the bladder silent and the bladder neck closed. At the same time, the pudendal outflow is working to keep your external sphincter closed. So during the filling phase, you have your detrusor that is relaxed and the sphincter which is contracted. What happens during the voiding phase is that this inhibitory input finishes, the sacral, the parasympathetic outflow increases, the detrusor contracts, and at the same time, the bladder neck and the external sphincter would relax. Now, what happens with the neurogenic bladder, the kind of dysfunction would depend on the level at which this injury happens. You can have suprapontine lesions where the lesion is above the pontine micturition center. You could have it through the pons, or you could have it what we will be looking at today, which is the infrapontine lesions or the spinal cord lesions. And these could either be suprasacral, which is above the level where the S234 parasympathetic supply is, or it could involve the sacral cord. So spinal cord lesions essentially are of two kinds. One, it could be the suprasacral, where the sacral micturition center is preserved, or it could be through the sacral spinal cord or the subsacral chorda lesion. Now, what the dysfunction in neurogenic bladder can essentially be seen in two parts. One is what is happening to the bladder, and the other what is happening to the sphincter. So, if I confine myself to the spinal cord patients, these are the two classical varieties that we see, though you can see different varieties if the lesion is incomplete. In a suprasacral lesion, the bladder is overactive and the sphincter is also overactive. So the problem is that during storage, the bladder is at high pressure, the bladder is storing at high pressure, the upper tracts are at risk, and also there is reflex incontinence. And during the voiding phase, this overactive sphincter does not allow the patient to void, or the condition that we will subsequently see, what is known as DESD. Whereas if the lesion is through the sacral cord, you typically get a contractile or an underactive bladder along with a sphincter that is weak. So here the problem would be during the filling phase, this weak sphincter may allow for stress incontinence, and during the voiding phase, this bladder doesn't have the strength to empty. So it's an emptying failure with neurogenic stress incontinence in these patients, and it's a filling failure along with a voiding failure in suprasacral lesions. This is what we will be essentially seeing in detail. Now, initial urological management, we are all aware. We will the first thing to do is to put in an indwelling catheter. There is a common question which is asked as to when should you change it to an intermittent catheterization protocol, which is what is the standard. And so as early as the patient is medically stable, you should consider shifting him from an indwelling catheter to a intermittent protocol. During this period, it really does not matter what the choice of catheter that you're using, and any catheter, since it's a short duration catheterization, any catheter would essentially do. The management after this period, ideally you should be seeing these patients within the first 3 months, and we all understand that we need to take a detailed history. One important thing that you need to look in these patients is their ability to do CIC. What is their cognitive status? How is their hand function? What is their mobility? Is the person, so let's say the person is a female and the BMI is very high, so she may not be able to do an intermittent catheterization. So get an idea as to whether this patient is likely to be able to perform intermittent catheterization or no, and also look for the social support. If the patient cannot do it himself, is there a caregiver who can do intermittent catheterization or no? The level of injury should be defined. Now, this is not where the vertebrae broke. This is the lowest or the most caudal normal segment, where on both sides, right and left side of the body, both the sensory and the motor functions are normal. And this is a chart which your neurosurgeons would be filling. So you need to know the level of injury, and you also need to know whether the lesion is complete or incomplete, because that has a prognostic significance. When we say complete or incomplete, it essentially refers to one parameter, whether there is sacral sparing or no. By sacral sparing, we mean whether there is sensation, pinprick, light touch sensation in the perianal area, or if there is sensation on digital squeeze, or if the motor function in that is present, which means they're able to contract the anus when you put in a finger. So that defines whether the injury is complete or incomplete. There is an AIS scale that people would use to define the level and then the completeness of the injury. Now, investigations besides the routine investigation, the gold standard for these patients is a invasive urodynamics. And what should be the time of this baseline urodynamics? Well, it should be ideally be a video urodynamics at the end of the spinal shock phase, which would mean that for a patient who has a high cord lesion, when the BCR reflex comes back, that is the time that you would be looking at doing a baseline urodynamics. Most urologists would schedule this at about 3 months. Now, should this urodynamics be done in all people, or let's say there is a spinal cord injury patient who recovers the ability to walk? So is there any correlation between the skeletal recovery and the smooth muscle recovery? The answer is no. Both are equally at risk of having a bad or a high risk bladder, as we will define subsequently. So urodynamics should be done in all spinal cord injury patients, regardless of the skeletal recovery. We all understand what we need to look at in urodynamics, but I will go specifically to what we need to see in from a neurogenic bladder perspective. Now, during the filling phase, the bladder is supposed to be relaxed. If you get involuntary detrusor contractions, you observe them on urodynamics. They are called as detrusor overactivity. When there is a known neurological abnormality, it's called as a neurogenic detrusor overactivity, or an NDO. Now, there are 4 types of NDO that have recently been described in the paper by Kajewski. Phasic DO, we all understand. Terminal DO, we all understand, which is just prior to the voiding phase. There are 2 more terms which have been introduced. One is a sustained DO, which means the DO is not phasic, but it is more of a continuous DO which lasts for a longer duration. And the last is a compound DO. So by compound DO, we mean that even though this DO is phasic, but the general trend is upwards. So the detrusor pressure is, with each DO, the detrusor pressure is rising, and this is called as a compound DO. The other thing you need to understand in these patients is compliance, which means that as the bladder is filled, because of a property of receptive relaxation, the pressure does not rise. And if the pressure rises as the bladder is getting filled, that essentially would mean that the compliance is not that good. So this is urodynamics, where if you look at the PDET trace, as the infusion is increasing, the PDET is more or less static. And if you look at this trace, as the infusion is increasing, the PDET is increasing. So poor compliance is when the bladder is not able to maintain low pressure as the volume increases. I will come to the numbers in a bit. There are 2 other terminologies that you need to understand. One is the detrusor leak point pressure. Now, what does this detrusor leak point pressure mean? It essentially means that when the pressure is rising because of poor compliance, at one point this patient would leak. So the lowest point at which this patient leaks, in the absence of a detrusor contraction, overactivity contraction, or abdomen contraction, that is the point that pressure is called as the detrusor leak point pressure. So there is no apparent detrusor contraction, there is no apparent abdomen contraction. The other terminology which has been introduced is the detrusor overactivity leak point pressure. Now, this is different from this DLPP. Here, what we mean is when the overactivity comes, what is the lowest pressure at which this patient leaks. So DLPP is different from the NDO LPP. And we all have heard, we all know that people use this terminology of leak point pressure more than 40 risks the upper tracts. Well, this was in a population of myelomeningocele, so it may not transmit to the spinal cord population. And also there has been some recent data from the Italian group which say that a cutoff of 20 centimeters may be more sensitive from an upper tract damage point of view. Last thing which is important from an neurogenic bladder perspective is what we call as DESD, which means when the patient tried to void, the sphincter reflexly contracted. And this is seen on the video film as a dilated posterior urethra. Now, DESD is also a risk factor for upper tract damage. Now, coming to the numbers, so neurogenic detrusor overactivity, if it is of a high pressure, which means the amplitude is high, or if it is frequent or sustained. So there is a study which has shown that if the duration of DO, the time duration of DO is more than 1/3 of the time duration of cystometry, it puts the patient at high risk for an upper tract damage. If you have compound DOs or if you have a high NDO leak point pressure, all these put the upper tracts at risk. A poorly compliant bladder, and usually we take a figure of 20, would put the upper tract at risk. High end filling pressures and high detrusor leak point pressures are again risk factors. Maximum detrusor pressure more than 75 centimeters of water has been shown to be a risk factor in spinal cord patients. DST we've already spoken. Also, patients who have a capacity less than 200, they are at high risk. So the idea of doing urodynamics at this stage is to identify the subset which you may have to manage more aggressively because they have these high risk factors and their kidneys would get damaged sooner than later if you don't, if you're not proactive. There is another concept that you should understand, which is a concept of safe storage period. So if you look at these two patients, this is patient A and this is patient B. Patient B looks to be more at risk because he's generating higher pressures during the filling phase. But you have to see at what volumes is this pressure going high. So for example, in this patient 1 is doing CIC at about 230 cc, which means that this entire period from 75 cc to about 230 cc when he reaches, the bladder is storing urine at higher pressures. If you look at this patient 2, he is doing CIC at 300 cc, which is here. So even though his pressures may be going very high, but the time that he is storing urine, pressures during that time are fairly low. So this patient is more likely to be at risk of upper damage than this patient. And this is what we call as the concept of safe period of bladder storage. And this is what the therapies that we use, antimuscarinics or botulinum toxin, which we will see subsequently, this is what they aim to achieve. They aim to achieve a longer period which is safe for storage, so that within that period or within a convenient frequency, intermittent catheterization can be done. Now coming to how we manage these patients. So we spoke of suprasacral spinal cord injuries where the bladder is overactive. So during the filling phase, the upper tracts are at risk, and also you will get reflex incontinence. And during the voiding phase, the sphincter, there is a detrusor external sphincter dyssynergia. The patient will not be able to void, so you will need to do something for this as well. This is a urodynamic from a suprasacral patient that we've already gone through. Now, so there are 4 ways in these patients can be treated. Option A, you decrease the bladder pressures. You decrease the bladder pressures, the kidneys become safe, the patient may not be incontinent, and for the voiding phase, you circumvent this by introducing intermittent catheterization. The other option, so, and it is in this regard that we prescribe antimuscarinics, botulinum toxin, or the surgeries. The option B is, instead of addressing the bladder, you decrease the pressure of, you decrease the outlet pressure by doing a sphincterotomy. That reflexly decreases some amount of bladder pressure, and these patients then need a condom urinal. Option C is triggered void, option D is indwelling catheter, and we shall see all of these one by one. So oral antimuscarinics, we all understand, first line pharmacological therapy. They decrease the pressures by 30 to 40%, and they increase the capacity by 30 to 40%. Is there anything to choose in between them? Well, efficacy wise, all of them are same. but the choice of antimuscarinic may depend on its side effect profile. So if you have a patient who has let's say cognitive issues, you may want to prefer trospium or derifenacin in those patients. People have used there are a percentage who will not respond. People have used double dosage of a single drug. They've used 2 drugs with double dosages, and which are found to be fairly well tolerated in this population. But should you be using this? Well, there is now a concept of the anticholinergic burden and the impact that it may have on cognitive function, Alzheimer's, and so on. So that will have to be taken into account before you decide what you need to do with these patients. Mirabegron is still evolving. For idiopathic detrusor overactivity, it's standard. For neurogenic detrusor overactivity, there is still not enough data. We've also done one study, and overall the results say that there has been subjective improvement, but objectively people have not been able to show much on neurodynamics. So mirabegron is still evolving, and there are some people who use alpha blocker. By using an alpha blocker, the outlet resistance goes down, so the bladder pressure goes down. It is not being used to help the patient void, it is being used to help the bladder pressure to decrease. So essentially, if antimuscarinics do not work, the second line therapy is botulinum toxin. 200 units is the standard dose. And how much does this help? It improves the capacity by about 60%, decreases pressures by about 60%. So this is almost twice as what an antimuscarinic would do. The effect lasts for about 9 months, and repeat injections are as efficacious. There is no point in continuing an antimuscarinic with.
Excuse me, sir. So 5 minutes left.
All right. So we could. The next is augmentation cystoplasty. We all understand. You have clamp cystoplasty where you bivalve the bladder and put a detubularized segment. The alternatives are not well established, and they are for certain populations, which could be auto-augmentation or ureterocystoplasty. Now, the other option is what we spoke, that you decrease the outlet pressure here, and then this would go down. But these patients would then require a condom urinal. This is not a preferred option, and it's only for somebody who has a high tetraplegia and cannot do CIC, or there is no caregiver for CIC. Triggered reflex voiding is an unphysiological reflex by which people try to void, and you should avoid it for most part. Indwelling catheters, when you have no other choice, then and if you do use this, then you should prefer a suprapubic over indwelling catheter. The one thing here is that you should try to change them early so as to preempt blockage, and not change them when they get blocked, because that increases the risk of them getting urinary infections. One important point here is sometimes we put in a catheter and forget and think that their upper tracts are safe. There are enough instances and enough literature to say that in spite of an indwelling catheter, the upper tract still may be at risk. So you need to keep following them. Coming to sacral injuries, again, the problem is of bladder emptying or of urogenic stress incontinence. Now, bladder emptying by Valsalva or Creed maneuver is not physiological. Whenever you get pressure, whenever you apply pressure here, that pressure also gets transmitted to the membranous urethra to contract this. So essentially, this is the kind of figure you would get, that you do get dye into the posterior urethra, but then there is a cutoff. So this, you are yourself creating a functional obstruction, and the pelvic floor gets stressed. So these patients are already at risk of incontinence, and if you let them do this maneuver, this will worsen, and they can also get prolapse, hemorrhoids, and hernias. So the way to go is intermittent catheterization. By intermittent catheterization, you have what we follow here, which is clean catheterize. We reuse our catheters. In Europe, what is standard is aseptic catheterization, which means that they use a single catheter every time with no touch technique, and sterile is basically reserved for the theater. There is no evidence that sterile or aseptic is aseptic is better than clean. There is no evidence that single use is worse than multiple use is worse than single. there is no evidence that any catheter material is better. What is important is education. Tell them about hand cleaning, meatus cleaning, catheter cleaning, lubrication, gentle handling, atraumatic catheterization. Ideally, they should be doing 4 to 6 times the frequency, and sometimes to aid complete emptying, sometimes there are people who would add Valsalva when they're pulling the CIC catheter out. Now, one important thing here is that even though we feel that these are now acontractile bladders and all they need to do is CIC all their lives, up to 50% patients over a period of time will develop poor compliance. So this was the patient. So let's say this is a patient with sacral spinal cord injury. It is very possible that after a year or two, this is his picture. So please do not forget about them after you put them on CIC, because a significant numbers will develop poor compliance, and then they will require same therapy as what we use for sacral, suprasacral cords, which is either antimuscarinic, botulinum toxin, or augmentation. Mirabegron.
The last 1 minute, sir.
Just finish. Mirabegron in this population works better than it works for the NDOA population. So this would be my second last slide, I think. So neurogenic stress incontinence in these patients, well, bulking agents don't work for the neurogenic population. So it's either a pubovaginal autologous sling for the woman or a AUS for the male. Now, how do you follow neurogenic bladder patients? A repeat study at 6 to 12. So you did your first study at 3 months. You must do your study again at 6 to 12 months. So 2 times in the first year, and then ideally you should do it yearly, or in some cases where you feel that the bladder is safe, you could do it once in 2 years. Thank you.
Thank you, Pawan. Thank you very much.
Thank you very much, sir, for enlightening us. Our next topic of discussion will be lower tract armamentarium by Dr. R.G. Yadav, sir, and candidates here will be Dr. Rohan and Dr. Ravi Tawari, sir. Sir, Dr. R.G. Yadav, sir. Good morning, sir.
Very, very good morning. Hi, Pawan Vasudev.
Sir, good morning.
Very good morning. How are you?
Very well, sir. How are you?
Very nice lecture today.
Thank you, sir.
Sir, we can start, sir.
Oh yes, we can start. We'll be discussing the lower tract armatorium. Now, yes. I'm not able to see the candidates.
Dr. Ravi Tawari and Dr. Rohan Sharma, please join. And sir, time limit will be 25 minutes.
Project करो एक सेकंड बस हो गया are you able to see the slides?
But slide is empty. There's nothing written there. Can you run one more slide and then we can have a look?
Okay, okay. Just wait for a few seconds only. Now you are able to see this. Please identify this thing.
Not yet, sir. Not yet. You have, sir, what you have to do is you have to open the presentation first, then go to screen share, and then click on the slide, and then make a slideshow.
Are you able to, now, are you able to see?
No, sir.
Now I explain you. This is a filiform. Now you are able to see?
Not yet,
No,
sir.
Now you able to see?
Not yet, sir. What you can do, first you can do stop sharing, keep your PowerPoint presentation open, then go to that, share it, and then start.
Okay. जूम का वो बताना एक बार पासवर्ड आईडी आईडी है 8 नहीं यूजर नेम पासवर्ड आईडी बताओ वो तो नहीं है
Any problem, sir?
Just wait, I'm logging in because here is a network problem. Okay. Now it's okay now.
Yes, yes.
Now you are able to see.
Yeah, sir. Make
now
it
identify what is. Pardon?
Make it full screen, sir. Okay, fine, sir. Go ahead, sir.
Okay. Now you identify this structure.
This is a filiform.
Your time starts from now. It's 10:23 and now 25 minutes.
What is this? You see the metallic part. What is this?
This is opening to pass the guide wire, sir.
Not the guide wire. You can put the filiform with the followers. The name of that follower is filiform follower, or other name is Phillips catheter. Or you can screw it with the Otis urethrotom. And then, if you are not able to pass, then put the filiform with follower for 24 to 48 hours, and then you can follow and put the little larger size of catheter. Now, what is this?
This is Otis urethrotom.
What is the other name of this instrument?
Mormeyer's urethrotom. Otis Mormeyer.
Mormeyer's urethrotom. It is a blind, or you can Visually
it is blind.
Blind, sir.
Blind. Okay. Now, what are these? If you remove these screw, then what you can put on it? You can put the over the filiform and follow this and do the internal urethrotomy. Before what are the size of the filiforms which are available? They are available from 3 to 5
15 to 40.
French size. Use a smaller size of the filiform. Put 3-4 filiform with adequate lubrication, so that and then gently manipulate it. If once you will gently manipulate, one of the filly will go to the natural passes. Otherwise, it will never follow. If you have created the false spaces, one of the filly will stuck in this in the false spaces, and that will block that false spaces. Now, these are the different notes which you can put in front of the Otis urethrotom. Now, what is this?
This is Sash's
Optical
urethrotom.
Optical urethrotom.
Sash's urethrotom sheath. Now, how will you differentiate it from the cystoscopic sheath?
Sir, it has an marking from the beginning.
Beginning to the from the proximal to the distal end. The marking.
There is a marking. What is the size of this sheath?
21
French.
What, pardon?
21 French.
And what is this mark written in just below the sheath?
We can pass 5 French ureteric
5 French means
catheter.
this is the working channel.
Working channel.
Yes.
Okay, you can put 5 French catheter, but 5 French catheter is of a large size because we are dealing with a stricture. You always try to put a 3 French ureteric catheter or the guide wire, so that while doing the optical urethrotomy, you will never miss this the normal tract. Suppose you have put the blade and you have entered in the false spaces, then you will not be able to see anything. But if you are in the if your guide wire or ureteric catheter, small size ureteric catheter is in place, you will never miss the tract. And now what is this?
This is the working element.
Thumb operated
This is a
working element.
receptoscope. You can use urethrotom also. It is it active or passive?
It is passive, sir.
Very good, very good. Now what is this? Yeah, you will be appearing in MC's final examination. This is the most frequent instrument used in the urology.
Metal sound, sir.
Huh?
So I'm not able to see the complete picture, sir.
It is a stellate. You can, what is the other name of this stellate? Introducer. What is the other name of this introducer? Is a mandarin. These are the 3 different names. Now, what precautions we are frequently using this stellate after doing TUR or when you have a multiple hospitals and you want to put the urethral catheter. Now, what precaution you have never seen this?
To introduce Foley's over it.
What should be the basic principle before putting it on the Foley catheter?
We should not cut the tip of the Foley's.
Number 2, which is more never cut the tip. And the other important thing, you must
enter
lubricate
inside.
it. You must lubricate it. Put 2-3 ml of jelly lubricant in the Foley's catheter, and then it passes. And the basic principle, because you are not able to put the catheter, you want to make that catheter stiff. Now what is this?
This is
outer sheath.
outer sheath of TURP.
TUR.
Outer sheath. Then what is this?
So this is the outer sheath. The previous one was the inner one. The outer sheath has these fenestrations for outflow.
Yes, yes. So that there will be outer. You can name it as the VSs. So that there is a continuous flow of fluid, irrigating fluid. Now you tell me, what is the size of this sheath?
24 to
24 French.
24 or 26, sir, because of the yellow color coding.
The 24 is inner sheath and the 26 is the outer sheath. Now the basic principle, this knob, the inflow should always be keep up, and you must match 0-0. So the outflow is on downward trends toward the bucket. Now this is it. Identify this, the telescope.
And
telescope and working element.
Yes, what is the view of this telescope? Is having the red marking.
So 30 degrees, sir.
30 degrees.
30 degrees. What are the indications where you use the? This is Hopkins 1 or Hopkins 2. Now you tell me, yes, gentlemen, tell me the difference between Hopkins 1 and Hopkins 2 telescope. This is Hopkins 2 telescope, which have a brighter illumination, more wider angle. It can be autoclavable, more vision, more wider vision. You can see the things which are able. You will be able to see with the telescope. Now, what is this resectoscope? It is active or passive?
Passive. It's an active, sir.
Active. How can you say this is a thumb operated?
Oh, sorry. It is a passive, sir. Thumb
Passive.
operated. Passive.
What is the difference between active and passive resectoscope?
Sir, in the passive electrode, the cutting happens when the loop is coming backwards, and when the
yes, repeat.
With
when
sir, the spring action in the spring action, sir, in the active working element, the loop is in vision. So
no, loop is in the bladder, and you can see the loop.
Yes, sir. That is, it is in vision, and while your thumb movement controls the movement of the loop, sir. That is in the active one, sir. In the passive one, the loop is not in vision. It is brought into the vision with your thumb, and with the retraction, the spring action of the working element, it passively cuts the.
Now you tell me for the beginner, the active mode is preferable or passive mode resectoscope is preferable?
The passive is preferable, sir.
Why? The active, you
know,
have a faster resection, whereas in the passive is a slower resection. And what are the other advantages you can add by using the passive receptoscope.
In active, sir, the loop is always outside, so surgeon has to take care. It does not damages the other structure, and the cutting is not controlled. It can get a deep cut while doing the resections. In passive, the cutting is controlled, and the loop is always inside the system.
Okay.
So
Okay.
you
Now
don't have
this passive you are using routinely in optical ureterotomy.
Yes.
Passive is always used in optical ureterotomy. Now, basic principle when you are doing the optical ureterotomy, you should make it slower cut, 2 mm or 3 mm cuts, so that you can cut, and when up to what margin you will cut. Up to what
Sir,
margin you will cut
excuse me, sir. Background sound is coming from somewhere. It is.
No, I'm sitting in my chamber, so there is no question of a backside sound.
Okay, good, sir. Good.
It must be from your end.
Navneet, can
I'm
you
in
check
my
from where
chamber
it is?
and my chamber is closed.
Navneet?
Now you tell me what is the principle when you are doing optical ureterotomy, how deep you should cut. When you will see that the fibrous tissue is cut completely, how will you identify?
Bleeding will be there, sir.
No, bleeding means you have entered in the corpora. There should be fine capillary oozings. It means you have cut the complete the fibrous tissue. That's why we give the cut between the two corpora in that at 12 o'clock. Now identify these structures. These are different types of loops.
Sir, one
is the loop, one is the
Collins,
cutting knife, and other is the roller ball, sir.
Roller ball.
Now, what is what is thick loop? What
thick
is the
loop
diameter of the wire?
0.45 mm.
Oh yes, 0.4 is okay. But if it is a thin, what is the advantage of thin loop over the thick loop?
Sir, more precise cutting will happen because current would be transmitted better. Sir.
Yes, very good. When there is a thin loop, you can do very precise cutting. But if there is a thick loop, you can do the better coagulation. Okay. What is the second structure? That is Collins knife.
Collins knife.
Yes, Collins knife. Now, where it should be used?
Bladder neck incisions.
Bladder neck incision.
Bladder neck incision. What precaution you will take doing bladder neck incision? It should be purely on cutting, not coagulation. Give at 5 and 7 o'clock. Now, what is the third one?
Roller ball.
Where it is to be used?
At the end of TURP surgery to fulgurate all the bleeders.
Why there should be fulguration? You know the fulguration means only the arterial spatters can be nicely coagulated. The venous coagulation oozing will be automatically finished and will be stopped within 3 to 4 hours after putting Foley's catheter. Or there will be the tamponade defect once you put the Foley's catheter. And put a little bit traction. Then this is used to coagulate the prostatic fossa. Now, what is this? What is this? Have you seen it?
Don't know. No, sir.
No.
most frequently used in the lower. This is a loop protector. Loop protector. You can keep your optical blade, your Collins knife, your QRT loops. You can put in the and take it out. Wash the loop with saline. What is this?
Helix evacuator.
Now, tell me the different parts of the helix evacuator. This is the bulb.
The red one is the pump. This yellow one is the outflow.
Outflow is a connecting tube. This is
connecting tube.
This is steel. The steel structure is a adapter. Now, how it is a very good helix evacuator. There are two types of helix evacuator. One is of a glass type, glass bottle type, which is filled. But to fill this helix evacuator is a little bit tricky. It experience you, but it has a very good suction capability. Okay.
Yes, sir.
Its use is to remove the prosthetic chips and to the blood and the blood clots. Now, what is this?
This is Tomy syringe.
Oh, what is this? The steel part. This is the adapter, and this is nozzle. Where this adapter is used?
In Foley's catheter.
So, bridge of
Yes, very good. You have to put this in the Foley's catheter, connect it with the Tomy syringe, and then give a negative pressure. So the clots will be removed. Okay. And when you have the TUR sheath inside the bladder, you can put this directly, this Tomy syringe, and you can remove the clots or prosthetic tissue chips. Now you tell me one thing. What are the different types of optical blades?
One is the straight
you
blade.
have done the, yes, very good. That is our name is sashes blade.
Sir, one
Then
is the half moon blade, sir.
That is where it is to be used and what precaution you should take.
Sir, it is used in bladder neck stenosis.
Yes.
And it cuts while it is going in and coming out, sir.
To and fro. Gentleman, this is coming in front of your view, so you will not be able to see. Once you are in the prostatic urethra near the disease segment, then you put this half moon blade and then give a to and fro motion and then give the cuts. But right from the beginning, you should not do. Now, what is the third type of the blade?
Serrated blade, sir.
What the name of the serrated blade is?
Ludwig's. Ludwig's blade.
Ludwig's. Where it is to be used?
In dense urethral strictures. If it is not being easily cut by the straight.
Very good. Now you tell me the different types of obturators we use in the doing the TUR. Now you tell me what is the 17 20 French cystoscopic obturator and 24 sheath size obturator. The difference between these two obturators.
4 to 5 minutes left only.
Okay, okay.
There are 20.
In the cystoscopic obturators, you have the ridges. these ridges are used for irrigation purposes. And in when you are doing the putting the receptoscope sheet, they are either the visual obturators. The visual obturator, when you are passing the instrument in the direct vision. Then there is a obturator that is called as Timberlake. When you are passing the instrument blindly, and it is useful when there is a large high bloodedness or large median low. Okay?
Yes, sir.
Now, any questions you have? Dr. Chawla, I think I have finished the...
Excellent, sir. Lovely case discussion, lovely discussion of instruments, sir. Yes. Any question from the residents?
Yes, sir.
Sir, minimum diameter to pass an Otis urethrotom?
Yes, very good question. Since the optical urethrotomy sheet size is 21, before that, the smaller size, more damage you will going to give the external meatus and the fossa naviculars. So you will be making worse. So before you must identify see the size of the external meatus, calibrate it with the meatal dilator, and make sure that you have reached to the adequate size. 21 plus 2, yani 23, up to 23, you must dilate the external meatus. For example, the Otis urethrotom, the size of the shaft is the instrument is 14 French. But the basic criteria that you should have a urethral caliber of 16 French. So you can you should add to in previous years when we did MCs very long back. It is in routine to do the internal urethrotomy so that we can pass the 28 receptoscope sheet. Our next question. Any question?
Yeah, thank you very much, sir. I think we'll wind up now. They have no more questions, sir. Thank you very much, sir. Thank you.
Okay.
Thank you, Dr.
Thank you so much. Thank you so much, Dr. Chawla. Okay, okay, Dr. Chawla.
Thank you, sir. Thank you very much.
Thank you very much, sir. Hello.
Yeah, go ahead.
Thank you very much, sir. It was really a very informative session. Heading to yet another such session, I would like to invite Dr. Sujata, who will be the chairperson for the first case of the next session. And I would like to request ma'am to share her screen and start proceeding. The participant for the first case will be Rohit Kapoor, Dr. S. Reddy, Dr. Sagar, and Dr. Samarth Patel. And time for the case will be 40 minutes.
Hi, good morning. I think Dr. Chawla will be helping me by.
Yeah.
Good morning.
Please tell me whenever you want me to move the slides. Yeah. Okay, ma'am.
Yeah, sure. Yeah. Okay. So we can
Are
start with the first.
Is everybody seeing the screen?
I would like to know the name of who is answering.
Ma'am, 4 people
Rohit
are there.
Kapoor.
Rohit Kapoor, Dr. S. Reddy, Dr. Sagar, and Dr. Samarth Patel.
Okay. Yeah.
Oh, thank you.
So we can start. Yeah.
Okay.
So Samarth, the first slide for you is a 35-year-old male who married and 2 children, and he is presenting with increased frequency, which is 8 to 10 times in the last 6 months. Nocturia is 4 to 5 times, urgency and dysuria. In additional, there is flank pain on the right side and weight loss and loss of appetite. So tell me your thoughts on these symptoms.
Am I audible, ma'am?
Yes, yes, you are.
Okay, so the patient is a young male who is mainly presenting with storage LUTs. I would like to document this further with a bladder diary. And moreover, I'd
Okay.
like to ask him other relevant histories, like whether he's having any history of back trauma or spinal injury or spinal surgeries, whether he's having any comorbidities, whether he's
Yeah.
having any fever.
Okay. What else? So see, just because we are short of time, the increased frequency, nocturia, urgency, all are storage symptoms, yes? But so
Yes, ma'am.
storage symptoms associated with right flank pain and weight loss.
Yes.
So we are trying to give you in a nutshell, what would these symptoms together indicate?
I'm a urinary tract infection.
Most likely, it would indicate a genitourinary tuberculosis, ma'am.
No, they indicate some sort of irritation going on in the lower tract associated with upper tract symptoms also, right?
Okay. Yes.
So, the irritative symptoms in the lower tract, what are they related to? Your answer is right, infection. Secondly, you thought in terms of some, I think, neurogenic element because you were asking for spinal trauma and all those things.
Yes, ma'am.
So yeah, that's also right. What else can it indicate?
It could indicate a bladder stone.
Bladder caliculi.
Yes,
Bladder
it
stone.
would indicate a bladder calculus. Very good. Yes.
It
And
could
what
indicate
else?
a CIS or a malignancy of the bladder.
And
yeah, but he's
And
34
there's a
years
right
old.
associated flank pain. It would be an associated upper tract infection as well in the right side. We can think
Yes,
about.
you're right. So see, this is the way your thinking is right. This is the way it should go on. Or
And
it
this
could be a small capacity bladder. Yeah.
Yes.
Small capacity bladder
Yes,
due to various causes. That's why he's having all these issues. Or he could be having obstruction of the lower tract. I mean the genital tract, the penis or the urethra or the bladder neck or whatever, right?
Yes, ma'am.
Okay, so these are the things which are coming to our mind after seeing all this. Now, if we add weight loss and loss of appetite to these symptoms, then how do you narrow down?
Two things
A
can be
young
there.
male
Either
with constitutional
malignancy can be.
symptoms, ma'am, most likely it would indicate the presence of tuberculosis in this case.
Okay, tuberculosis is one. Now, somebody said malignancy. Now, which malignancy is common at the age of 34?
TCCs can be suspected in such case since an upper flank pain is also there. So obstruction can be
No,
suspected
I'm
in the.
asking you a specific question. Which malignancies are common at the age of 34 or around the 30s? Plus, he has right flank pain. So we are thinking in terms of even it could be a renal problem. Testicular, okay, but yeah, it could be possible. Anything else? Familial RCCs, right? Yeah, I'm getting these answers on the screen, right? You also need to tell me something. Adult swims is also right. Something more? Renal, what else apart from familial?
Adenocarcinomas at this age.
Which renal tumors are common at in a younger age? Okay, so that's food for thought, or I may tell you the answer at the end. Okay, so we are associating symptom of weight loss and appetite with this. So you need to think in terms of now some chronic infection or chronic malignancy or something going on chronically in the bladder. So now this negative history comes up of no urge incontinence, hematuria, poor stream, fever. So in addition to what is shown on the screen, which is the most important symptom you feel you should ask?
Fever, associated fever that was there. Then that kind of fever that's coming.
Okay, yeah. You need to quantify if it is a long case. What else? So you have to ask for the sinister symptoms, like which are most important because they will guide you like as to what's happening. Is there gross hematuria?
The kind of pain that
Is
is
there
present in
fever?
the patient.
Yeah, is the patient presenting with some sort of features of chronic renal failure? Okay, because it's involving the upper and the lower tract, though it is involving only. So these symptoms are more important. Yes, you need to quantify, you need to look about the fever, you need to ask what sort of fever it is and all. Okay. So I hope this negative history slide you would keep in mind. It's important that in an exam you ask the important things first. Okay. So now we are going ahead with his medical history and personal history. Anything in this medical history you would ask? Can we not go to the next slide, please? Otherwise, there's no chance for them to think. I'll tell you when to change, please. So anyway, now that the slide is visible, you must ask for the history of tuberculosis because that had come to our mind, right?
Yes, yes, ma'am.
Yeah. Okay. What else do you want to know before we conclude the presenting symptoms and everything?
There's no history of trauma, no history of previous any instrumentation. He's not on any medication right now.
Right. So medication, surgical history, medical history is very important because we don't know what's going on in this person's life. Anything in childhood you feel it is necessary to ask?
Any history of previous tuberculosis mentioned?
Tuberculosis, okay, but he's 32,
it's already
right? So
mentioned.
childhood, yeah. Anything else? Can this be a presentation of an adult posterolateral valve? Could be, right?
Yes.
Could be. It could be a PUJ obstruction with a bladder stone, right? Like you need to think like, yeah, this is a bit remote, but yes. Okay, so from your presenting history and past history, what do you feel? What are your provisional diagnoses?
Again, since there's no history of any fever with chills and rigors, so our first would go towards the chronic infection itself. So first would be a genital urinary tuberculosis that we'll keep. Then second, since hematuria and all is not present, so we can in a way keep malignancy towards the lower end. Then since storage symptoms are present and associated calculus in the bladder, which might be causing a recurrent symptoms can be considered with an upper, upper we'll have to go again for a right flank pain with any, as you said, ma'am, as a PUJ obstruction that might be present concurrently with it.
So just to probe you more about this congenital anomalies presenting in the same way. Anything more you can tell me, one or two? Stretch your imagination. Yes, uretrocele, I agree. So it could be a uretrocele, which itself causes lower urinary tract symptoms like frequency, urgency, and all those stuff which was there in the first slide. And yet it can end up in flank pain. Okay, yeah. So I think there's good participation online by the messages. Please do continue it. So yeah, these are the presumptive diagnosis. I agree with you. So what would be your, what would you like to see on examination? Please don't show him the slide.
Local examination would be important. Should examine the genitals, ma'am, first, and DRE would be helpful. Suspecting UTB.
How in your diagnosis is tuberculosis? How you think DRE is useful and genital examination is useful?
If it involves the seminal vesicles, then there could be hardening.
Isn't that rare? Have you ever seen, have you ever palpated a seminal vesicle with tuberculosis?
Very rare, very rare.
Ma'am, we'd go from the abdominal examination and the general examination for any lymph nodes. On the abdominal examination, since there is presence of right flank pain, we'd look if there's any lump present, which would point, or renal angle fullness, if it's there at that point. In local examination, we'd like to look first at the glans and at the penile skin if it's there. If the preputial skin has any phimosis, which might lead to recurrent infections. Then in the scrotal and testicular examination, we'd look for the beading of vas if it's present and any other testicular changes that are there. And then we can move towards a DRE to look for other forms.
Yeah. So I would like to just make one more point. I agree with you. You said it quite well. only one more thing is genital involvement in tuberculosis is pretty late, or it is pretty uncommon. The urinary part is more common. And unless the genital part is actually involved, we may hardly find any signs. If we are thinking in terms of tuberculosis, but we need to think in terms of some neurogenic oblique non-neurogenic affections of the bladder. So you need to look out for those signs also. In addition, you need to you also thought of malignancy, so a lump and all those things are in place, looking for varicocele. Okay, but it's pretty fine. Your answer was fine. So can we show them the slide, please? So examination was normal. There's nothing to be noted in it. Yeah, next slide, please. So, okay, wait. Investigations. Okay, you wanted a frequency volume chart. Who wanted it? Yes, so whosoever wanted the frequency volume chart, here it is. So tell me its inference. Come on, we are less time. Yeah? No answers?
I intake with a...
Ma'am, from the frequency volume chart, we can infer that the average void volume is 200 ml. I think the maximum voided volume is also 200 ml, apart from one instance in which a 400 ml volume has been documented. So it seems that the patient is having more or less a fixed voided volume of around 200 ml with increased frequency, and a nighttime void of average 6 to 8 times in the nighttime he's voiding.
Yeah.
And he's
so
not
now
having
what
any.
is the collective inference of all these findings?
Ma'am, it seems to be a small capacity bladder with fixed urine voids and a functional capacity around 200 ml.
Okay. Yeah, I think that's all we can. It's something not very gross also, that it's not 50 and 60 ml. That's also, you need to keep it in mind. And he has at times voided 400 ml. So it could be that he has an adequate or just an average capacity. Can you show the next slide, please? Hello. Yeah. So
slide is on, ma'am.
Yeah. So it gives us a bit of the pattern of urination and details. Yeah. Okay. Can we proceed? Okay. Wait. Like, what investigation would you like now, apart from frequency and volume chart?
I'm a routine urine investigation along with urine.
Ultrasound, ma'am, first.
Urine for
ultrasound.
First a urine examination, a routine urine with a culture if it's present, to rule out any sterile pyuria or any other infection if it's present with the patient.
So what other infections are present in tuberculosis?
Right now, just a urine examination would show us if it's a sterile pyuria. Then
No,
we can
I'm
go
asking
towards.
you a question. Suppose the patient has tuberculosis. So one of the spectrum is sterile pyuria. What is the other spectrum?
Superadded infections that might be there in it, which are
by which organism?
E. coli.
E. coli usually.
Okay. Yeah, E. coli. Okay. So urine routine, definitely yes. It would look at hematuria. Is microscopic hematuria part of tuberculosis?
Yes, ma'am.
Yes, ma'am.
Yes.
How many percent?
50%.
Okay, you're roundabout right, maybe 30%.
Into 30%.
So this tuberculosis is showing pyuria and no RBCs, no bacteria. You'd immediately ask for a culture.
Ma'am, a culture along
How
with the
would you
urine for AFBs, since they're sterile.
But you are not sure only at looking at the history and urine routine micro that this is tuberculosis, and you would like to make the person spend for AFB 5 days sample.
No, ma'am, culture along with the First, we'd
But
go for a
maybe
culture
I
if
think,
it comes out negative.
yeah,
Okay.
because not necessarily that we are all thinking only of tuberculosis, but is it necessary to order all the tests for tuberculosis at the initial point? I
No,
don't
ma'am,
think
not
so.
initially.
Yeah, unless you get an inkling of the diagnosis. So maybe you have an ultrasound, or maybe you have his past X-rays or something, or you very strongly suspect tuberculosis because he had taken AKT or something like that. So because these tests are expensive and the yield is also low, like AFB doing it for 5 days would be costing the patient some $1,500, right? So before ordering it, I think you have to think a bit. So can we show him the culture report? So there is no growth. So what does this indicate? Only tuberculosis?
If the patient is on antibiotics from before, then it might report a sterile pyorrhea because of the action of antibiotics.
Okay, what else?
And sterile pyorrhea can also be seen in other conditions like stones or malignancies or any fungal infections. Chlamydial infections all
So
can
still
possibly
we
lead
have
to
no
sterile.
inkling as to what's happening. It could be
Yes.
anything of this, right? Yeah.
Yes, ma'am.
Okay, what investigations do you want now?
Now ultrasound KOB to begin with.
Why KUB? You don't want to know whether he has other problems?
Can consider a whole abdomen ultrasound.
You can consider because this is something going on for a long time and it is pretty worrisome. You don't know, no? Especially in a female, if suppose the same person was a female, then, and you are still suspecting tuberculosis, won't it give you more information happening in the genitals and elsewhere? There are abdominal lymph nodes and so many things to notice, right?
Yes, ma'am.
So we don't, not necessarily, okay, but it's not a major point of debate. Can we show them the ultrasound, please?
You have few slides, ma'am, related to teaching side related to urine. Would you like to show them, or shall I go straight away to ultrasound?
Oh, yeah. Okay, yeah. You can show them. In the end, I will give you my resident's email address in case you want this presentation. We can send it to you personally. But yeah, these in general, these are a few slides about urine sample collection, how to collect and storage and transport, and few things which are commonly asked in exams. But I won't dwell and read them out to you. Okay. Only one thing I need to emphasize, that if you are suspecting genitourinary tuberculosis and if you have an access to collect a sample directly, like an aspirated urine sample from the kidney or from the testes or from the or whatever structure which is dilated, or there is an possibility of collecting a ureteric wash sample or a tissue sample. Okay, these will give a better yield for tuberculosis than normal urine sample. So this point has to go into your mind. Can we go to the next slide?
Shall I go ahead, ma'am?
Yes. So like these are the questions we would ask you if maybe somewhere in the course of time, what are the advantages of a culture, means a tuberculosis culture, what are the types of tuberculosis culture, and so maybe you want, I can send you all the slides on email, but yeah, I think these would be the questions which are asked. So okay, we are showing you the lab investigations. So his RBS is 88, his hemoglobin is on the lower side, his ESR is pretty high. But still, we cannot say that this is tuberculosis as of now. Can somebody read the ultrasound as he's showing you?
There's a ultrasound KUB showing hydronephrosis of dilated calyces with a dilated pelvis in the right kidney, along with a thickened bladder with a normal left kidney width.
So what does hydronephrosis mean to you with a thickened bladder?
Ma'am, one is that there might be a thickened bladder because of the infection. There might be a reflux going. We can't see the ureter in the right kidney. So if there's no dilated ureter just up till pelvis, then we can go for a PUJ in the right side. There might be because of the chronic infection. There's no visible calculus or any other mass in the bladder. So it is showing that there is a thickened bladder with probably secondary multiple infections, which might point towards an outlet obstruction.
Yeah, I agree with you. Any specific observation about the tube of the hydronephrosis?
Till pelvis.
What is striking?
The dilatation is only up till pelvis.
Yes.
And no dilated ureter is seen apart from that. And there
No,
is
I'm not talking about the ureter. I'm asking you about the hydronephrosis.
Ma'am, on the right side, the upper callicial dilatation does not seem to have a communication with the rest of the pelvic callicial system on this scan.
Yes.
However, since it is a static film, we cannot comment whether or not
that I agree. See, these are all our limitations of online things. You can't see it, and plus the films may not be good. Everything is okay. I just few observations. Can you notice that the pelvis is not dilated in relation to the calyces? The calyces are dilated much more in relation to the pelvis. We are comparing two things, right? There is thickening of the urothelium of this system, both in the pelvis and in the calyces. The upper calyx doesn't seem to be exactly draining into the pelvis, but okay, that can be some variation, operator dependent, all such things. So maybe that part you ignore, but 2 or 3 observations are important. So how do you correlate now? Now coming back to our diagnosis, now we have got an upper tract which is dilated, the ureter which is either not seen or not dilated, and we have thickened bladder. So tell me the differential.
Outlet obstruction with a secondary right side upper tract pathology, which might be a pelvic outlet obstruction. It's present.
Okay, possible, but that would, if it is only a plain pelvic outlet obstruction, what should be the difference? The pelvis also needs to be dilated, right? If it is a benign, if it is a chronic obstruction going out without inflammation, without infection, then the pelvis also needs to be dilated. Maybe the ureter also would be dilated. Okay, yes, but it's a possibility. Next.
It could be a case of infravesical obstruction as well, where the outlet is the primary pathology, and since the bladder wall is thickened so much, it is causing back pressure changes as well as obstructive changes to the upper tracts.
At the age of 34, what are the possibilities of outlet obstruction?
The most likely reason would be a urethral stricture, but the patient is not having any symptoms of voiding LUTs.
Okay, not buying much into it. Anything else?
Neurological cause causing a bladder neck. A functional bladder neck obstruction in a young male is common, which might be an outlet obstruction.
What is it called? What is it called? What is it called? Okay, one more differential to it. Primary bladder neck obstruction, right?
Primary bladder neck obstruction.
It's called primary bladder neck obstruction. What else is it? Is it called? That would mainly reflect bilaterally, not necessarily unilaterally. Okay, anything else? Can it still be a PU1? Could be, no? They are not showing you the bladder neck
posterior
films.
urethra we've not seen.
Yeah, adult presentation. Okay. Then coming to your, because there is no calculus seen, are you ruling out certain things? Okay, I think maybe we will not reach the end otherwise, so we'll proceed. So after ultrasound, you have got a fair inkling that something is wrong with the upper tract on the right side and the bladder. So what investigation would you like now? Creat is normal.
Ma'am, 15 minutes left for the day.
Yeah. I'll keep that in mind.
Ma'am, to rule out any outlet obstruction,
So
we can
tell me
go
one.
for. Now, pre-void, post-void is something that we've not got on a USG right now, just to rule it out. That if it's a significant post-void residue, then
Okay,
we
can
can.
you tell them the pre-void and post-void? See, I just mentioned a few
Okay,
causes
post-void
of
10,
thickened
sorry.
bladder wall. That's just for you to remember that you can read. Yeah. Post-void, can we tell them the post-void?
It's 10, 150 and 10, not significant.
Okay, yeah. So now, okay, so on an ultrasound, we can't make a diagnosis. Anyways, it's only giving a direction to your further investigation. So now you tell me, what investigation would you like?
I can think about a uroflowmetry to
At
know
this
about the
point in time,
stream.
you would
We
like
can
to...
get at pattern. Then
His capacity is around about 200 ml. So yeah, maybe if you're thinking very strongly in terms of obstruction.
an MCU can be done in this patient to look at the posterior urethra along with the voiding pattern. Then we can think about any, for the upper tracts, you can go either for a CTI view to know the drainage pattern of the upper tracts, and also if there's any associated pathology in this. Hello?
Can you hear me now?
Yes.
Yeah. So what radiological investigation? Come on.
Now, micturating cystoureterogram for the lower tracts, and for the upper tract, you can go either for a CTI view to rule out any other. To rule out first, we can see the drainage pattern, and second, we can see any anatomical other GU. For example, if we are thinking about GUTB, then we can see any other signs that are present on a CT. Any nodal enlargement that is there.
So which one would you ask for? An MCU or a CT?
An MCU, ma'am.
See, here your thinking needs to be very clear. We are always bothered about the upper tract first, okay? We need to know what's happening there first. An MCU, yeah, would be in order, but I think a CT and imaging and proper anatomy of the upper tracts is necessary for us for a diagnosis, because we're still not at it. So can we show them the CT, please? Or they have done a chest X-ray and radiology also. Yeah.
It's normal.
Have a look.
Ma'am, it shows right gross hydroureteronephrosis and uneven calyctasis are also present on the right side.
Parenchymal thinning
See
along with
everything.
the.
Don't be in a hurry.
Can you go back to the previous images, please?
Previous slide. Left mild hydroureteronephrosis is there now.
On the right side, there's uneven dilatation of the calyces along with thinning of parenchyma. On the left side, the parenchymal uptake looks, the parenchymal uptake is there with the normal parenchymal thickness, along with the left-sided pelvis and upper ureter, which I can see dilatation, along with the thickened bladder, which can be seen in the bladder film of the portovenous phase. Otherwise, no. As such, notes for extrinsic compression or something can be seen.
Urothelial thickening is also there, ma'am, in the pelvis.
Yeah, sorry, I was disconnected. The net is an issue here, but yeah. Can you just repeat it fast?
Right-sided multiple calyceal dilatation with thinning of parenchyma. Left-sided, the parenchyma looks normal, but there is a pelvis dilatation along with probably upper ureter is also mildly dilated with thickened bladder in the portovenous phase that you can see.
Hmm.
The uptake is delayed on both the sides. You can't, there's a arterial phase only right now. Okay.
I think a network issue. She'll be joining.
Okay, so I think just to summarize, I think you have to notice that the pelvis was not dilated, pelvis was thickened, the ureter was not dilated. Okay, and the bladder wall thickness is out of proportion to the, you can say, to the upper tract changes. Okay, and then there are a few lymph nodes. You need to look at whether there are any extra renal things happening, like an abscess, something tracking down the psoas, something coming out. Is there Hello, and sorry, I don't think I'm going off and on the screen, but okay, we'll try and continue. Can you hear me?
Yes, ma'am. Yes, ma'am. Please go ahead.
Yeah. Okay. This is the report. Yeah, this is pretty suggestive. Now, as I told you beforehand, you have here a dilated system. You have a kidney there. So definitely, I would urge you all in your practice later on in life that you have here a focus where you can collect some amount of specimen directly, because your diagnosis now is turning towards genitourinary tuberculosis, and again, I think I went offline. I'm not sure what's happening to the net. Anyway, so I was just saying that you have an opportunity to collect a sample here, and that needs to, you keep it in mind always, that yes, it is a possibility that you can get a sample as to what's happening here from the upper tracts. Okay, so how would you proceed now, provided we ask you now, after the CT, what else? Are you
Shall
sure
I
it is
run, ma'am,
tuberculosis?
the 2 slides which are your CT scan quickly? These are the 2 CT scan which you have put. Yeah. Anything you want to?
Yeah. No, I'm fine with the CT. I want to ask them what next.
Okay.
A confirmation
because we
of
hardly
a
have time, right? Just to complete
yes.
This. So hence we can't dwell on the CT, but do look for other genital changes which are occurring, especially if the patient is female. In the male also, you need to notice the prostate size, seminal vesicles, if at all something is striking there. Don't just concentrate on urinary tuberculosis. It could be genitourinary tuberculosis. Okay, like proceeding, I would ask you, which other investigation would you want, or your diagnosis is done on the basis of this?
First, we'd look for a urine for TB PCR. We can go for
MGIT.
Urine TB PCR. Yeah, you have struck the right word for me to argue with you. So, what are the urinary tests you can do to confirm tuberculosis?
a back tech can be done. We can go for a culture. We can go for a urine for TB PCR.
Gene expert.
Gene expert.
MGIT.
Okay. So I see a lot of confusion over here. So I'd like to make you understand that when we divide the urinary test in tuberculosis, you should classify them into a urine routine test, a urine smear, a urine culture, then molecular test, then related to the genetic material which we are gaining on the urine sample. So then you will be able to very easily understand like how can we proceed. So a urine smear, definitely we discussed about urine smear and the samples and all them, and the yield is low, and though they are specific, but relatively they are relatively cheap to do, and so they need to be ordered. Now regarding an urine PCR, I told you in the beginning only that the PCR, for PCR, the urine and blood are very poor samples. If you get tissue samples, if you get aspirates, if you get some washes, then this is a good sample. If you are spending so much money, you should get an yield out of it. If I were your examiner, I would not like you to say an urine PCR, but at the same time, I'm aware that various centers do send urine PCR and some send even blood PCR. So it's not a total no-no, but it's written in the guidelines of tuberculosis by Government of India that PCR is not to be sent for urine and blood. That is only one thing I need to tell you. As I told you, I can send you a better presentation on email. Another thing about culture. Culture is done when we want a definitive diagnosis. What are the uses of culture? You need to know. Why a culture is ordered? You need to know. So culture, we'll come to it. I have a few slides on them just for your, to brush you up.
Shall I run, ma'am?
But yeah, can you run them? Yeah. So molecular methods are sent only when the AFB is not detected on smear. Okay, so you need to know that these are the various types of molecular methods. CPNAT is available in all of the RNTCP centers, but they do not accept urine. They are only accept tissue and aspirated fluid. Next slide, please. Then how would you diagnose? So diagnosing tuberculosis has specific criteria. So you clinical suspicion is one very important point in diagnosis. Then microscopy is the second most important point. Third point is radiology, and the fourth point is pathology. So there are two definitions. When you say that, yeah, definitely this is tuberculosis. If you want to say this is a case of tuberculosis and there's no other diagnosis, you need to have microbiological proof or pathological proof. When you want to say it's a clinically diagnosed case, it's not, we are not sure. That implies that we are not sure. Then you can do
We
it
are
on the
left with
basis
last
of
2 minutes.
clinical suspicion, radiology. Okay, can we go to the next slide?
These are the scenarios which
Next
you have
slide,
framed,
please.
ma'am. You want to discuss
Yeah,
this,
I
ma'am?
wanted to yeah, I'll just discuss it because anyway we don't have time. So it's very important that these scenarios come into your daily life frequently, that the clinical features are not there, but the radiological features are there, microbiology is not there. So in this, okay, we are coming to scenario number 1, in which clinical features are positive, radiological features are positive, but microbiology is negative. So it is acceptable, and you can start AKT in this patient, though microbiology is negative, only on the basis, because clinical features is a very important part that you suspect tuberculosis. Second scenario is, can we go to the second scenario?
Yes, ma'am.
Second scenario is the clinical features are not suggestive, only radiology is suggestive of tuberculosis. Here you have to repeat the microscopy after a period of 1 month or 2 months, or you have to find out whether you can take up a better sample from somewhere. Can we go to the third? Clinical features are negative, radiology is negative, but microbiology is positive. This also does happen in certain instances. And here is a very simple test, which is cheap, which is readily available, at least in metros, and it is called MPT64. It is an antigen which is tested, and it is specific for Mycobacterium tuberculosis. It is not present in the Mycobacterium bovis and other types of tuberculosis. So if that is positive, then you can start. But these are all clinical guidelines for starting treatment. I think we are short of time.
We'll run the two scenario, ma'am, last 4 and 5, then we'll wind up.
Okay.
I give four scenario.
So I'm not sure whether you encounter these patients, but there would be some patients who would come with a past history of pulmonary tuberculosis. They are completed their AKT and now they have some extra pulmonary symptoms. So if such a patient is seen within 6 months to 2 years, then it is also advisable to start the AKT the second month of the normal AKT, not the drug resistance protocol. It is necessary to take the second AKT because this is taken, it is not considered as a recurrence of the tuberculosis. It is a new occurrence. Okay, to fifth scenario, please. Here you may get a patient who is treated with GU tuberculosis with category 1 AKT, and now he has progression that he is not responding. He is developing abscesses, or he is developing more symptoms, or his involvement of neighboring organs. So in this is the only case. This is the only scenario where you have to find out whether there is a resistance to the AKT which was given category 1 AKT, and resistance can be tested by gene expert, LPA, or pyrosequencing. Only in this group of patients you have the right to start on drugs for second line of tuberculosis or drug resistant tuberculosis. And definitely if you are appearing for an exam before me, I would definitely want you to know what are the drugs available, what are the regimes available, and what are the common side effects of all these regimes which are there. The other point which I would like to make is you need to know what are the different types of surgeries which are available for genitourinary tuberculosis. Obviously, various affections. Kidney would be different, ureter would be, and bladder would be different, prostate would be different. So in an exam, I think if you are aware of all these things, I think it's more than adequate to clear the exam. So maybe I'm at the end of my
yes, ma'am.
time.
This was the last slide, ma'am. Yes, ma'am. This was the last one. Yeah, this was the.
Yeah, thank you very much. And I like the students because they answered pretty well, and happy with their answers. I wish I could go on as any teacher would like to go on and on, but yeah, it's a full stop. And thank you very much for including me and thinking of me. Thank you to the
Thank you,
Secretary
ma'am.
for USI, and especially to Dr. Arun Chawla for making it so easy for me. Thank you very much. Bye.
Thank you. Yeah, residents also, they can make note. Madam has published one book on genitourinary tuberculosis, and this was released in the last annual conference of USI at Kochi. If you are interested in going into more depth, it's a beautiful collection of case scenarios, beautiful radiological CT, IVU, MCU pictures. It's worth reading. You can buy it and you can just keep it as a collection. It's a beautiful book. Thank you, ma'am. Thank you very much.
Thank you very much, ma'am. It was very informative about the GUTB. Without wasting time going towards the next case, I would like to invite Dr. R. Shimpi, who will be the chairperson for the next case, and the participants will be Dr. Sanket, Dr. Saurabh, Dr. Sepuri Bala, and Dr. Shashank Agarwal. I would like to request Dr. Shimpi to share his
Can you
screen.
repeat the names of the residents?
Yes, sir. Dr. Sanket, Dr.
Yes.
Saurabh Arya, Dr. Sepuri Bala, and Dr. Shashank.
All with S.
Okay, sir. Yes, sir. The time for the case will be 30 minutes, sir.
You can see my slides?
No, sir, not yet.
Now?
Yes, sir.
Am I audible?
Yes, sir.
Yeah. At the outset, let me thank Dr. Sood and Dr. Chawla for this opportunity. And good noon to everybody. We have a case with 50-year-old
Please
male.
make it full screen, sir. Please make it full screen.
So this gentleman is 50 years old male with a BMI of 22.5 and presented with right loin pain since 4 months. The pain is dull aching and it's on and off. Can anyone tell me about the differential diagnosis and how will you proceed in this case? Anybody?
So given 50 years of age with the light side loin pain, the first differential diagnosis will be renal stones. Second
Why?
can be, hello?
Yeah?
Because it is dull aching and coming with off and on.
Okay. Any other option?
Second, in the case, I would like to put the right side PUGO, which might be silent in the initial period, but later on it appeared.
Yes. Any other differential? Any tumors?
Can be a renal mass.
Yes. Okay. So this is the only history they have given. Now, if you proceed, so this is the negative history. There's no history of hematuria. There's no history of lithuria. There's no history of loss of weight or appetite. And patient doesn't have any loops. There's no past history of urolithiasis. No history of any previous surgical interventions. Patient has diabetes and on medication. So what next?
I would like to ask the history of fever.
You'd like to ask for?
The history of fever.
History of fever. There is no history of fever. Okay, so we proceed to the physical examination. So pulse is 96, BP is normal, per abdomen soft, tender, no organomegaly. RS, CVS, CNS normal, and external genital normal. So which will be the next and the first investigation we would like to perform? Most relevant investigation in this case?
I'd like to go
ultrasound
for the
abdomen, sir.
KUB.
Ultrasound. Okay. So these are the ultrasound pictures. Can you read it?
So it's the ultrasound KUP, which is showing left kidney to be normal of shape and size. The CMD is well maintained and the renal parenchyma is good. While on the right kidney, the size seems to be within the normal limit. However, I can see
size, we should not comment on the one single picture unless there is a reading. You can comment on the capsule. You can comment on the anything else.
I can see an hyperechogenic area with the and shadow.
See this?
Yeah, it's an hyperechoic area with some sort of shadowing, which is not very much clear, but some sort of shadowing.
This is a posterior acoustic shadow.
So,
and quite extensive, right from the upper pole to the lower pole.
Lower pole. And the parenchyma is okay.
Okay. The cortical medullary junction or?
It is maintained, but it is not as delineated as the left kidney, but it is maintained.
Okay. Can you comment on the capsule?
The contour of the kidney is regular and well maintained.
Is there any scarring anywhere?
Sorry, sir, I can't see this guy.
Okay. What are these two small things here? The cystic lesions? Is hydrocalycosis or cyst? Can you make out?
Yes, it can be a hydrocalyx
or even cyst.
It's most surely hydrocalycosis because there is a acoustic shadow and it is it is towards the medulla, not towards the cortex. So in this cell, I can comment just there are more chances of hydrocephalus.
Okay. So these are the findings. A large hyperopic lesion noted in the posterior acoustic shadow measuring 3 to 1.5 centimeter in the pelvis, extending into all the calyces. Left kidney is normal, bladder is normal. Now, which next investigation you would like to do?
Sir, I'd like to go for the routine blood and urine examination.
And now this is the routine blood investigation. Hemoglobin is 13.1, TLC is 9,800, platelet count is normal.
Renal profile.
Urea is 20, creatine is 2.1. What does it indicate? Creatine of 2.1, what does it indicate?
It is raised.
Yes.
Patient is diabetic and so.
Yes, so he has a component of diabetic nephropathy probably involving both the kidneys. The potassium, sodium, the normal. Uric acid is 7.7. What is the normal range of uric acid, serum uric acid?
Up to 7.
More than 7 considered to be abnormal, and we start treatment above 7.
Range is 2.4 to 6. And what are the causes of hyperuricemia?
Sir, the causes of the hyperuricemia.
The gouty also, I think.
Hyperuricemia can be, sir, due to excessive intake of the animal proteins, or
Yes.
some sort of myeloproliferative diseases like leukemia, lymphoma, or the patient is
Yes.
having some sort of taking hyperuricosuric drugs, or if the urine pH is low urine pH, or if the volume of the urine is low. Those are the cases leading to the hyperuricemia.
Yeah, you can have tumor lysis syndromes.
Yeah.
You can have immunosuppressive drugs. Then hypothyroidism, genetic causes. This and even renal insufficiency can cause rise in the serum uric acid. The serum calcium is 8.8. What is the normal range for serum calcium?
8.4 to 10.2, sir.
8 point?
8.4 to 10.2.
Okay, 10.3, yeah. So what are the causes of hypercalcemia?
So it can be either of the absorptive type or reabsorptive or renal hypercalciuria.
That is calciuria, calcemia I'm saying.
If the patient is having hyperparathyroidism.
Yes. And granulomatous lesions?
Yeah, like in a TB
Yes.
or sarcoidosis, we can see it.
How do you get hypercalcemia in these cases?
Due to the elevated level of the parathyroid hormone related proteins.
No, it is related to the macrophage which secretes the active form of D3 that causes hypercalcemia. That is a secondary hyperparathyroidism you get in these conditions. Then you can have lung or breast cancers, diuretics, excessive vitamin D. All these conditions can cause rise in the serum calcium. Okay, phosphorus is within limits. So this is the routine urine microscopic examination. Urine shows RBC of 8 to 20 per hyperfilled. Epithelial cells 0.9 per hyperfilled. WBC 7 per hyperfilled. Bacteria 8 to 7. pH 6.2. Urine culture no growth. And crystals they are not mentioned. So is there any significant pyuria? How do you define significant pyuria?
WC count more than 5 per height for men, and
More than?
for 5. And
No, it is
more
10.
than.
If it is more than 10, then it is significant pyuria. What should be the pH of a normal urine?
5.5 to 6.5. That is the
What are the causes
average.
of, yeah. What are the causes of acidic urine and alkaline urine?
The acidic urine we can see in the like the patient's having chronic diarrhea
Yes.
or dehydration.
Yes. Systemic
Renal
acidosis.
tubular acidosis.
Yes.
RTA, yes.
No, renal tubular acidosis will cause alkaline urine.
It will cause alkaline
Alkaline
systemic.
urine, yes.
Yeah.
Certain respiratory diseases where the carbon dioxide is retained can also cause acidic pH. And what are the causes of alkaline pH?
UTI.
Yes, the urea splitting enzymes. Bacteria. What are the bacteria which produces urea producing enzymes?
Protease.
Protease, yes.
Protease, Klebsiella,
Yeah.
Pseudomonas.
Yes. What are the other causes? In which condition you get failure of acidification of the urine, which you just told me just now?
Renal tubular acidosis.
Renal tubular acidosis. And what are the types of renal tubular acidosis?
Type 1, 2, 4.
Yes. What is type 1?
In type 1, there will be the hypokalemia because the pathology is located in the distal nephron, as well as he will be having, patient will be having hyperchloremic acidosis.
So basically there is failure to excrete acid in the urine.
Yeah.
And type 2?
So here the lesion will be in the proximal, this one, nephron, PCT level, and there will be the defect in the transportation of the bicarbonate.
A failure to absorb the bicarbonate. That's why it is alkaline urine. And type 4?
I don't know.
Type 4 is renal damages, chronic pyelonephritis. Okay. So this patient's urine was sent for culture. There is no growth. What are the different crystals you see in the urine?
Hexagonal crystals in case of cystinuria, and
Yes.
the true white, it is coffin shape, and
Calcium oxalate monohydrate.
It will be hexagonal.
No, it will be hourglass.
It
will be hourglass.
Hourglass.
Calcium oxalate dihydrate will be envelope shaped. Calcium phosphate.
It is amorphous.
Amorphous. Bruchite.
Bruchite.
Needle shape.
Needle shape.
In
And
uric
uric
acid, we will get diamond shape.
It is amorphous plates. Okay, these are the examples. Okay. Okay. So after this, which other investigation will advise?
Sir, I'd like to know the random sugar and the glycosulfate hemoglobin of this patient, because he is having a stone on one kidney and plus his serum creatinine is also raised.
Yeah. HbA1c is, I think, 6.7, and sugars are within normal limits.
We would like to proceed for CT KUB.
CT KUB?
Yes.
Non-contrast or with contrast?
Non-control, because creatinine is based 60.1.
Will you not go for IVU?
Sir, contrast in this case can cause the contrast-induced nephropathy, and his creatinine is already raised. This too. So I would like to go for only for non-contrast CT.
Suppose if the serum creatinine is normal, which will be your preferred investigation, IVU or CT urography?
CT urography.
Sir, okay, sir. If the creatinine is normal, then IVU and CT-IVC, though the radiation dose is more, but it has certain advantages, like CT can show the adjacent structures, like in case we can know the renal colon, and we can know about sphenomegaly and hepatomegaly. And in case of CT, we can also know the parenchymal abnormalities, any anatomical abnormalities like Horst kidney. We can that can be seen in IVP also, but these parenchymal lesions, they can be better seen in CT. So, and there is no bowel preparations required in case of CT IVP. In IVU, there are bowel preparation is required, and that is not clear. Clear picture of the all the anatomy is not seen. And in CT IVP, when we combine it with the CT IVP, then the functional status also we can assess. We can guess the functionality of the renal system.
All right. So for KUB and IBU, the specificity and sensitivity as far as the stone is concerned is between 20 to 30%. Well, that for the CT urography is almost like 70 to 90%. And in addition to that, you get three-dimensional anatomical picture of the pelvic elastic system. You get about the stone density. What is the implication of stone density? HU units.
Sir, actually,
and what is the cutoff point?
Higher the HU, the harder the stone is. So, means the releasing or the breaking of the stone is harder.
Yes. And what is the cutoff point?
Plus, we can comment on the composition of the stone based upon the density. For instance,
yes,
uric
indirectly you can comment. So the cutoff point is 970 HU. If it is less than that, then it's comparatively a soft stone. If it is more than that, it's comparatively a hard stone. And that will be useful, especially when you're subjecting them for lithotripsy. This will also, sometimes you can combine with angiography also. Suppose you have a patient, you have a PEG obstruction with a stone, and you want to rule out the crossing blood vessel at the PUJ, you can combine with renal angiography. It will also tell you about the distance between the skin and the stone and the relation with other organs like colon, spleen, and pancreas. Okay. Will you go for a DTPA scan?
So not in this, not in this case. And the DTPS can, when we see the features of this parenchymal thickness is less and the CMD is lost in USG, then we can go for DTPA. And when we are thinking in the terms of nephrectomy, but when we are thinking in the term of clearing the stones, then DTPA is not required.
Yeah, because you're not going for non-contrast. And if the kidney shows any kind of abnormality and you want to know about the function of the kidney, then you can perform a DTPA scan. You'll prefer DTPA or MAC3?
If I have to creatine, I will prefer MAC3. But MAC3 is unfortunately not available in India.
Yeah. Okay. So this was the KUB. Can you read this KUB?
Sir, this is X-ray KUB showing the lower rib cage showing 11 and 10th intercostal space, and spine is central. There is a radio opacity, though the picture is not so clear, but there is on the right side on the renal region, there is a radio opacity is there. There are multiple, and I'm not able to define it completely. Otherwise, the bladder region, ureteric region, it seems to be clear, and the bladder region is clear, normal.
Now this is the approximate picture of the stone. Will you call this as a staghorn calculus or a partial or complete staghorn?
Sir, it is involving two major calyces. It seems to be involving two major calyces, so it can be defined as the partial staghorn.
Okay.
Incomplete, more than two major calyces are involved.
Yeah.
Sir, we are left with 10 minutes for the case.
Oh, really? Okay. So this is the CT scan. Okay, this is Stagon calculus measuring 3.2, 1.4 into 2.2, extending into upper, middle, and lower calyx. There are 2 cortical cysts noted in the right kidney. So what are the anatomical dispositions which can form stones?
The PUG obstruction.
Yes.
R2 kidney.
Yes.
The medullary strong kidney.
Yes.
And
Calcial diverticulum.
Calcial diverticulum.
Ectopic kidney.
Ectopic pelvic kidney, sir.
Ectopic kidney.
Yes, sir.
Okay. Now you have a Stagon calculus with infection, and if you don't treat this patient, what will happen?
So there is 30% in 10 years follow-up if we don't treat a Stagon infected calculus.
There are chances that the patient.
So what are the complications? So what are the complications which can occur?
Since it's a Stagon, it might be harboring infection, and the patient may land in sepsis with due course of time.
Yes.
And plus, there will be deterioration in the renal functions further.
Yes.
Apart from that, he will be, of course, having a UTI also, off and on.
Yes. Can it cause xanthogranulomatosis pyelonephritis?
Yes, it can cause.
Renal failure?
Yes.
Any malignancy you know of this patient?
Chronic stones can lead to squamous cell
carcinoma. Yeah. So after PCN, you should take a biopsy of the renal pelvis. So these are the treatment options you have. Open pyelolithotomy, open inotropic pyelolithotomy, which is not done nowadays. Only in selected cases we do it. So between PCNL, ESWL, flexible URS, laparoscopic, robotics, or combination, which one is your first preference?
In this case,
pardon?
I will prefer PCNL because the sizes of the stone is more than 3 centimeters, and the HU was also more than 1,000 units, and
success rate of PCNL is?
What? Sorry?
Success rate of PCNL is almost 90 to 97%. For Stagon.
Stone free rate is highest in case of PCNL.
Yeah, and with ESWL?
Because the HU is more than 1,000 is the harder stone, and the size is also size is more than 3. So ESWL with that the stone free rate will be very low, and
it is around 50 to 60%. Flexible URS as a monotherapy is not used. You can subject them for laparoscopy or robotics, or you can go for a combination. So what are the factors which affect stone management? As far as stone is concerned, what are the factors?
Stone size,
stone location and its density.
Location, density,
and composition. Renal factors.
Any abnormality.
Yes, that is obstruction.
Calcial abnormality.
Stasis.
Any PUG.
Renal ectopia, lower polar stones. And what are the clinical factors?
The patient is obese or not, whether he is febrile or not.
Presence of infection, body deformity like hyposcoliosis, coagulopathy, hypertension, solitary kidney, urinary diversion, pregnancy, then transplanted kidney, etc. So what are the contraindications for PCNL? The contraindication?
Uncorrected coagulopathy.
Yes.
Active UTI, sir. Active infection.
Yes, active UTI.
And what are the relative contraindication? Morbid obesity.
Yes, sir.
If the patient is very much morbid obese, then what you will do? How will you modify your PCNL technique?
Valdivia position.
So you need to have, suppose the maximum size of the ampullus is around 20 centimeters.
With the longer size of the instruments.
But you don't have any ampullus more than 20 centimeters. So in that case, you can make a slightly wider skin incision, go up to the muscles, and with the help of master retractor, you keep that thing open, and up to muscles, about beyond muscles, you can keep the ampla sheet. How will you prepare this patient? We'll keep blood ready.
Yes, sir.
Yes, you'll give antibiotics.
Antibiotics.
Which anesthesia you will prefer?
General anesthesia. General.
Why?
Because it may require 2 punctures.
That is one thing. Second thing, usually for stag-on calculus, it is always better to go through upper calyx.
Yes.
So you can control the respiration if you're using general anesthesia. Now, what type of PCNL you do? Mini PCNL, ultra mini, or micro mini?
Standard PCNL for stag-on calculus we can choose for because the size of the tract is more. But these is we can go for mini PCNL, and along with that we have the more tone segmenting devices like soft pulse is there, trilogy is there. So this can be cleared with the mini PCNL also. Otherwise, standard PCNL.
Yeah. So what are the sizes of, how do you define mini, ultra, and micro?
So more than, by conventional classification, anything more than 20 French sizes standard PCNL, less than 20 is mini PCNL.
No, mini is between 14 to 22, ultra mini is 11 to 13, and micro is 4.8 to 11 French. So that is the size of the nephroscope which you use for these techniques. What are the different energy sources you can use for PCNL?
We can go to
pneumatic or
ballistic.
laser.
Yes, for MEM laser.
Or we can use the combination of dual, that is ultrasonographic with pneumatic.
Yeah, ballistic. So what are the advantages of laser?
That can be used to a flexible scope also, and
yes.
That can leave any kind of stones, means heterogeneous kind of composition. They can get hard stones also.
Disadvantage?
Left, sir.
So lasing
Can it
time
cause
is,
perforation?
Yes.
Can it cause perforation?
Yes.
It can cause.
Yes.
Yeah, compared to Lilith, because the depth of the is only 1 mm. The other energy source like ballistic, what are the advantages and disadvantages?
The chances of injury, the mucosal injury is less, and
yes.
But the disadvantage is greater chances of retropulsion.
Retropulsion. That's right.
Retropulsion can be used. It cannot be used in the flexible milieu.
Yes, scopes. And the third one, the ultrasonic.
So ultrasonic is basically used when the stone fragments are very small size. Then
it can be combined with vacuum. Basically, it can be combined with vacuum. Again, it can be used
also be
only with the
combined
rigid
with pneumatic.
scopes. Yeah. Will you keep nephrostomy or not?
Definitely. In this case, I would like to keep the nephrostomy because the patient is having a staghorn, so he may be harboring infection. So for proper drainage, I'd like to keep.
So what are the indications for tubeless PCNL?
So if the stone
If it is a
size
single puncture,
less than 3 centimeters, single puncture, and the surgeries goes uneventful without any trauma to the PC system, or in that case, I'd like, and the stone is not impacted also. In that case, I'd like to go for tubeless.
and full stone clearance.
Yeah. So, but you do keep a small ureteric catheter. So it is not completely tubeless, but you keep a small ureteric catheter. Now, what are the associated procedures you can perform with PCNL?
I can perform ECIRS, combined flexible rotoscopy along with the PCNL from the retrograde and antegrade route. And apart from that, if I want to reduce the number of the punches, then I can introduce the flexible rotoscope via the same tract, antegrade.
Can you go for endopilotomy?
Yeah, I can go for the
yes.
Time is up for the case.
Along with that, if there is some masses in this one renal pelvis, then I can go for the antegrade fulguration or the biopsy of it.
Okay. Can you identify these pictures?
So hydrocalyx, first one with the calicial diverticulum with harboring the cal.
This?
So this seems to be some sort of horseshoe.
Infundibulum long.
Horseshoe kidney. This? So these are all indications for the PCNL. These are the complications. Do I have another 2-3 minutes? Hello?
Yes, sir. Please wind up within 2-3 minutes, sir. Okay.
Time is
Okay. So these are the complications of PCNL: bleeding. How do you stop bleeding?
Sir, intraoperatively, I can stop bleeding by placement of the larger side of the nephrostomy tube. And
Yes.
if,
Or balloon. You can use balloon.
Or
And if
there
there
is
is
one
artery bleeding,
that is, we can fulgurate bleeding with the laser if we can locate it. Or if not, and if the bleeding is diagnosed post-operatively, then one modality is angiography and selective embolization.
selective embolization. How will you diagnose intraperitoneal extravasation of fluid?
Sir, if the intraoperatively, if there will be sudden collapse of the collecting system, then I can suspect that there is some perforation leading to the extra vescation of the fluid.
Yeah, so there will be a fall in diastolic pressure, the pulse pressure will reduce, and there will be abdominal distension and difficulty in ventilation. Colonic injuries, will you do exploration or you will just keep a tube and come out?
Just keep a tube and come out.
Separate drainage for the colonic drainage and renal drainage, separate tubes.
Okay. All right, so I think I should stop here. Thank you so much, and thanks for the active.
Some background noise is there, sir. So from where?
Some background noise there.
Yeah.
Yeah. So thank you so much, Dr. Tiwari. Sorry, Dr. Chawla and dear residents. I think you are done well.
Thank you, sir. Thank you very much, sir.
Yeah.
Thank you, sir.
Yeah.
Going towards the next case, I would like to invite Dr. Lakshman, sir, who will be the chairperson for the next case. And I would also like to invite Dr. Nishkash, who will moderate the case on behalf of the sir, and request Dr. Nishkash to share his slides. And the participant for the case will be Dr. Shekhar, Dr. Shruti, Dr. Sitaram, and Dr. Steve. Time for the case will be 30 minutes. Dr. Lakshman.
Yeah. Can you repeat the names of the participants? Yeah. My resident friends.
Yes, sir.
Shekhar, Shruti.
Yes, sir.
There will be 3 participants.
Sitaram and Dr. Steve.
There will be 3 participants: Dr. Nikhil, Dr. Sitaram, and Dr. Shekhar.
Okay, Dr. Shekhar, Sitaram, and Nikhil.
Sir.
Okay, we'll get going. Yeah, please start the presentation.
Dr. Nishkash.
Nishkash.
The screen is on. Yes, screen is there.
Yeah. Nishkash, you are only presenting, or you are also participating in the discussion?
Only present.
Only presenting. Okay,
Dr.
go ahead.
Nishkash only present.
Okay. Yeah, Nishkash is going to present, and the others will be there. Okay, get started. Nishkash.
Nishkash, please go ahead with your presentation.
Yeah, go ahead. Yeah, you go ahead with the presentation. I won't read it out. You know, you read it out, and I'll tell you to start. Okay. Can you hear me, Nishkash? Anyway, we are wasting time. Yeah.
Nishkash, please remove your earphones. Nishkash?
Yeah, it's okay. I think,
No. Let him just
are we going to have a services or not? Yeah. Yeah, who is controlling the slides? Anyway, now I have not gone through this presentation. Shekhar Sitaram and the other friend of mine, but I'll read it out for you. 8-year-old girl presented with chief complaints of recurrent burning micturition into 5 years and right flank pain into 6 months. So what do you make out of this? I think I'll start with Shekhar. Shekhar? Dr. Shekhar? Dr. Shekhar?
Hello.
Dr.
Yes, sir.
Shekhar, Sitaram Shekhar, please unmute yourself.
Yeah, unmute yourself. Sitaram, Shekhar, and who is the other one? Other third one?
Nikhil, sir. Nikhil.
Yeah, go ahead, Shekhar. Nikhil, yeah. Nikhil, yeah.
8-year-old girl, sir, which is presented with the chief complaints of recurrent burning micturition for 5 years and with the right flank pain since 6 months. So, sir, patient
Would you like to know anything more than that?
But with recurrent burning micturition, any episodes of fever she had in between? Any episodes of fever or hematuria?
See, there are a lot of disturbances. Others can unmute. Others can mute and, Shekhar, go on. I'll come to the others. Can we have the slides, please? I'm not able to see the slides. Nishkash? Yeah.
So, female patient with recurrent burning micturition, I would like to...
Yeah, okay. Doctor, yeah, it's a female child. Yeah. Go to the previous slide. We are not through. Nishkash, go to the previous slide, please. I think we are having a serious problem. I think, we'll go ahead. Shekhar, are you there?
Yes, sir. Yes, sir.
Yeah, see, we will start discussing and we will move to Nikhil and Sitaraman shortly. So okay, we can read it out ourselves because I don't think we are getting attention because we have only 20 minutes. Now, recurrent episodes of burning micturition, around 3 to 4 episodes. Now, go to the next one. Go to the next one now. Don't mess it up now. Go to the next one, please. Go to the next slide.
Next slide, please.
Go to the next slide, please. Show the next slide, please. Move.
Issue is there. He will come. No problem, sir. You can ask questions now. We'll run the presentation now, sir.
Okay. Yeah. Now, Shekhar, I have a point with you that all the story which they have tried to tell us in the first and the second slide, whatever it is, we will come to that shortly. Do you think the child will give it to you or someone else will give it to you?
History will be provided by the mother, sir.
8-year-old can give you all that?
Sir, 8-year-old can...
8-year-old I am addressing the question to you. Others, please mute yourself. I'll come back to you. I can't hear you, Shekhar. Can an 8-year-old give you all these graphic descriptions?
No, sir. 8-year-old cannot provide all the information.
There are a lot of disturbances.
8-year-old cannot provide all the information required. History must be given by the mother.
Yeah, mother. What is the mother referred to as?
I would like to ask that for the last 5 years for recurrent burning micturition, what treatment has been taken? Is there the recurrent burning micturition?
Thank you, Shekhar. I think we will. No, hold on. I think there is a lot of disturbance. If I am audible, please listen. All these graphic details can't come from there. Okay. They have to specify that this has come from an informant, and that informant has to be identified in the case notes or in the presentation. It can be the mother, it can be the grandmother, it can be the father, whomsoever it is. And the reliability of the informant has to be established in your case notes. It's very important. And when you are dealing with a pediatric case, that is the first step. Unfortunately, this is being shown like an adult case. That is not correct. That is not appropriate. Okay. Shall we go to the second slide now? Shall we kindly show us the second slide, please?
Sir, we do not have...
Anyway, we are not seeing the second slide. Yeah. Can we?
Sir, we do not have Dr. Nishkash on board.
Okay, doesn't matter. I think I'll go to Nikhil. Unmute yourself. Nikhil, unmute yourself.
Yes, sir.
Yeah.
Yes, sir.
So
You
you
are
saw
audible.
this. Yeah, I think we chanced on that first two slides.
Yes, sir.
Till we get back Nishkarsh. Yeah, what did you make out of those that story? We had an 8-year-old girl with flank pain and all the symptoms they are trying to, the OP which they have shown.
Yes, sir. I feel the patient is having some kind of infection, sir.
Some kind of
infection.
Yeah, I think we have.
I would also like to.
Yeah, Professor Chawla, thank you very much. I think he has come to our rescue.
Sir, I would also like to know whether.
Yeah. See, I'll read it for you. Recurrent episodes of burning nutrition, around 3 to 4 episodes in a year, relieved on taking medication from local physician, and one episode of febrile UTI present 6 months back, 6 months ago, and for that the patient received antibiotics. Okay, now I will ask you a straight question. Is it appropriate to treat a child with febrile UTIs with parenteral antibiotics? I'm asking a straight question. Can a child be with febrile UTI?
Dr. Lakshman? Dr. Lakshman? Dr. Lakshman?
Yeah.
Your voice is breaking, sir. Your voice is breaking. Can you remove this earphone and yeah, it is breaking your voice. Yeah, without this we can speak. Go ahead.
Is it better now?
Yeah, it's better, but in between it is breaking.
Yeah, is it better? Okay,
Yes,
I will take off the
Yeah, it's better now,
yeah,
sir.
am I audible now?
Very well audible, sir.
It is better. Okay, Nikhil. See,
yes, sir.
Sir, 1 minute.
Let us not waste time because we have a lot of. Let us not waste much time. If I'm still audible, my question is it appropriate to treat a child with febrile UTI with antimicrobials? Is it appropriate? The answer is yes. The answer is yes. The evidence is strong. When you have a child with febrile UTI, you have to treat the child with parenteral antibiotics. Okay? Now, what do you make out of this? The whole scenario.
So
Nikhil,
the patient is having recurrent infection. You can make out that patient.
What
is
would
having
you consider? What problem would you entertain?
Sir, it could be because of some reflex, sir. Recurrent infection. It could be because of some reflux, sir.
No, see, not necessarily. No, it could be some dysfunction in the urinary tract. It can be in the upper tract. It can be at the VUJ. It can be at the outlet. Okay.
Yes, sir.
From this story, you cannot come to any conclusion. Now, at this stage, if the mother were to be there, an educated mother were to be there, would you ask her something? In addition to the story which she has given about the child, if there is an educated mother who has had regular antenatal checkups, what will you ask her?
Sir, during the antenatal, we would ask whether there is any hydronephrosis present. So during the antenatal checkups, I would ask whether there was any hydronephrosis.
Detected, what is called as?
Bilateral hydronephrosis.
Okay. Now you would like to know whether any abnormality in the fetus was detected and whether she was counseled about it. It appears that this child is now old enough, now 8-year-old, and maybe such a story was not there, and we really do not know whether she has had it. But then if the mother is able to tell you that there was an antenatally detected hydronephrosis, what would be your approach? Let's say that, let us leave this case for a while, and I'll ask you a question, that if an antenatal hydronephrosis is detected, and let's say with respect to reflux, let us not go into other entities. Okay, this is a girl child. With respect to reflux, what would you arrange in the postnatal phase?
So postnatally ultrasound we have to do.
In the postnatal phase, there is an indication for a screening for VUR. And when will you screen for VUR otherwise? One is antenatally detected scenario.
Yes.
There are two other situations where you will have to screen for VUR. What are they? If a sibling were to be diagnosed with VUR, you will have to screen. And if you had a parent who had VUR, even then you have to screen the child. Okay, we will leave it. We'll go to the next slide. Please change, sir. Please change. Now I'll go to Sitaram. I think we'll give a chance to Sitaram. Next slide. So please change, sir. Next slide. Not able to change?
Negative. Yeah, no, sir. You can see this. Next slide.
Okay. No, I am seeing HOPI. The third slide is not coming on. The third slide is not coming on.
No, it is coming from my end. Let me check, sir. Can you see now?
No, not
Are
really.
You seeing? Okay, sir. 1 minute, sir. 1 minute. You engage them in question. I'll come back again.
Yeah. Anyway, I think, this slideshow is not assisting us. And I was told that, it was a case of VUR, that much I know, but I just can't build it up on this. So till we get the slideshow. So I told you three things now till now. One is the informant is very important. And the second thing is you have to screen if there is an antenatal detection.
Can you see, sir?
Yeah, no, I can't. I think I lost my examinees also.
Sir, it's visible, sir. The screen is visible.
Yeah, and I just, without eye-to-eye contact, it's difficult. I must have at least one face.
Are you seeing the slide, sir?
Nothing. It's gone blank.
Is the candidate seeing the slide?
Sir, I am able to see, sir.
Yes, sir.
Nikhil, Shekhar, are you able to see the slides?
Okay.
Yes,
now,
sir, we are able
yeah.
to see the slide.
Yes,
sir. We are able to see.
Nikhil.
Yes,
yeah,
sir.
Nikhil,
Yes,
you
sir.
are there? Yeah. So I think we had some discussion with you. Now we'll move to Sitaraman. Can we get Sitaraman? Yeah.
Yes.
Yeah, thank you. Yeah, pain is insidious in onset, mild and dull aching, non-radiating, relieved on medications, not affecting daily activities. Okay. So there's something seriously wrong with this presentation because we'll have to criticize the scenario because it has to be appropriately worded. In the examination, when you present your case, you have to word it appropriately because see, when you use this expression not affecting daily activities, what are the daily activities of a child? 8-year-old, not able to attend a class, not able to concentrate. These are the issues which come. Daily activities of an adult are different. And this kind of graphic description is very difficult to get from a child. But then if the child is older, now 8-year-old can give you that. Let us accept that this child has pain on the right side. Okay. A febrile UTI, we can make some sense out of it. And Sitaram, at this stage, what is your DD? Forget the VUR for a while. What is your DD?
So the history started with the lower neck tract infection symptoms. Now suggests to have a right flank pain. One is pyelonephritis.
Okay.
Patient can be having a pyelonephritis. Patient can be having a
Can you
reflex
make
which
it a
is
little more
causing
specific?
the
In a girl child, why will there be pyelonephritis?
reflex and ascending infection, ascending
So what you
urinary
have
tract
to
infection.
say, what you have to say is that there was a story of lower urinary tract symptoms, which could be a voiding dysfunction. All right.
Yes.
Or
Yes.
there is no history of bowel disturbances, so BBD is unlikely. So a voiding dysfunction or a VUR, and now the girl is experiencing right flank pain, and there might be upper tract UTI. Can it be anything else? Can you have a primarily an upper tract problem which can present with lower tract symptoms?
PUJO can coexist with lower tract symptoms like VUR, sir. Conditions like PUJO can coexist with conditions of lower tract symptoms.
So VUR can it can coexist. So it's an open. Point is taken. I consider that. So at this stage, we are more or less certain that we have a problem on hand because there was a febrile UTI, and there are symptoms which are now getting lateralized to one side. So what will you do at this stage?
First, I will do a clinical exam.
Not available to us. Antenatal history is not available. We'll presume that there was no checkups, and there is no bowel disturbances, no constipation, no ancoparesis, and let us presume that there was no occult or overt spina bifida. So we will keep the neurogenic situations out. So in this child, girl child, who is not incontinent. So
first, I will do a clinical examination.
Let us look at the negations. Yeah, we'll go back. Yeah. Okay. Oh, you want clinical examination? Okay. See, go through the clinical exam. Sitaram. Yeah. Yeah. Let us stay on that. Let us not move. Yeah. So what do you make out of well-built and well-nourished?
Means the child is appropriate, growth is appropriate to age, sir. Because if we are suspecting cases of long-term VUR or conditions of VUR congenital, patient can have decreased, renal failure, and patient may not be appropriate for age growth. So,
see, in that case, I have a question. I think Sitaram, I'll go back to Shekhar now. Shekhar, can you come in now?
Yes, sir.
Yeah. In the initial evaluation, Shekhar, if you have a child with a suspected urinary tract dysfunction, it could be an anomaly. What are the necessary things to be done in the initial examination, clinical examination?
So in general, in
so you will record height, you will record weight, and you will use an appropriate cup to record the blood pressure. Appropriate cup to record the blood pressure. And it is also important to know the developmental milestones. So you should have a chart of the developmental milestones and the nomograms. And let us presume that they are all okay because they have said that this child is well nourished. But the whole description here is not, in the language of pediatric clinical medicine. This is, they have used expressions which you normally use for adult patients. So I would like you to fine tune all these things in the examination so that you score. The moment you say informant, you will score. The moment you establish the reliability of the informant, you will score in the examination. Now they are saying, okay. And in addition to that, there are some investigations to be done. We will not go there. Now, what do you make out at this stage? You want, these are general. Would you like to do a local examination? Yeah. Local examination.
Per abdominal examination, sir.
Local examination is normal. Yeah. In an 8-year-old girl child, how will you check for anal tone? Shekhar, how will you check for anal tone? They have mentioned that. You have to examine the spine, fine. Abdomen, okay. CVS, RS, okay. See, what is important in case you are asked this, no back swelling, you have to use the little finger to do the rectal examination in pediatrics. Please remember that, the little finger in a child. And vaginal examination not permitted. Okay, right. Next, at this stage, Shekhar, have you come to any conclusion as to what could be wrong with this child?
Sir, with this findings of... Yes, sir. Hello?
Yeah, I can't hear you. Can you be a little louder?
Yes, sir. Yeah. Sir, with this particular examination, the DRE, the normal anal tone, and BCR is present. That lower urinary tract dysfunction can be ruled out, sir, based on the clinical examination.
Yeah, go on.
So based on the clinical examination, that normal anal tone and BCR is present, so we can rule out the lower urinary tract dysfunction.
Yeah.
So now it can be, sir, our differential diagnosis.
This scenario is unlikely to. Go on. Shekhar, go on. Shekhar, your voice is not coming.
Yes, sir.
Hello?
Hello, yes, sir.
Shekhar?
So now, sir.
Yeah, please speak on. We have only 20 minutes, boss. Yeah, we have to move fast. Yeah. So you.
Hello?
Yeah, you think it's a VUR, right?
Yes, sir. Now the differential diagnosis will reduce.
I can hear you. Can you hear?
Yes, sir. Yes, sir. I can hear, sir. It will be reduced to VUR.
Okay. Okay. We will. Yeah. Sitaram, unmute yourself. Sitaram,
Yes.
unmute yourself. Yeah. What is your view? What's your view?
My view is VUR, sir. VUR, sir.
Pardon me?
VUR, sir. Vesico-ureteric reflex, sir, without LUTD and mainly involving the
Reflux, okay, wonderful. I think you will think of a vesicular reflux. What investigation would you like to do now?
ultrasound, sir. USG-KUB.
What investigations would you like to do now?
USG-KUB,
Yeah, USG-KUB. Can we have it, sir?
Ultrasound.
Yeah. Yeah, USG-KUB. Yeah.
Yes, sir. Sir, in the
Right kidney left, can
USG-KUB.
you?
Yes, sir. I can see, sir.
10 minutes left, sir.
Yeah. What do you
So
make out?
The USG showing the right kidney, there is right gross hydronephrosis, ureter I can't see, sir. Right gross hydronephrosis, thinning of parenchyma with no internal, and there is rise of cortical echogenicity.
Yeah, very well done. What is the current terminology for this? Do you still say hydronephrosis, or what is the current terminology? The current terminology is upper tract dilatation. All right. So the word hydronephrosis is not being used now. The current terminology is upper tract dilatation. The left kidney looks okay. The bladder also looks okay. What next? Nikhil, what next? Yeah, quickly, what next?
Sir, MCU would be good, sir.
Yeah, sir, MCU, please. Yeah, what are the precautions you'll have to take before doing MCU? Quick.
So before
Nikhil.
Sir.
Nikhil.
Sir, it's an MCU showing right-sided
Before
dilatation,
MCU,
sir.
what are the precautions? 1 minute. Before MCU, what are the precautions you are supposed to take? Am I audible?
Yes, sir.
Urine analysis.
Can you hear me? Okay, Sitaram, unmute yourself. Come in. Yeah, come in. Sitaram, unmute yourself.
Urine
What will
analysis.
you do?
Urine should be sterile.
There should be no evidence of UTS.
Yeah, urine should be sterile. Urine should be sterile. Okay.
With MCU, sir.
Yeah, Nikhil, read this. Thank you.
Sir,
Thank you, Nikhil. Read this. Why should you do a culture before MCU?
Sir, we don't want to introduce infection high up into the tract, sir.
No, that is not the reason. There can be transient VURs because of infection. Whenever there is infection or inflammation, there can be transient VUR. We may make an overnight. Okay. The connectivity is bad, but we will read this. So, what is your diagnosis?
Sir,
Please diagnose quickly.
Sir, it looks like a grade 5 VUR, sir.
VUR
grade 5
please.
VUR. Sir, it looks like a grade 5 VUR, sir. The dilatation is going up to the...
Grade 5 or grade 4?
Grade 4.
Grade 5 or grade 4?
Grade 4.
Grade 4. Why do you say grade 4?
Sir, because the dye is going up to the upper tract and kidney is dilated, and along with that, ureter also is dilated, sir.
Okay, okay, whatever it is, if you are still able to, hear me, this can come as a OSCE in your DMB examination, and if there is going to be OSCE in MCT examination, if the examiner thinks otherwise, you are sunk, because the answer key, your answer and the answer key has to match. But the simple rule is up to the ureter grade 1, PCS with the coupling maintained grade 2, PCS with blunting of the calyces 3, and then you have they say that mild to moderate hydronephrosis, mild to moderate dilatation, and in grade 4 you got severe dilatation and tortuosity, and then of course the last one is they say very severe gross dilatation. And so this grade 4 and grade 5 is always a nuisance. So whatever it is, it's a high grade reflux. I'm not going into that. It's a high grade reflux. How will you manage this child? This child is 8 years old. When do you expect the VUJ to mature, and the reflux to resolve? At what age?
By the age
Anybody
of 5
can
years.
answer, any three of you.
By the age of 5 years.
Pardon me?
By the age of 5
By
years.
the age of
Normally
5 years, okay. Now she's 8 years. Yeah, okay. There's a lot of disturbance. I hope you got the question. Now, do you think this reflux will resolve? Do you
No,
believe
sir.
that this
Unlikely, sir.
reflux?
Unlikely,
Unlikely.
this reflux will resolve.
Okay, now next question is, since we are running out of time, can you put this child, place this child on CAP? What is CAP? Continuous antibiotic prophylaxis.
No, sir, we can't.
Can you place this child?
No, sir.
Why not?
Sir,
Why
all
not?
adolescent girls with unresolving unresolving VUR, which is high grade, should be counseled for surgery, because one is less chance of resolving. The second is, once they get pregnant, the chance of prenatal premature deliveries are more. So these people should be advised for surgeries.
Yeah. Yeah. Well done, Sitaram. I will interrupt you. I will go to Nikhil. Nikhil, please tell me, which subset of patients will be benefited by CAP? Which subset? And what are the criteria you have to take into account before you place somebody on CAP?
Sir, I don't know, sir, that.
So grade, age, gender, breakthrough UTIs, presence or absence of scars, presence or absence of BBD, all these things you should know. Anyway, all of you believe that this patient needs intervention. What intervention? Endoscopic or surgical?
Sir, I would like to assess the function like DMS and then decide on what modality of procedure I will go ahead, sir.
Okay, can we have the DMS scan, sir, if it is available?
It's not moving. Yeah.
Oh, okay, that's the
This is
DMS
the report.
scan. Yeah.
So the right kidney is showing only 6% of functioning, sir, and it is small contracted. Yeah. So, and patient is having recurrent urinary tract infection. So this could be the source of harboring the infection. So I would like to counsel the patient for a right nephrectomy, sir.
Nephrectomy. Any dissent? What about the other two? Nikhil and Shekhar.
Sir, we can give another option.
Come on in now. Yeah, Nikhil and Shekhar, do you?
Sir, the another option is we can decompress the system and then we can. Sir, we can decompress
I'm
the
not
system.
able to hear you, Shekhar. Please. What
Hello,
can you do?
sir. Sir, we can decompress the system and then reevaluate.
Yeah, Shekhar, please.
Sir, we can decompress the system and then we can reevaluate the child after 4 to 6 weeks.
Okay, thank you. Nikhil, let me see whether I can hear Nikhil.
Sir, because the function is only 6%, sir, so I will go with the option of nephrectomy, sir.
You will go with the option of nephrectomy. So I'm going to tell you why not place this child on a CAP and leave it like a pop-off.
Sir,
let the right kidney take a beating. Blood pressure is normal. There is no proteinuria. Why do you want to ablate the system?
Sir, these recent evidence shows that there
because
is.
If you ablate the system, the other side may start refluxing.
Sir, there is recent evidence says that
the
pop-up.
That you ablate the system.
Sir, pop-off mechanism is questioned these days. They say it doesn't help. Pop-off mechanism doesn't work or help the other system, whichever is compact. So pop-up mechanism is not there, sir. And the second thing is there is recurrent urinary tract infection since last 5 years. So nephrectomy would be a better
last
option.
2 minutes left, sir.
Okay. Now I'll put it. Yeah. Can you
sir,
can you give
we'll
me the
take 5 minutes, sir. We'll take 5 minutes because lost time in between.
Yeah. See. Yeah. Anyway, thank you very much, sir. Chairman, sir, thank you very much. Sitaram, can you tell us the indications for endoscopic management?
Sir, endoscopic management is low-grade VUR, preferably symptomatic. Low-grade VUR is indication for endoscopic management.
Which grades? You have to be precise. Grade 2, grade 3, grade 4.
Grade 2.
Okay.
Grade 1, grade
2, grade 3, and grade 4. Your continuous antibiotic therapy should have failed. CAP should have failed, and there should be a surgical indication. In such children, you can offer. Now, can you just tell us what are the agents used in endoscopic management?
Sir,
now, I don't want the brand names. Sir, what are the
hydrochloric acid, sir. Hydrochloric acid, collagen,
you are right. Yeah.
PTFE and
PTFE, yes.
Fat is also used, sir.
fat has been used in Manipal. I think Dr. Chawla's Professor Chawla Center has used fat. But what happens is at the end of the procedure, you will find all the fat in the urosac. 1 hour later, you will find most of it is in the urosac. It has not worked in, at least during my time. So PTFE was the first one, in the sting procedure it was used. Then you have got the collagen, and then you have got Teflon, you've got autologous chondrocytes, and DexHA is the one which is, I think, currently used. Whatever it is, you will be asked about double hit, what is hit, all those things. I'm sure you are aware of it. The hydrodistension implantation, technique. Now, can you name a few open surgical procedures which are eponymously credited with?
Sir, one is cross-Cohen reimplantation, Palatano Ledbetter,
Cohen's yeah.
Yes, sir. Glenn Anderson and
Lish Grigor.
Very well done. Yeah, very well done. Which is the best, most physiological?
Cross-Cohen's cross-trigonal procedure, sir.
What is the problem with cross-trigonal reimplantation, Cohen's?
Exactly, identifying the trigone in children and placing it, creating the tunnel, sir. Like.
No, the trouble with Cohen's is, if it is done, if you can see me, if it is done like this, sometimes you can create a L. There can be a sharp angulation, and that leads to a lot of problems. Okay, a combined technique, intravesical, extravesical, Ledbetter quality works very well. What should be the ratio? Length of the
5:1.
Yeah, 5:1. Now, before we wind up, can you tell me the natural defense mechanisms which prevent vesicoureteral reflux? Physiology.
It is the ureteric peristalsis, flow of the urine.
Yeah,
Hello?
pacemaking activity. Yeah, pacemaking activity. Yeah. Okay,
Flow
one way ureteric peristaltic activity. Okay, then.
Unidirectional flow of the urine.
Agreed. Next one.
Next one is, sir, it is the length. It is the length in intramural length, obliquity,
okay,
posterior, lateral,
length,
and obliquity,
and the submucosal length. And most important thing is the intravesical pressure, the bladder compliance.
Yes, sir.
Anyway, I have interrupted
the bladder,
because it was, rather troublesome because we could not navigate through the slides and we were racing against time. If you ask me, I will only wind up by saying that the initial evaluation should be accurately done. A pediatric case is presented differently. In the initial evaluation, height, weight, blood pressure using an appropriate cuff, that is to be mentioned. And the baseline creatinine is essential. And then you have the classical approaches, whether you want to do a top-down approach or VCUG first. And there are 3 scenarios where you are required to screen whenever a sibling has a VOR, or when parent has a VOR, or an antenatally detected hydronephrosis, where you think it could be a VOR. Thank you very much.
Thank you, sir.
Thank you, sir.
Thank you, sir.
All of you did well. Yeah, thank you very much.
Yes, thank you, sir.
Over to Professor Chawla. Yeah.
Thank you, sir. With this, we wind up our session 4.
Sir, one minute.
Yes.
And is there any question from Nikhil Sitaraman to Dr. Lakshman? If there's no question, thank you, sir. Thank you, Dr. Lakshman. Thank you very much, sir. Thank you.
Thank you, sir. For the next session, I would like to invite Dr. Preetham, who will carry the next session forward. Dr. Preetham.
Hello. Am I audible?
Yes.
Welcome to session 5. I am Dr. Preetham. There will be 2 cases in this session. First is RCC and second is metastatic CA prostate. First case will be presented by Dr. Milab and it will be moderated by Dr. Hemant Goyal. The participating candidates are Sumedhankar Sagar, Dr. Sumit Agrawal, Dr. Sunil Kumar and Dr. Suraj Reddy.
I think it will be moderated by Dr. Swarendu Mandal.
Yes, sir. Dr. Somendra. Sorry.
Hello.
Yeah.
Hello.
There are two candidates in this program, in this session. One is Dr. Sumit and other is Dr. S. Mundra.
Hello.
Yes, sir.
Am I audible to you?
Yes, sir. Yes, sir.
Myself, Dr. Subindranath Mandal. I'm HOD, Department of Urology, Calcutta National Medical College. Can I know who are the residents present here?
Sir, I am there, Suraj, sir.
Suraj.
Yes, sir.
And or others?
I am Sumit.
Dr. Sumit, Dr. Sunil, and Dr. Suraj.
Okay. Good afternoon to everybody. Now we can start the case. So most probably the slides will be running from your side.
Yes, sir. Am I audible, sir?
Yeah, audible.
52 years old female housewife presented with hematuria since 4 months and right flank pain since 3 months, sir.
Okay, so it's a female patient, 52 years. Patient started with hematuria last 4 months and now develops flank pain for last 3 months. Okay, who is facing? Who is talking?
Yes, sir.
Suraj. Yes, Suraj. Sumit.
Yes, sir.
Okay.
Sir, it is presented by another person, sir.
Okay. Now, who is facing the case? Who will answer?
Sumit, after you point towards anyone, we can answer accordingly.
Sumit.
Yes, sir.
Sumit, now you have read the presentation, is the history. This is the chief complaint. Okay.
Yes,
I
sir.
want to at this juncture, I don't want ask you what are the DD. I go further. Now, give us the history of present illness.
Yes.
Next.
Hematuria was intermittent, gross, painless, occasionally associated with passage of vermiform clots, and pain was present in the right flank, which was diffuse in nature, intermittent, and relieved on taking medication.
So, Sumit, you got the history. It's a female patient, 52 years, with gross hematuria, intermittent, and there is pain in the flank. So, what comes to your mind? What are the DD in these cases?
Now, this gross hematuria along with vermiform clots gave a diagnosis that bleeding is from the upper tract.
Yes.
As they pass through the ureter, they will become vermiform. And this, along with this, as the pain is occurring in the right flank, so it is saying that as the vermiform clots are coming, it could be a clot colic from the upper tract. So
okay.
It is no doubt upper tract pathology, which is leading to hematuria, causing clot colic.
Want to know what could be the causes of this bleeding?
It could be a renal mass.
Number one.
It could be RCC or upper tract PCC, or
upper tract
ureteric pathology.
Why RCC comes to your mind first?
Because
considering the age group, sir, 56-year-old female.
52 years female patient, which is most common in this age group? Hematuria, pain.
RCC is more common.
Is it the RCC? Okay, proceed. I think you start with benign lesion first, which is most common. RCC is more common or most common?
Most common would be renal stone.
Yes, then start with the most common disease.
The most common would, yes, sir.
To start with most common disease. It could be renal stone disease. Okay.
Renal stone. Yes.
Next.
Renal mass.
Renal mass.
In that renal mass, it could be an RCC or a TCC, and then a ureteric mass.
Which case? RCC or TCC? Hematuria is common in which cases?
To start with, it will be
TCC.
TCC.
is DCC. DCC is most commonly associated with hematuria. Okay. RCC.
Yes,
Anything comes to your mind other than TCC, RCC, and stone disease?
With visible hematuria, angiomyolipoma also can be present, sir. Benign lesion.
Because this
Renal
is a female.
tumor.
Angiomyolipoma is more common in case of female patient. Okay, it's a female
Yes, sir.
patient. It could be. It could be. Why there will be pain in AML?
Yeah, intra-lesional hemorrhage, sir. Recent
That's
hemorrhage which is stretching.
Okay. Right. Next, anything comes to your mind? Any other benign lesions? Could it be a hydronephrosis, pre-existing hydronephrosis later on develop certain pain, hematuria? Could it be a hydronephrosis due to some reason?
Tuberculosis? Upper tract
Yes,
tuberculosis.
it could be. Okay.
It could be an upper tract tuberculosis, yes.
Keeping in mind 4 or 5 DD.
அந்த book எடுத்துட்டு வா.
What?
Yes, sir.
தம்பி அந்த book எடுத்துட்டு வாடா.
Who is talking?
கொண்டா எல்லா book எடுத்துட்டு வா Clara.
Some other person.
There is some noise from the other side. Okay, background noise. Okay, ignore it.
Yes, sir.
Ignore it. Next comes so what you want to ask this patient? What more history you want? Keeping in mind this your DDs.
Renal cyst which could have caused a hemorrhage into it also, sir.
Yes, that part we have crossed. Yes, there is another.
Yes, sir.
It could be a multicystic disease. Okay, renal cyst,
yes,
adenonephrosis could be. So that part we have already crossed. Next, what you want to ask the patient to get your diagnosis? What more history you know?
Is there any history of weight loss?
Weight loss, anything? Then proceed. You just ask us.
History of weight loss, bone pain, and
come with the your first diagnosis was what? Then come with this in the common things. But usually ask first. Don't jump.
any history of surgery in the past? Any history of renal stone?
History of lithuria, sir, to rule out.
Just one will talk and talk
Any history of pulmonary TB? Pulmonary TB or family history of any malignancy in the past, family history of tuberculosis.
You must have another provisional diagnosis, that is genitourinary tuberculosis.
Yes, sir.
Genitourinary tuberculosis is very much common in our country. So another DD was genitourinary tuberculosis. If that is in your DD, so you have to ask for past history of pulmonary cox. Okay,
Yes, sir.
that is what you are asking now. Okay. Go forward.
Then.
So you ask for stone disease, you ask for weight loss, you ask for pulmonary history, past history of pulmonary cox. Anything?
Jaundice, stopper syndrome. We are ruling on
Why
stopper
you are
syndrome.
thinking of jaundice only? Now,
They
one
can
thing
be
now.
metastasis or they can be a stopper syndrome.
Just listen to me. Listen to me. Don't ask haphazardly. Okay. You have the history. What is the history? It is the pain and hematuria. You already know from the history that it is there from the upper tract. There is some pathology in the upper tract. Okay.
Yes.
So your next questions, your direct question, you will be accordingly. If it is a stone disease, so ask for stone disease. What you ask? If there is history of vomiting, lithuria, passage of past history of stone disease or not. Okay. If you are thinking of malignancy, okay, RCC or TCC you have already told us. So if you are thinking of malignancy, then other questions like you have already asked whether there is weight loss or loss of appetite or not. And there is second metastatic features. You must have the metastatic features. What you are asking is the jaundice or like that. That is the metastatic features. So ask systematically, what are the metastatic features of a renal mass?
Sir, bone pain, cough.
It is already written there in the in your screen.
Yes.
Yes, sir. Bone pain
Lung.
and pulmonary complications.
What is the most common site of metastasis? Most
Lungs.
common
Lungs,
site
sir.
Lungs.
is the
Lungs.
lungs. So ask lungs related questions. What are that? History of cough, sleeplessness. Okay.
Oh.
Ask accordingly. And then bone pain, you have asked bone pains. There may be liver metastasis, so there could be jaundice also. Anything more you want to know? Anything?
Hemopsis, sir.
Next slide, please. Next slide, please. Next slide, please.
Yes, sir.
Hemopsis.
Past history, she's a known case of diabetes and hypertension on medications. No any significant drug history or family history.
What drug history you want to know? Any particular drug history? Patient with hematuria. Always ask some questions. You must have
Cyclophosphamide.
cyclophosphamide. Why cyclophosphamide comes to your mind?
Sir, hemorrhagic cystitis.
Okay, good. Anything more other than cyclophosphamide?
ATT, rifampin. Other drugs which cause red color urine, you should ask the history of that.
Okay. What are the drugs?
The clots would not be there with those. It could be rifampicin.
What are the drugs that causes red color?
Pyridoxine.
Yes, pyridoxine or
Rifampicin and then phenolphthalein.
Acrolein.
want to ask about the blood thinners or antiplatelet agents?
Yes, antiplatelets.
You must. Okay.
But
Yeah, you must ask about that. Okay.
Yes.
There is so much history. Okay, drug history is normal. There is no such history. And regarding family history, what family history do you want in these cases?
History of renal mass in families.
Yes, in cases of renal mass is one of your diagnosis in the yes. So, what family history you want to know?
Family history of tuberculosis, family history of any other renal mass in the family, and also about ruling out any colonic cancers, because PCC can be associated with Lynch syndrome.
Yes.
So HNPCC. So
RCC sometimes it works in the family. There are certain familial syndrome. Okay. Can I ask you just just tell me what are the familial RCC?
Papillary familial RCCs and VHL syndrome.
What is that called? Papillary RCC? Hereditary papillary
Hereditary
RCC.
papillary RCC.
Okay. Other than that, most common?
VHL syndrome.
VHL syndrome.
Yes, VHL. That comes first. VHL. Okay. VHL,
Yes.
then hereditary papillary. Other than that?
Succinate dehydrogenase deficiency.
What?
Familial papillary.
VHL.
Another is the HL. HL, hereditary leiomyomatosis RCC. Okay, there are so many familial RCCs are there, but these three you must remember. Okay, there may be BHD. Okay, you are talking about BHD. There may be others also, but these three or four you must remember during your they will ask you in your exam. So there is no such family history of familial cancer. Okay, so you have got the history. Now you want to do physical examination. Okay, so next slide, please.
Patient is conscious, cooperative, and well-oriented to time, place, and person. Average build, performance status is good. Vitally, she is stable. Bilateral pedal edema was present, and there was no pallor, icterus, cyanosis, clubbing, or lymphadenopathy noted. For abdomen, wake mass was palpable of approximately 6 by 5 centimeters in the right hypochondrium region, 3 centimeters below the costal margin, firm and non-tender. No any prominent veins was visible over the abdomen, while rest of the systemic examination was normal.
So this is the physical examination. So physical examination, what you got? What are the positive things you got?
Bilateral
mass.
pedal edema, sir, and a large
One
mass, which is
large
palpable.
one positive things. Another?
Large abdominal renal mass.
Palpable renal
Abdominal
mass.
Yeah.
It is a palpable mass. There is a
Palpable, yes.
palpable mass on the right hypochondrium, 3
Yes.
centimeter below the costal margin. Okay, these are two positive findings along with your history, hematuria and flank pain. So what are your DDs now? Can you exclude all the your DDs, or you still stick to all the DDs?
No, sir. Renal mass would be the first thing in this.
So renal mass could be RCC, could be
TCC, renal
TCC.
clearance.
More
Other
chances of again, because this mass is along with pedal edema. So first would be renal mass, that is RCC, that is going to the IVC with a thrombosis, basically with an IVC thrombus.
Okay. So because of this presence of bilateral edema, you are thinking of that there could be thrombus, RCC with thrombus, that gives rise to these pressure effects. Okay. So now your diagnosis comes to the renal tumor, could be RCC or could be TCC. Okay. So next, to prove your diagnosis, next what you want, what you will do?
As an extension, we would like to do an ultrasound bedside. I mean, to complete the examination. Sir.
Other than ultrasound, only ultrasound you want to know?
Sir, along with that, routine investigations I would like to send, especially RFT, because I'm looking forward for a case of RCC, so I would like to get a CECT done. So before that, I would like to get the renal function test done. Sir. So routine investigations, including the complete blood picture and the RFT, I'll get it done.
Better till basic investigations, basic laboratory investigation. Okay, don't
Creatinine followed by hemoglobin, creatinine, ALP, LFT, followed by CT scan.
Other than renal function, just talk one. Other than renal function test, what other test you want to do?
So calcium level.
What level? Potassium.
Serum calcium. Calcium.
Okay, good. Serum calcium level. Okay. Then
liver function test to see alkaline phosphatase levels.
Liver function. Okay. Show him the results. Next slide, please. So this is the urine microscope.
Yeah.
Okay, just back to urine. Okay. What you got here? Only positive findings is numerous RBC. Okay. Next lab test. To this, you got blood glucose level, your renal function test, then your electrolytes, serum calcium, serum potassium. Anything wrong here?
Calcium and hydroxide.
Fine, everything is
almost
fine.
within normal.
Within
what? They are almost normal range. Renal function is within normal range. Electrolytes are within normal range. Serum calcium you are talking about. Serum calcium is also within the normal range. So next is the hemoglobin, platelet count, and total count. Is there anything wrong here?
TLC is decreased.
Huh?
TLC is low.
3,400.
Oh, yes.
Yes, slightly low. Okay. And hemoglobin?
9.5. That is also slightly low. Less than 10 is a.
That is mild anemia there.
Mild anemia.
Okay. Other than that, Baki platelet counts is within the normal limit. Okay. So next, you want to see the ultrasonography, na? Show him the ultrasonography report. Ultrasonography report.
Yes, sir. These are the ultrasound pictures, sir.
So these are the ultrasound pictures. Can you read it from the left side? They are showing the kidney and the right kidney and the
Sir, on the right kidney, there is a hypoechoic lesion noted, and the color Doppler shows hypervascularity is present, sir, in the lesion.
Okay, hypervascularity is present in the mass. Okay.
Yes, sir. So suggestive of a malignant lesion or a neoplastic lesion.
Want to know the report of the ultrasonography? Show him the report.
The right kidney was normal in size but bulky with an ill-defined heterogeneous lesion of size 7.2 by 4 centimeters in the upper and the mid pole, showing internal vascularity extending along the renal vein and IVC, queried tumor thrombus. The left kidney was normal and the bladder was also normal.
So there is a mass in the right kidney. Okay, it is heterogeneous, ill-defined, and there is increased internal vascularity, and they are suspecting something in the renal vein. Left kidney is normal.
10 minutes is left, sir.
What?
10 minutes is left, sir.
10 minutes. Okay, next. So with this report, now what you want to do? How will you proceed?
Do a CT, abdomen and chest.
What CT?
CT, chest and abdomen.
Multiphasic CT, sir. Multiphasic CT with CT urography.
Term is multiphagic CT. Okay. Okay. Do you have multiphagic CT? Show him.
Yes, sir. Can you see the images, sir?
No, can't see. Yes, sir. So the axial, first the axial films, not the coronal. First, show him the axial films.
Yes, sir. These are the axial cuts.
Cross section. Yeah, these are the places. So all the films are after giving contrast. Okay. So first I want to know what you will see when you are suspecting a renal mass. You already got that. You have got a renal mass from the ultrasonography report. So what are the things you want to see in a multiphagic CT? Just tell me that, and then you will tell me what you are finding here.
Sir, first we want to see whether contrast uptake is present or not and how much increase in contrast enhancement. If this is a renal mass or sometimes angiomyolipoma may also present, which can be differentiated on CT. Then sir, we will define the staging of the tumor, what is the size of the tumor, what is the location of the tumor, its relation to the adjacent structures, if any lymph nodes are present or not, and what is, if any thrombus is present, what is the extension of the thrombus.
Let me tell you, I can't hear you properly actually. So, can you hear me? Can you
Yes,
hear
sir.
me? Okay. So when you see a multiphagic CT or other form of CT scan, the things you want to know first see the normal kidney. Okay, whether it is functioning or not, in normal size, it is functioning or not, exclude. Okay, that part here you see the left kidney is normally functioning. Okay, then come to the tumor, the side of the where the tumor is there. First you see the size of the tumor, whether it is heterogeneous or homogeneous, whether it is enhancing or not, if it is enhancing and how much is enhancing. So how much enhancement is a typical in cases of malignancy? How much
More than
enhancement you
plus
40 Hounsfield.
15.
more than
15.
15.
More than 15, 1-5. Okay, yes,
Yes,
more
sir.
than whenever there is a you take it as a case of malignant, you are dealing with a malignant tumor. Okay, so heterogeneous enhancement, how much enhancement is there? Okay, then comes the adjoining structures, whether this tumor involves the other adjoining structures, whether the tumor fat plane is present between the liver on the right side, on the left side, there is spleen and other organs. So you must note that fat planes also. Then comes your next part, lymph nodes. You have to see the lymph nodes, lymph node address, okay, because of otherwise how can you stage the disease? So where you will look for the lymph nodes?
Perihilar region.
Perihilar,
Okay,
precable, paracable, and interaortocable.
Around the great vessels. Okay, around the great vessels and in the perihilar, you have to see that there. Then next comes Venas.
The next liver, any
Involvement of
metastasis.
So because
Metastasis.
special predilection for the venous involvement. So how many of cases there is venous involvement in RCC? How many cases there is in venous involvement?
20 to 30%.
Almost 10%.
7%, 7 to
This is
14%.
venous involvement. Okay, some form of maybe in the renal vein or the IVC. Okay, so you have to note whether the venous is involved or not. That part is very much important. It will increase the staging. Okay, what you see here? Now show him the coronal films. The picture screen, coronal films.
Yes, sir.
Yeah, IVC invasion.
Yeah. Now see, these are beautiful films. What do you see here?
The renal mass,
an
which
IVC.
is, and the tumor is continuing in the IVC.
Yes, this tumor is continuous within the IBC. Okay, this is a beautiful picture showing everything. Okay, it is bad for the patient, but for the discussion is good. So what you see, the same. Another thing important, the same enhancement, same enhancement in the tumor and the mass present within the IVC. So can you assume from this what type of thrombus it is? There are two types of thrombus. One is the blunt thrombus, another is called tumor thrombus. So what type of thrombus it is?
Tumor. The 5 minutes is left, sir.
How will differentiate tumor thrombus from blunt thrombus?
It will not enhance. Tumor thrombus will enhance and blunt will not enhance.
It will enhance this because these tumors are usually arterialized. They are arterial supply. They have got supply, so that therefore they are enhanced. So here you got the enhanced tumor tissue. Okay. So what are the levels? Can you tell us what are the different levels of IBC involvement?
It can be graded by Mayo's classification, sir, into 5 grades, where grade 0 is involvement of the renal vein, and grade 1 will be involvement of the IVC, but less than 2 centimeters into the IVC. Grade 2 would be like more than 2 centimeters of the IVC, and grade 3 would be above the level of the inferior margin of the liver. Grade 4 would be above the level of diaphragm.
So can you tell us what type of what level it is?
Sir, this is extending just above the level of the diaphragm, sir. So it is grade 4, sir.
Just above the level of the diaphragm.
Or at the level of the diaphragm, or just above the level of diaphragm.
Can you see that? Hello, it is gone. Can you bring back the picture? Hello. Bring back the picture, please.
Yes, we are doing.
Because you have to read CT scan. You have to read CT scan. You have to read ultrasonography and MRI in the exam. Okay. So you must read it properly. If there is any problem, you cannot decide whether it is, then you may ask the reports. So can you show us the CT scan report? What was the CT scan report?
Just a second, sir. We will display it, sir. Just one moment, sir. So you can see, sir?
Yeah. I can. So you read out the report?
Yes, sir. I'll read it out, sir. A heterogeneously enhancing partially exophytic mass lesion of size 7.2 centimeters into 4.5 with hypodense areas, likely cystic or necrotic, within is seen arising from the upper pole and interpolar region of right kidney. The lesion is hyper enhancing in the arterial phase. and the tumor is hyperensizing and noted extending into the right renal vein and into the infradiaphragmatic portion of IVC for a length of 10.75 centimeters, suggestive of a tumor thrombosis. So the tumor size is 7.2 centimeters, sir.
How much time?
2 minutes.
Only 2 minutes. Okay. So this is a level 3. Okay. This is the level 3 thrombus. Okay. So now we have you have the renal tube. Now got the total information. You have got a renal mass. Okay. Most probably it is RCC with tumor thrombus level 3. Okay. So what will you do now? What will you do now? How will you plan your management?
So we will first we'll explain the condition to the patient and its prognosis.
Yes, yes.
That what is the result? We'll also do, although we do not have any metastasis, liver is fine. Liver is fine, bone looks fine. So it is a type of T3B, T3C. N lymph node metastasis is also not very prominent, but T3C, N0, M0.
T3C? Is it T3C? What is C and what is B?
T3B, T3B.
Yes, it is T3B. It is below sub. It is below is T3. So what is the stage now?
T3B, N0, M0.
T3B, N0, M0. Okay. So it is a locally advanced tumor.
Yes, it is a locally advanced tumor. So we will have to go.
Sir, time is up, sir.
And
just
one.
Also
yes. Sir, you go ahead and try to wind it up in next 2 to 3 minutes.
So in this case, we'll also have to look that this IVC invasion does not seem to be there. The wall invasion does not seem to be there. So it is just a mass. So we can do a radical nephrectomy. We can plan for a laparoscopic or open radical nephrectomy. Open would be most preferred in this case because it is a large tumor. It would be, and vascular handling would be easier in open cases.
This is a level 3 tumor. You will go for laparoscopic?
No, sir. Only open can be
Open,
so why do I about laparoscopic?
because liver mobilization would be required, sir. Even after ligating the renal artery, we cannot expect the tumor thrombus to shrink so much.
Not possible. Up to level 2, it is possible in some sense. Up to level 2, not level 3. You have to mobilize the liver. Otherwise, how can you shoot the retrohepatic portion of the IBC? Okay. So where you just ignore the nephrectomy part. You just tell me what you will do in cases of IBC thrombectomy, where you will put the clamps and how and what sequence. Where you will put the clamps and at what sequence.
Dr. Sumendra, please wind up it now. Otherwise, we will be late in other. We have 2 minutes.
Just 1 minute, and then I will wind up.
In case of only renal vein thrombus, Satinsky clamp can be used, sir, and that can be removed. And in case of level 1 thrombus, also a Satinsky.
Yes, level 3.
Only in level 3. Sir.
Opposite renal vessel.
First is the lower down IVC, then in the opposite renal vein, and then after mobilization of the liver, if we can clamp it just above the liver and below the renal, hepatic veins, we can do that. If we have to clamp it above the level of hepatic veins, then we have to follow the Pringles maneuver and clamp it, sir.
What is Pringles maneuver?
Pringles maneuver is a compression of the portal vein, hepatic artery at the level of
hepatis. At the level of porta hepatis. What is the time limit you can compress?
20 to 25 minutes, sir.
Yes, within 30 minutes you have to complete these things. Okay. Thank you. Thank you. Everybody has done well. They have read well, I know. So thank you, everybody. I want to thank Dr. Chawla for inviting me in this session. So I can conclude this part also.
Thank you, sir. Thank you very much for nice presentation and nice discussion. Thank you. Thank you very much. Now we have to move on next presentation.
Thank you, sir. The next presentation is metastatic carcinoma of prostate, and it is prepared by Dr. Gagan, and it will be moderated by Dr. Hemant Goel. The participating candidates are Dr. Surjit Singh, Dr. Takir Mir, Dr. Vaibhav, and Dr. Udit. The time allotted is 35 minutes.
Yeah, hello.
Yes,
Am I
sir.
audible?
Yes, sir.
Yes, sir. I am Dr. Hemant Goel. I am head of department urology and renal transplantation, RML Hospital. Who are the residents along with us?
Sir, I'm Dr. Vaibhav Vishal. I'm from Calicut, Kerala.
Okay, and
Sir, this is Dr. Surjit from Trivandrum Medical College.
Dr. Surjit and Dr. Vaibhav. These two
Yes,
are with me. Okay, so we'll just rapidly go.
Myself, Dr. Udit.
So it's Dr. Vaibhav, Dr. Surjit, and
Hello, sir.
yeah,
Dr.
third one.
Udit from.
Okay, Dr. Udit. Okay. I can see you. Okay, so we'll directly go with the case, and we'll try to complete the examination, the history part, and basic investigations. Okay, so I think I'll start with Dr. Surjit, the history part,
Yes, sir.
and we'll go to Dr. Udip. No, I'll start with Dr. Vaibhav, the history part. The examination part will be done by Dr. Surjit, and then the investigation and treatment by Dr. Udip. So we'll just divide one third. Okay. So Dr.
Okay,
Vaibhav, so
yes,
I'll
sir.
just this is Mr. Mohan Lal, 70-year-old male, resident of Jaipur and retired government officer by occupation. He presented with chief complaints of decreased stream of urine for past 12 months. So his lower urinary tract symptoms, patient was relatively asymptomatic 12 months back when he develops decreased stream of urine. This was accompanied by hesitancy, straining, feeling of incomplete evacuation. Patient also complained of increased frequency of menstruation along with nocturia 14 times in a day and 6 times in a night. Okay. Otherwise, there was no other significant history. There is no history of AUR, burning micturition, hematuria, incontinence, fever, flank pain, leg swelling, any facial puffiness, backache, pelvic heaviness, loss of weight, loss of appetite, and chest pain, dyspnea. There were no any metastatic symptoms like jaundice, no other urethral intervention, no trauma, no sexually transmitted disease. The past history was absolutely normal except history of COPD. Also, the drug history was normal. He was appeared to be ECOG 1. The personal history, he was a smoker for 20 years, 1 pack daily. There's no other addiction, vegetarian by diet, and the family history was normal. There was some decreased erectile function since 4 to 5 years. So, Dr. Vaibhav, would you like to know anything more from the history?
Sir, any previous instrument? No, sir. Most of the history has been covered.
Can you summarize it shortly? Shortly.
It's a 70-year-old male who has got progressively increasing voiding and storage LUTs, and there is no significant any comorbid condition like diabetes, hypertension. There is no surgical history, and only significant is he has been a smoker for last 20 years, and he has a significant nocturia also.
Okay. So he has both storage and voiding LUTS, and he is smoker and COPD. That is the only positive history. Rest everything is normal. Okay.
Yes,
he is not on any medication. Okay. So what will be your differential diagnosis?
So based on his age and his symptoms, my first differential diagnosis will be prostatic enlargement with bladder outlet obstruction. My second differential diagnosis will be carcinoma of prostate. And third, because of his old age, I can consider neurogenic bladder as one of the last DDs.
Okay. So the first and second diagnosis are almost same. You can say prostatomegaly may be benign or malignant because of metastatic. A CA prostate will also cause obstruction when it is enlarged. So you can say that prostatomegaly, benign or malignant. Second is neurogenic bladder, very well said. In advanced age, it can be a possibility. One thing you missed, there can be a bladder stone. Okay, at this age, patient can present with some prostatomegaly with a vesical calculus. Okay. One thing is, what are the drug history, specific drug history you would like to take? Like in this age, what are the drugs which can affect bladder dynamics? Because that is very important.
Sir, any medication which is taken for psychiatric illness like delirium or seizures or Alzheimer's, Parkinson's.
So those are the drug for the neurological part. For any antidiabetic medications, any medication which he is taking for COPD can also affect the bladder contractility.
Yeah, and also like antihypertensive, like ACE inhibitors, calcium channel blockers, they can also cause bladder relaxation. So the drug history in elderly patient is very important. The drug may be the cause of low urinary tract symptoms than anything else. Also, he was a chronic smoker. So do you know about what are pack years? What do you mean by pack year? What is the
So
definition
number
of pack?
of cigarettes per day in 2 years.
It's not a cigarette, it's a pack per day in 2 years.
Per day in 2 years.
So it's a pack of 20 cigarettes. So it is if he is taking one pack per year for 20 years, so it will be 20 pack years.
20 pack years, yes.
So I think the differential diagnosis is clear. This part is clear. So we'll go with the physical examination. So I think Dr. Surjit. So physical examination, the patient is calm, conscious, cooperative, and well-oriented in time, place, and person. Moderately built and nourished, 70 kg weight. Blood pressure is vitals are normal. The systemic examination is within normal limit. Specific examination per abdomen, inspection, palpation, genitalia, everything was normal. Okay. The digital rectal examination, specifically on inspection, there were no hemorrhoids or skin type. Palpation, the anal tone was normal. There were no hemorrhoids, normal perianal sensation. Rectum was empty. The prostate, there was grade 4 prostatomegaly. It was non-tender. Median sulcus was obliterated. Getting above the prostate was not possible. Mucosa was not free. The prostate was non-tender and hard in consistency. It was non-nodular. It was smooth. Irregular but not nodule. No nodule were palpable, and there was no blood on returning fingers.
Yes.
So this was the DRE. You would so what is your differential diagnosis now?
Sir, now the first diagnosis will be carcinoma prostate, sir.
Okay. Any other possibility of hard prostate on DRE? Like I would like
So
to ask. Yeah.
Yes, sir. Granulomatous diseases can be there, and tuberculosis can be there with hard prostate, tuberculosis of the prostate.
Okay. So granulomatous and tuberculosis are one of the almost the same DD.
And
so if you have a hard nodular prostate on DRE in an elderly patient, you just take hard nodular prostate. So one is CA prostate, one is granulomatous prostatitis, maybe tuberculosis. Any other possibility?
Same, sir. Sarcoidosis, that is also kind of granulomatous disease.
And a benign prostatic
calcium.
large prostatomegaly can also be a nodular prostate. You can have nodular prostate in that
sir.
also. Okay.
Yes,
Any
sir.
prostatic calcification, prostatic calculus can present as a hard
Calcification calculus, yes, sir. Yes.
So these are some of the DD you should have in mind when there is a hard prostate on DRE. So Dr. Udip, are you there?
Yes, sir.
Dr. Udip, so what investigation, how would you like to investigate? First, with Dr. I think, Dr. Surjit.
Yes, sir.
So I'll like to ask you one more thing. How do you grade prostate on DRE?
Sir, there can be finger, by finger we can see the how much I can hold with the finger. If I can completely hold, then grade 1. If we just reach up to the this upper margin, then grade 2. But I can hold. But in 3, I will just reach there, and 4 I won't be able to upper part.
Any other
and then one lateral sulcus. Yes, sir. Lateral sulcus also we have to see, sir, whether it's obliterated or not.
So how is the grading? It's you said grade 1, 2, 3, 4, है ना? So grade 1, 2, 3, 4. What is the approximate size of the prostate? So you know of any grading system by name?
We don't know, sir.
Like there is a Law's modification of Romero et al. I think that is very commonly used. Law's modification of Romero et al. So that he has divided prostate in 4 grades, grade 1, 2, 3, 4. So 1 is approximately 20 gram prostate, 2 is then 40, then 60, then 80. They see at least 3 to 4 parameters. What is the surface of the prostate? Then how is the medial sulcus? How is the lateral sulcus? And how far you can reach above the prostate. So these 4 parameters you have to know. Okay. Yes. And each parameter has some grading. So the surface is flat in grade 1. Then it is rounded, bilobal in grade 2. Then it is rounded in grade 3 and 4. Median sulcus is palpable in grade 1. Grade 2 is well defined. 3 and 4 it is obliterated. So grade in 3 and 4, it will be obliterated in benign as well as malignant prostatomegaly. Now lateral sulcus it becomes deep. With prostatomegaly, benign prostatomegaly, the lateral sulcus become deep. So initially it is shallow, then it allow one finger, then two finger, then more than two fingers. Okay, and the fourth one you have described, that you can reach, you can palpate the entire prostate in grade 1. Grade 2 you can easily reach up to the top of the prostate. Grade 2 with difficulty. Grade 3 with extreme difficulty. Grade 4 you cannot reach at the top of the prostate. So this classification you should know very hard, because it is very commonly asked, the DRE classification for prostate grading. So next we'll come with investigation and grading. Dr. Udit, how will you investigate this patient?
I would like to investigate first with the urine routine microscopy, USG abdomen pelvis with full bladder PVR and UFR with PVR.
So you want an ultrasound, you want uroflowmetry, you want urine analysis.
Yes, sir.
Nothing else at this point of time?
And serum PSA also.
Okay. So you want these 4 investigation first. So I'll share the ultrasound. This is the ultrasound film, and this is the report. What would you like to see? Okay, you can see the film. Can you comment?
Sir, the kidney, left kidney appears normal, and on bladder there was PVR was appears to significant, and sir, right kidney also appears normal, and
Okay, so I'll just share the report with you for the lack of time. So he has gross prostatomegaly of 567 grams. Okay, and his pre-void is 84 cc, 85 cc, and post-void is 84 cc. Okay, and there is irregular outline parenchymal calcification is there, appearing to be CA prostate. So do you think the report is right? Does it look to be in retention?
so they sorry, maybe partially filled bladder.
So the thing is, he pre-void is, so we cannot comment on retention. If it was 200 cc, 300 cc, then and he is not able to void, then we can say there may be some retention, but it was incompletely filled bladder. So the only information we can get is a huge prostatomegaly, that is 567 grams. Second, you said uroflowmetry. So this is the uroflowmetry of the patient. So what information extra you got with this uroflowmetry? Dr. Udit?
Uroflowmetry, sir, yes, sir. Sir, the Qmax is 9.4 ml per second, so it is low. So I think it is a bladder outlet obstruction, and the pattern appears to be of obstructive pattern, and more probably it's because of prostate enlargement.
So when we say
And
about
that's
what
told,
you gather from uroflowmetry, you should know that he is not in retention, because the residual volume is 40 ml. His bladder capacity is good. The voided volume is 209 ml. So he does not have a small bladder capacity. That is the second information. His flow is okay, not very bad, not very good. He is not in retention, but he has some BPH type of flow, not exactly stricturous pattern. So you should know what you gather from uroflowmetry. This is a specific investigation. He has a okay bladder volume. He is not in retention. He is a average flow, poor but average flow, not very poor. Okay. So this is the information we gather from uroflowmetry. Okay. Next is a PSA. He has a PSA of more than 100 nanogram per ml, and urine routine and culture are normal. Okay. So now what? How would you like to further investigate? If I'm fast, then let me know.
sir, PS is more. No, sir. So PS is more than 100. So I would like to go for a biopsy, sir. 12 core USG trust guided biopsy or finger guided biopsy also.
Any role of pre-biopsy investigation like MRI or PET scan in your setup, or you specifically find it is useful?
Definitely, sir. This patient is having more than 100 PS, so I would grade him in the risk stratification. So once I get the biopsy report, then I will stratify this patient, and then I will plan for the further investigation.
So, Dr. Weber, you also would like to directly go ahead with biopsy or any investigation?
The only condition in which without biopsy we can go for hormonal treatment is an impending spinal compression or spinal fracture. And,
my question was, pre-biopsy you would like to have any investigation like MRI, multiparametric MRI or PET scan? In any this case or in any case of CA prostate, we are suspecting CA prostate?
no, sir. I would like to have a biopsy first. For
Only when we are doing a repeat biopsy, we go for a multiparametric MRI. Otherwise,
Yes.
directly go with the biopsy. So one more thing is creatinine is normal, 1 milligram per deciliter. Rest of the investigation are normal. So this was his biopsy. 12 core standard 12 core biopsy was done, and this is the report. Dr. Surjit, can you read the report?
Sir, final impression or that report is not that much visible, sir.
So it is a prostatic acinar adenocarcinoma.
Yes, sir. That
pattern.
I get it. Gleason's pattern 4+5, that is 9
By 10.
oblique 10, and positive in all 12 cores.
All 12 cores. You would like to have any other information?
So, sir, it is already advanced carcinoma with so much high grade. So,
Okay.
not much, sir, now.
And what are these Gleason grade groups? How do you classify in Gleason group?
Actually, Gleason ISUP grade 2014 is now what we are following. So their minimum is 6. That is ISUP grade 1, and 7, 3+4 is 2, and 4+3 is 3, and 4+4 or 5+3, 3+5, that is 8, means ISUP grade 4, and 9 and 10 is more the ISUP grade 5.
So you have an idea why was this classified in this? It was reclassified as Gleason group 1, 2, 3, 4.
Yes, sir. Yes, sir. Actually, when ISUP grade 4, this grade Gleason's group was 4, 5, then patient may think that he is in midway of that spectrum. But practically minimum is 6. So that is also very low grade. So patient will not think that he is in the higher side. So we have kept 6 as a lower limit in the ISUP grade.
So this was very important. The patient need to have a patient understand this better. Like 1 is a low risk and 5 is high risk. So that is why they were reclassified. So with this biopsy report, what next investigation, Dr. Weber, you would like to have?
Sir, since the patient had PSA of more than 100 and he is having Gleason's of 9 by 10, I would like to do a metastatic workup, which would include an chest X-ray and a bone scan.
Yeah, so this is a very important point because we are suspecting a metastatic CA prostate. So we'll directly go with a metastatic workup. If we were suspecting a localized CA prostate, we would have gone with a multiparametric MRI. Okay, so this is the bone scan. And I think any of you can just comment on the bone scan.
Sir, multiple higher uptake areas are seen on the long bones of the arm, and most probably the spine also. So it is a metastatic CA prostate, and it's low volume. The number of lesions are less than 4, so maybe a low volume metastatic burden.
It is primarily a skeletal metastasis, and they are on right clavicle, multiple dorsal lumbar vertebrae, right ilium, adjacent to sacroiliac joint, query bilateral acetabulum. Okay, so tell me which this nuclear agent we use in bone scan?
It's a technetium 99.
Technetium 99M. Any other we can use?
MDP.
MDP is there. And what are the instrument which is used for this bone scan? What are the specific instrument? So the gamma cameras are used, or you can use the PET scanners. These two can be used to capture the images. And one more thing I would like to ask: what is super scan? Dr. Surjit or Dr. Weber, anybody?
Sir, if so much mets are there, whole the contrast is being taken by mets only, and kidneys are not visualized.
So what is this known as?
Super scan, sir.
This sign is known as absent kidney sign. Okay, so this is specifically known as absent kidney sign, which is seen in super scan. So it is taken up by entire bones, and you don't have any contrast, any radiotracer in kidney. Okay. And one more thing I would like to ask you, when the patient is have undergone bone scan, how much time it takes to completely this is the nuclear agents. So how after how much time he is free of this radiation, like he can undergo a second nuclear imaging? Like he cannot go up bone scan and PET scan simultaneously. There has to be some interval. So what is that interval after bone scan? Minimum how much days after which he can go with next nuclear imaging? That you should know. That is 2 days. 2 days. So many 2 days it takes to eliminate entire the nuclear agent. So this is about bone scan. Then we have provided. They have provided with the MRI images also, but I think we will not discuss here. Chest X-ray is normal. Okay, there was no evidence of any metastasis. So general workup was okay. His cause of death of the father was natural. Ejection fraction was 55%. So now tell me, how would you go ahead with treatment? Any other investigation you would like to have?
Sir, liver function test, lefty.
That is normal. That is normal. Any other? Any workup you need to do?
Sir, calcium level.
I think that is sufficient. That is sufficient for. So he is a bony metastatic CA prostate with skeletal mets, predominantly skeletal mets. 5 to 6 location there is skeletal mets. Okay, and secondly he has moderate lower urinary tract symptoms. He is not in frank retention. So I think Dr. Udit or Dr. Surjit, any how would you go ahead with treatment? So
Sir, by charted criteria, it is 5 to 6 location in skeletal bone. So it is considered as a high volume disease.
Okay.
So by that definition, it will first choice should be chemotherapy in the form of docetaxel.
So the point is, it's charted is not only chemotherapy, it's ADT plus chemotherapy.
ADT plus, yes, definitely.
You should know how to administer them. Second is, when I ask for the plan is, you tell me what is the oligometastatic disease? How you classify low burden and high burden?
Oligometastasis, actually there is a different definition, sir. But usually considered is 5, meaning less than 5 mets is oligometastasis.
Okay. So there is no standard definition of oligometastatic, but generally 3 or less than 3, and there should be non-visceral. Any visceral metastasis is supposed to be high burden disease. Okay, so it is predominantly bony metastasis. Somewhere it is 3, somewhere it is 4. So 3 or less than 3 may be considered as low oligometastatic or low burden disease. Okay, so you were telling about the trials. So can you name some of the trials, common trials in metastatic CA prostate?
Yes, sir. This Stampede is there. Actually, Stampede is multi-arm, multi-phase. So it has covered a lot of things. And this Latitude trial is there, sir. And a lot of other trials like TAX trial for this chemotherapy,
So
COA 301 and 302. Yes, sir.
Okay. So what is the, you know the full form of this charted trial?
It's a chemotherapy in advanced, exactly I forgot, sir. It's chemotherapy in advanced prostate cancer, sir.
And hormonal abiraterone acetate randomized trial for extensive disease of CA prostate.
So it is chemohormonal versus androgen ablation. It is not abiraterone. It is chemohormonal versus androgen ablation in extensive disease. Okay. It is a randomized trial in extensive disease. So this charted was done only for metastatic CA prostate. Whereas Stampede, we have included the advanced disease, non-metastatic as well as metastatic. So that was the major difference. The arm C of Stampede was charted. It was similar to charted. The study design was similar, but only thing was included patient were both metastatic patient as well as advanced non-metastatic patient in Stampede. In charted, they were only metastatic patient. So that was the difference. So, so I think you should thoroughly know about the charted, the multi-phase Stampede trial. The arm C was similar to charted trial, and arm G was similar to this Latitude trial, in which they have used abiraterone versus plus abiraterone. I think this androgen ablation versus plus abiraterone. So tell me, what will you choose, a surgical castration or a medical castration in this patient? Dr. Vaibhav, I think you can answer.
Sir, I will give both the options to the patient, but since this patient has a a low flow rate also. So I will give an option of either a surgical castration or LHRS antagonist.
Okay.
I would prefer an antagonist over an agonist because of the low flow profile.
Two or three specific indication of LHRH antagonist. Besides, it can be used anywhere, but what are the 2 or 3 specific indication where you will prefer LHRH antagonist over an agonist?
Sir, in the patients who have impending spinal compression or spinal, in which we need an early control of, because the control of in antagonist is achieved within 3 days, while for agonist it takes at least 3 to 4 weeks.
So one is this indication. Any other indication?
Sir, 10 minutes is left, sir.
Okay, so if there is an impending urinary retention, okay, then also you want an early response. And second is there is a history of cardiac comorbidity. These 3 indication you will prefer LHRH antagonist in place of LHRH agonist. Okay, and there are some pros and cons about the surgical. So surgical castration is permanent. You have to explain the patient. You cannot offer him intermittent ADT later. It is permanent ADT. So that is one thing. Then there is a surgical complication can be there. So this is there, and the advantage is the lower cost. The lower cost is the advantage of surgical castration. That also we have to explain to the patient. Let the patient decide whether he has to undergo surgical castration or medical castration. Second thing is, if you are offering him chartered trial, okay, what will be the sequence of events? Like how will you offer the treatment? There are 2 treatments. One is castration, that is a surgical or medical, and second is chemotherapy. So what is the how will you offer the patient this? How will you provide the care? What will be first, and then when the chemotherapy will be started? So you have you give chemotherapy at your center by your own?
No, sir.
No, we refer to.
So you have to start a castration first. First, you have to do a medical or surgical castration, and chemotherapy has to be given within 3 months of castrate level, achievement of castrate level. So that is charter trial. And what is the difference between a normal chemotherapy in CRPC and in charter trial? What is the basic difference? You give chemotherapy docetaxel after the patient has become castrate resistant also, and here also charter trial. What is the basic difference in these 2? Is there any difference in these 2 chemotherapy? So I with lack of time, I'll just tell you. Charter trial, we always give 6 cycles of chemotherapy. That is standard. And when we give chemotherapy for CRPC, then it is not defined. You can give 9 to 12 cycles, even you can give 15 or 16 or 18 cycles as per tolerability of the patient. And since and if the PSA is declining, you can give as many cycles as possible. But in charted, you will give only 6 cycles. And second thing is, in CRPC, you give prednisolone along with it. Here it is optional. Only you have to give as pre-medication, rest it is optional. So these are 2 major differences between charted and in CRPC when you have to give this. Okay. So this was about the surgical and this. So how do you follow the patient? You have started with charted trial, and now how do you follow the patient? Like after 6 cycles, the PSA is 0.1. Okay. So how do you follow the patient? Any metastatic CA prostate, how do you follow?
Sir, we do serial monitoring of PSA and testosterone. The patient testosterone should be less than 50 nanogram per ml, and PSA should be, depending upon the therapy, should be at the nadir level. And any rise in PSA or any new metastasis which has developed, either a visceral metastasis or greater than 2 bony metastasis, then we classify him as CRPC.
So you are absolutely right. Only one thing I will tell you: you don't do routinely serum testosterone.
Yes.
Okay. So the serum testosterone you only do when there is a rising trend of PSA. Then you have to see whether the patient is compliant. He has developed castrate level or not. So you just follow with serum PSA. Okay. And when there is a rising trend, then you do testosterone, and whatever parameter you have said, you have to label him at castrate CRPC, metastatic hormone refractory prostate cancer. Okay. So in this case, the patient has you have given the patient docetaxel, and now 2 years later, his PSA is rising. Okay. So his PET scan is showing a progressive disease. So what treatment option you will offer him? So now it is a metastatic CRPC, metastatic HRPC.
Sir, metastatic HRPC with a prior docetaxel therapy, I will offer him enzalutamide as anti-androgen.
What are the options available?
Sir, firstly, as a bone prevention, I can give him zoledronic acid and denosumab. Other option is enzalutamide and cabazitaxel chemotherapy.
So options available are I'll just tell you again. There is a re-challenge docetaxel is possible. See, okay, if the first because this was charted trial, a proper chemotherapy you have not given, so a re-challenge docetaxel is possible here. Then a second line chemotherapy, cabazitaxel is possible. Then enzalutamide and abiraterone. All four you can give.
5 minutes is left, sir.
Sir,
okay.
one doubt, sir. Hello.
Yeah, you can
sir,
say.
if yeah, sir, if with starting we had that metastatic hormone sensitive prostate cancer. Now we have treated with docetaxel and it suppose mets has gone. So will it be considered as metastatic CRPC or non-metastatic CRPC?
Will be metastatic CRPC. You label the patient when you have diagnosed without any intervention. So a metastatic patient will be always metastatic. Okay.
Yes,
So that is there, and I think that cover most of the thing. Only thing is about the selection of abiraterone. In this patient, you will consider abiraterone as
yes, sir, we can give, sir.
So it is a bony metastasis. You can give abiraterone or docetaxel. There is no study which has compared abiraterone versus docetaxel. All have compared with androgen ablation. So abiraterone is effective. Even docetaxel is effective. Only thing is when you give abiraterone, the results of docetaxel are later on. If you give docetaxel, the results of docetaxel are not that good. So most people advocate if there is a high volume disease to give upfront docetaxel. Okay, and abiraterone and enzalutamide to be kept for a later date. I think we have covered most of the thing. Any doubt you want to ask? So you have done good. You have done good. Basic question all you have answered. Only thing I think you have to study this metastatic CA prostate treatment part in detail, and you should know. You should visit the chemotherapy department, onco department, how they administer the drugs. I think that is a very important part because in some of the institute like art, we are routinely giving all the drug by our own. So if I am the examiner, I will try to go into that part. Okay. So otherwise, you all three have done good. So all the best for your
And
exam.
sir, one more doubt, sir.
Yeah.
Sir, hello.
Yeah,
sir,
yeah,
this
yeah,
zoledronic acid will give means in metal CRPC in all patient or will decide any criteria or on all patient?
One thing is there for metastatic castrate sensitive prostate cancer, you can give zoledronic or denosumab. For CRPC, better is denosumab. Okay, and you have to give in all the patient calcium, vitamin D, and zoledronic. You have to give in all the patient. In sensitive hormone sensitive, you give as per your DEXA scan. Okay, but in CRPC, you have to give them routinely. You have to give monthly zoledronic acid, whereas in hormone sensitive, you have to give them yearly 5 gram, 5 milligram, or denosumab 60 milligram 6 monthly. So in hormone sensitive, you have to give only maintenance dose. Okay, but in hormone refractory, you have to give routinely monthly dose. That is the major difference. So you should know about these agents. They are entirely different schedule in sensitive part and resistant part. Okay,
Thank you, sir. Thank you
it's
very
clear.
much. Yes, sir. Thanks, sir. Very much.
Okay. Thank you.
Thank you.
Thank you, Dr. Anjal, for nice discussion. I think everybody have enjoyed it. Now we have to move on another talk that will given by Dr. Ganesh. He's from Calicut.
Sorry, good afternoon. Actually, I came as a replacement. Professor Suresh Bhatt from Kottayam was supposed to do this. I've been asked yesterday to cover this. Actually, some of the upper tract endourology instruments. Thank you for asking me to do this. Anyway, I think we'll go ahead with it. Okay. Anyway, we'll go ahead with this. Who is attending this? So he's going to attend the session.
We have two participants, sir, Dr. Rajkumar and Dr. Sitaram.
Okay, I think they can start this. What exactly you just describe this, and you know what exactly it is. What is the peculiarity of this equipment, instrument?
There's a 26 French nephroscopes are along with the outer sheath.
Okay. What is so peculiar about the eyepiece, that part of the equipment? Do you have different types of eyepiece?
Yes, sir.
And
Yes,
what
sir.
is that? Yes. What is, you have an offset, and this is the parallel one. What is the difference in the usefulness of this this parallel one? This is the parallel one, you know.
Yes, sir.
Okay. What is the advantage of this, or what? Where is it? What is the advantage? Actually, not much, but you must be knowing all this.
The angle of vision will be.
No, the angle of the vision is different. That is based on the make of the. Some of them are 6. Most of the Karl-Storz instruments are 6 degrees, and Wolf you have 12 degrees, 25 degrees. They're different because that is built in. That's the angle of vision is different. Here you have the advantage is that you can connect the camera well. Connecting the camera system is better with it will not interfere with your maneuvers. And once you connect the camera, the introduction of the other accessories also, it will not interfere the introduction of the accessories.
Yes, sir. Yes.
Okay. And what is the difference between this is actually a continuous irrigation nephroscope. And what is the difference between an integrated system and a continuous irrigation system? What is this? Why do you call this as a continuous irrigation system?
Sir, all nephroscopes, if used along with the sheath, they are continuous irrigation systems, sir.
So do you have all sheets for all the nephroscopes? That is what I am coming to.
No, sir. Like for suppose super mini PCR will have an integrated sheath which has suction along with that. So
not for super mini, even the other ones. See, all the actually the Wolf instruments, they are all integrated systems. I'll give you the example. See, this is an integrated system.
Integrated system. Yes.
Okay. Even the bigger ones from Wolf, you have an integrated system. So you don't have an outer sheath actually.
Yes, sir. Yes, sir.
You don't have an outer sheath. So
yes,
when you have an outer sheath which has got, so you can see the small openings. If you clearly look, you can see the small openings at the distal tip, just like your TU or resectoscope. So it can be so technically speaking, you can how do you can use it without an amplasty. Even though you don't use it, when it started, see actually you can do a PCNL without an amplasty. So when that's why it's called a continuous irrigation. When you can use it.
Okay. Yes.
Then how do you, what I have talked about the amplasty. What is the advantage of an amplasty when you use it along with an nephroscope?
So we can hold the tract. It keeps aligning our tract, and the fluid can come out. The irrigating fluid can come out through it.
You can make it a low pressure system basically. That is what you are talking about, the fluid, and the field is made clear.
Yes.
And then any other advantage?
The tamponade effect from bleeding from the
Okay,
tract.
so from the parenchyma, in the
Yeah.
parenchyma,
Yes, sir.
you can have a tamponade effect on the parenchyma. How do you know that the amplas has slipped out of the parenchyma, so collecting system into the parenchyma while doing the procedure? Is there any way which you can do? You can assess.
So can you repeat, sir? How?
While doing the procedure, how do you know that the amplas has slipped out, slightly slipped out from the collecting system into the parenchyma? Actually, you have given the answer. See, the bleeding will be much more.
Yes.
Fresh bleeding you will see. You may not. The field will become blood stained, and you will not. So once you during the procedure, if you see that, immediately you must think about this. And what is the type of optics here in a nephroscope? Optics. The system
Lens
of
rod system.
Yes, rod lens system. It is
Rod
a
lens system.
rod lens system. Okay. So it is not a semi-rigid instrument. It is actually a rigid instrument. It's not a semi-rigid.
Yes.
Then suppose you have what is the length of standard length of a nephroscope? Different makes have a small few 1 or 2 centimeters difference, but average somewhere around 19. You have
19 to 24 centimeters.
24 centimeters. Okay, but suppose you have a patient who is very obese, but what is the length of the amplas sheet? You cannot have anything beyond the amplas. What is the length of the amplas sheet?
Lens is 15, sir.
16, somewhere around 16 centimeters.
16.
Suppose you have an obese, really obese patient, how will you proceed? One is you will have to have a longer scope, like maybe 24, 25 centimeters. Down, you won't be able to do it with that 19 centimeter. And what about your amplas? You have a longer amplas actually. It is available 20, 30 centimeters, 20 centimeters. 20 centimeters is most of the time it is effective. Suppose you don't have that, what will you do? You can use if you have a telescopic dilator, you can use a largest of the telescopic dilator, and that is the Alkens dilator, and you can use it as a amplas instead of an amplas sheet if you don't have a longer one. Okay, dilatation. How actually what are the methods in which you can use that you can do the dilatation?
Sir, one is single step dilatation is there, and multi step dilatation is there. In single
step. What is that single step?
Single steps are we directly dilate with the bigger one single dilator. The big dilator.
Through
Yeah.
dilator. Okay.
Through dilator.
Any other way you can do a single step dilatation?
Balloon dilatation we can use.
Balloon dilatation. Okay. What is a pathway access sheet, PAS? Do you know something to do with the balloon dilatation? PAS, pathway access sheet. A balloon dilatation assembled along with an access sheet, so that you can put it over the guide wire. Once you dilate the balloon dilatation, after that you can take out, the access sheet will be retained there. You don't have to put another access sheet or an amplas sheet after that. That's the newer thing which is coming. can you use this instrument, this 26 French you have showed that continuous irrigation one, without the outer sheet, without the sheet?
Yes, sir, we can use.
What are the what are the difficulty actually?
Difficulty will be because of the irrigation will be.
Actually the inflow will not be see at the proximal part. So it will not actually go into the into the system.
Yes, sir.
That is one issue. You can do it in critical situations where you are negotiating some of inside the collecting system, some of the calyces. You may be using it, but routinely it is not possible because one thing is the irrigation will not go. Second is that you will not be able to align the instruments. Because unless you have the outer sheet to steady the your accessories, it is impossible. It is not. It is difficult. Technically, it is difficult. You have you may be able to do it because the emblast sheet may help, but still it is not possible. But in an integrated system, anyway, you don't have that. Anyway, what is this one?
This is also a nephroscope only, the parallel type nephroscope with 20.8 French nephroscope.
Okay, you have any name for this?
Mini Perk instrument.
Mini Perk, okay. You can call it as Mini Perk. Where is the difference? How will you classify? Anyway, there is no standard classification. What exactly? How do you?
Less than or equal to 22 French is considered as mini. So some consider as 20 French as mini.
20, 22. Okay, you can in that way you can include this also in the mini. But this is a Richard Wolf. It is called the Dresden model. What is the advantage actually here? Again, this is an integrated one. You could see that the thumb holder and things like that. So it is sturdy. You can hold it properly, and it is the working channel is bigger here. It will allow some 3.5 mm instruments and more sturdy. Maneuverability is much better here. This one of those. This is one of the mini Perk instruments. Okay. What about this? This is an offset eyepiece. Okay. This is used for a mini Perk. What else do you require along with this?
We need a sheath along with it, so like outer sheath of the instrument.
Okay. This is the outer sheath. This is the one which you are asking about. Okay. Okay. How you describe the outer sheath?
So that's
you have in the scope you have the offset eyepiece. There is a working channel there through which you can put and there is the inlet tube. Okay. For the scope.
Yes.
And the outer sheath, what exactly it is? Can you describe it? To have 2-3 openings.
So one is the working ports or working element. The other one is the inflow. The other one is the suction.
Working port is actually working port is not. It is not the working port actually. The one which is okay. This is the one. Okay.
Yes.
So you have an irrigation port in the channel.
Yes.
Okay. You have got an irrigation port actually, and an irrigation port also is there in the scope also. Okay. And you have this is where the scope goes in, and you have a suction port. You have you can see the small holes here. So once you goes to the irrigation, the fluid will come out through this outer sheath also. Okay, that will come out, and you have a suction port. So by doing, and you can see you break the faucet laser fiber, or even I think 2 mm and 2 mm, 3 mm fibers will go through this. Even 5 mm will go through this. So you can either use the laser or even small 5 mm graspers can be used. So once you break the stones, during the procedure, you can apply suction also here. So this, if the sheath is the flow is getting blocked, you can through this you can apply suction through this. This is for the suction. Actually, this is a suction port. You can remove the clots, because otherwise, now unlike the other the standard PCMs, you won't be able to apply suction through the amplas. So you have to do the suction. Here you have a suction port also.
Yes.
Now another. Okay. This is a describe this one.
Sir, ultra mini PCNLs are PCNLs that are from 7 to 10 French scope, sir. So this is a 7.5 French nephroscope, a 3 French telescope.
The amplas is up to 11 to 13 French. Actually, the amplas is even the ultra mini. You have the that also comes under the mini PCN, because the amplas is somewhere between 11 to 13 mm. So that is the actually dialed. How will you introduce this one? Actually, for this one, here this dilator also, this outer sheath also, there is an operator with a central port. And here also, you have an operator, the amplas sheath, which can be used as a dilator. And it has got an operator, which has got a central port. It can be guided through the guide wire and placed in the calyx. Okay. And you can introduce the nephroscope with the sheath. And this outer the nephroscope sheath has got 2 channels. What are they for? .5 sheath. It's got two channels. What are they meant for?
For introduction of laser fiber.
One is for the laser fiber. The other one is for the irrigation. So actually, through this, while you are doing this, it's you won't be able to remove the stone bits mechanically. So you break it with the laser, and you may be able to wash it out by irrigation. So you won't be using any instruments for removing this. And these 2 instruments, the 3 French telescope and the other one, this one, these are very flimsy things, flimsy instruments. It may be damaged very easily.
10 minutes is left, sir.
Yes. Tell me. Okay. These are instruments which can be which can get damaged very easily. Okay, this is you can see the different sizes. See up to 30 French, 30 French, from 30 to 20. Actually, it is the standard PCNL, and the mini, ultra mini, and the ultra mini PCNLs up to 11 to 13. And between that, less than 20, it is the mini PCNL. Okay, now coming to the ureteroscopes. Okay, you can see 2 ureteroscopes here.
Yes, sir.
These are both of these. There are about the eyepieces. There are 2 different types of. You can have a straight eyepiece and a offset eyepiece. What is the functional difference between these two, offset and the, which one is better here, offset or the straight? When you have a straight eyepiece, where do you have the working channel? The working channel is always offset. So you won't be able to pass a straight accessory with a straight eyepiece when you have a straight eyepiece. So that is the difficulty. So you always prefer a offset eyepiece if you are planning to do especially the litho class. When you are using only laser, it doesn't matter much. But you are planning to use both, then you always prefer a scope with a offset eyepiece. Okay. Now, what is the essential difference between these two? You look carefully. Forget about the size. Okay, what does the size denote? 4.5, 6.5, and 7.5. What does it denote?
That
So
means
the tip size is 6, and as we come back, it comes down to 6, 7.5 French.
It goes higher up. It goes proximally. The size increases. Okay. Okay then. And what is the optics here?
Marburg, that is Marburger type of eyepiece, offset like.
Okay, yeah.
Yes,
And what is the optics here in ureteroscope? Ureteroscope optics. Can you hear me?
Yes, sir. Yes, sir. We can hear you.
Yes, sir. Yes, sir.
Optics. It's a fiber optics actually. Do you have any other developments in the optics here in ureteroscope? Can you have digital ureteroscopes?
No idea, sir.
You can have a chip at the tip.
Okay, sir.
And what is the advantage when you have a chip at the tip? You don't require a camera. You can straight away connect it to the monitor.
Okay.
And you don't need a working. You can have a bigger, once you can get away without having a fiber optic system, so that you can have a bigger working channel.
Yes,
and
sir.
this is always much better when you have the system is with a flexi ureteroscope. See, once you have a instrument, the accessory passing through the working channel, the flexibility of the tip of a flexiscope is decreased. But when you have a bigger channel and a tip and this thing, a chip at the tip, the flexibility is much better. But what is the disadvantage actually of a chip? Actually, the smallest chip at the tip, that is you can have is, so far you can develop is 8 French. So it is difficult at times to have maneuver this in standard ureters sometimes, or in a flexi if it is there, it is difficult to maneuver some of the calyces sometimes. So sometimes these patients may require a freestyle. That is applicable for in the ureter, that is applicable for the rigid scope also. So
okay.
That is one problem. And now coming back to the these two, you look at the working ports here.
Yes.
Okay. You have an inlet, the inflow channel, the pillar, light pillar, and the working channel. Okay. How many working channels you can see here? Usually, how many working channels you have in a ureteroscope?
We have
Most of
working-
the models have one. Okay.
one.
Usually some depends on the size of the scope you have. Depending on the size, you have a 5 mm or a smaller one. Here, what do you see here?
There are two working channels, sir. One in irrigation and outflow channels, sir.
You have an irrigation outflow, and you have a straight working channel and an oblique working channel here. Can you see that?
Yes, sir.
Two working channels. Why do you need this, and what is the advantage, if at all there is an advantage?
We can to use guide wires, simultaneous guide wires like roll rain technique or right rolling technique, or to use a laser.
Why do you want to use a guide wire along with a stone breaking instrument or whatever?
So we can use the laser fiber. We can hold the stone with the one grasper or the basket, and with the another one we can send the laser fiber and break the stone if we are not able to withdraw the stone if it is stuck there. It's a big size. So
Okay,
two instruments.
Most important advantage is here you can have two instruments you can pass simultaneously, and one of the difficult situations where you face this, all other things can be dealt with in a single channel. But if you have a stone stuck in a basket, which cannot be pulled down, and the scope could not be brought down, how will you handle it actually? In such a situation, how are you going to handle it?
So we'll pass
basket, and you cannot take the stone down. You cannot disengage the stone. How would you handle it?
We'll break the stone there only, sir. In that position only.
The stone is, if you have a single channel instrument, you are stuck.
No, like this instrument, we have two channels, two working channels.
That is the most important advantage of a instrument with the two channels. You can hold it there, pass laser fiber through the other one. See, this can be done in when you have a 5 mm working channel. You can have both, but through a single channel. But it is technically cumbersome. It is difficult. It can get entangled with the other one. But if you have two working channels, you can have the basket in one, the other one you can have through the laser fiber. You can have it laser fiber, the other channel. You can always break it. Do you have any other options here? If suppose you don't have this two channel and other things, what are the other options available here? Straight away go and open, or do something else?
We can do PCNL, sir.
PCNL is another option. Will you offer ESWL?
ESWL can be offered, but
not with the scope inside. Not with the so that you will have to cut the distal end of the basket and remove the scope. Then you can give a ESWL.
Yes.
Otherwise, your scope is going to be damaged. Okay, what is the difficulty when you are doing a ureteroscopy for an upper ureteric stone?
One is the respiratory movement, sir.
But it is under control. Usually, it is under control. Why does why should the respiratory movement affect your ureteroscopy?
I mean, while fragmenting the scope, while fragmenting the stone, there will be difficulty because of the unguarded respiratory movements or accessing the proximal stone.
Accessing may not be difficult.
And stone can migrate upwards because of the
most important thing. Stone can migrate upwards. How will you avoid that upward migration of the stone?
So one is the tilting of the table, like reverse Tendelberg.
One is tilting the table. Then what else?
Then we can like break little bit, bring it down again, then we'll
Can you
break
give
again.
something
Then
else? Ask the anesthetist to give something.
Lasix, sir. Lasix can
Fluid,
help.
fluid and diuretic. Fluid and diuretic, that also may help. Any other way?
Basket, sir. And
Basket means the stone should be basketable. It has to come. It will have to come down again. The basket. See, you will have to have this type of equipment. In a standard uteroscopy, this may not be possible.
yes.
Any other? Any other?
Laser preferable more than a lithoclast.
Laser is preferable. Laser is preferable. If you have laser, yes, use the laser. Any other? Any other?
manually we can support the kidney.
Support the kidney. It may not work. Most of it usually it doesn't work. Any other equipment by which you can? Any other accessories by which you can prevent the migration?
Grasp.
Can you tell me a few of the accessories by which you can prevent the upward migration? Have you heard of N-trap? N-trap. Accordion.
Yes, sir. Yes.
Stone cone.
Yes.
All these things are accessories which can be passed through the working channel and kept above the stone. Actually, you will have to be able to pass another accessory up above the stone and open this. Open that so that it will prevent the upward migration. Okay. Suppose you are doing a uteroscopy and you find that the ureter is very, very tortuous and it is difficult to negotiate the tortuosity. But how can you proceed? Okay.
So one thing is we can do RGP and see the.
Okay. It will give you a landmark. Okay.
Yeah. Then we can use flexible guide wires.
All your guide wires are flexible.
Sir, time is up, sir.
Which one?
So time is up, sir.
Okay.
Using railroad technique
You
to make it.
can pass the guide wire through the tip of the scope and access it, or you can pass a second guide wire by the side of the one that may straighten this, or you can use the hydrodilatation. These are certain things, some of the things.
Thank you, Dr. Dinesh.
Thank
you very much.
Thank you very much.
For this well-planned discussion, the resident. Thank you very much.
Thank you, Dr. Dinesh. Dr. Rajiv is there? Yes, sir. Over to you, Dr. Rajiv.
Good afternoon. First of all, I would like to extend sincere thanks on behalf of USI and ISU to Professor Sher Singh Yadav, the Professor and Head of Urology, SMS Medical College, Jaipur, for being the convener of this program. Really, if it was not the COVID pandemic, we would have the physical mock examination at Department of Urology, Jaipur Medical College. But anyway, in the virtual format also, the whole entire gamut was covered. It was really interesting. We had made it into a 2-day program, and it has covered many of the aspects of the examination point of view. Even we had incorporated the instrument into 2 parts, upper tract and the lower tract this time. I would like again to thank on behalf of USI and ISU the faculties for this online examination. They had spared their valuable time on this weekend to be with us and to impart the training program. And all the faculties are examiners for the MCH or DNP or both. And we had selected them accordingly. And this time, the USI had the opportunity of holding 4 examinations, 1 physical mock examination and 3 online mock examinations and we have covered around 80 plus faculties. So the trainees have the opportunity to come across majority of the examiners across India. I hope you have been benefited immensely from this online examination, and I would request you to send to the central office your input on the online examinations and what more you want the USI ISU to modify or incorporate into the online examination, so that it will be very fruitful for you for appearing the MCH as well as the DNP examination. And beyond everything, I would like to thank Professor Arun Chawla, the co-chairman Indian School of Urology, for putting in a lot of efforts, because we have to shuffle across even in the last moments many things, and we have been deliberating each day, every day, in fact, how to fine-tune this event, and he had put in a lot of efforts to make this program. Thank you, Arun, on my personal behalf and on behalf of the Urological Society of India. And I thank once again the Professor S.S. Yadav, Department of Urology, SMS Medical College, Jaipur, the entire team of the faculties for this 2-day online examination, and the trainees as well. Thank you all once again. Over to you, Arun.
Now I request Dr. Yadav to propose a vote of thanks for this program. Over to you, sir, Dr. Yadav. And congratulations from my side also for the commendable effort you have yourself put and your postgraduates have put in to make this program a good learning exercise for the postgraduates. Over to you, sir.
Sir, I am very thankful to Dr. Anant Kumar and our energetic Secretary, Dr. Rajiv TP, and Dr. Rajiv Sood, and Dr. Chawla. Dr. Chawla put a lot of efforts for successful of this event. And I am also thankful to learned teachers, those who have spared their valuable time for this event. And nonetheless, the residents, those are participating in this event, and I hope they will definitely be benefited by this event, and it will help in their university examination getting prepared in a better way. I think it is a good efforts by USI and ISU to improve the knowledge, not only for the examination purpose, but otherwise also everybody is in more and more wiser by sharing the thoughts of other people and approach towards the patient and instrument. So I'm extending my thanks to my faculty, my residents, and USI, Dr. Chawla, Dr. Sood, Dr. Nanthua, and all the faculty. Thank you very much, sir. Thank you.
Thank you, Professor Yadav. Now I would like to thank our central office, Mr. Navneet Arora and Kiran Arora, who are the backbone behind the program. So it was very well arranged, very well organized, and you have seen them. There is not even one bit of problem during the airing of this program. So now they are very much experts in having a virtual Zoom meeting. So I, on behalf of USI and ASU, extend our sincere thanks to and appreciation to Mr. Navneet Arora and Kiran Arora. Thank you all once again.
Thank you, sir. Bye, sir. Thank you. Thank you, everybody. Thank you, sir. Thank you.